Dr. Swanlata will take care of the timing because we have back-to-back presentations. Without much ado, I take this opportunity to call the examiners, the internal examiners first. May I request Dr. Manisha and Dr. Gangadhar to come out to the dais and occupy the chairs. Along with us, we are very happy to have Dr. Santosh and Dr. Ravindra Prabhu with us. Thank you so much, sir. Thank you so much, Dr. Santosh. Thank you so much, Dr. Ravindra Prabhu, for having accepted to be the excellent examiners. This is going to be a day-long haul for us, but I'm sure you will enjoy and we'll all learn from you, and it will be bilateral learning. So without much ado, may I invite the first case. I think this is a long case that is going to be there, and this is being aired across. So I hope you are comfortable and also the student is comfortable. Over to you. Please.
Madam has to join. We'll start off. Morning, sir, Santosh. Good morning, Dr. Ravindra.
Good morning, everyone. Are we audible?
Yes,
Good morning.
you are audible, ma'am, but little soft.
Yeah, are we audible?
Yes, ma'am.
Yes, yes.
It's clear. Okay. Morning, good morning.
Good morning.
Yeah, that's right. Shall we start the case?
Yes, please go ahead.
Yeah, okay.
Sir, very good morning, sir. I'm Srinivas.
It's on.
Sir, am I audible, sir?
Yes, yes.
Yes.
Leave it. This will capture.
Sir, I'm Srinivas, sir. Today I'll be presenting a case. A 34-year-old male named Sheikh Gauss, an auto driver and painter by occupation from Vikarabad, came with a chief complaint of breathlessness since 45 days. Coming to history of present illness, I would like to date back my history to October 2019, when patient had been diagnosed with hypertension when he was evaluated for headache. Intermittent episodes of headache, which were not associated with photophobia. He was.
Don't face your back to the inside.
Yes.
Tippandi మీ chair. అంతా తిప్పండి మొత్తం తిప్పండి. So that you can face them. That is better. No, that's fine. No. So that you can also face the audience, not laptop or అంతే. That's fine.
So he was when he had episodes of headache, he was evaluated and found to have hypertension. However, he was not evaluated for hypertension. The etiology of hypertension, he was started on oral antihypertensives, which patient was not aware of. However, he was also non-compliant to the oral medications and stopped after 4 months as his symptoms subsided, and was also on not regular follow-up. Now, the patient has was apparently all right 45 days back when patient had noticed breathlessness, which was breathlessness subsided with. Breathlessness was not associated with chest pain, palpitations. Breathlessness was also not associated with pedal edema or facial puffiness or orthopnea, PND. And he denies history of fever or cough. He denies history of vomitings, abdominal pain, loose stools, nor joint pains, rash or ulcers. He also denies any history of decreased urine output, hematuria, dysuria, or frothing in urine or graveluria. No history suggestive of lower urinary tract symptoms such as urgency, hesitancy, or increased frequency of urine, or straining while passing urine, or poor stream of urine, or double voiding of urine. No history of nocturia, no history of yellowish discoloration of eyes. no history of polyuria, weakness and fatigue, and no history of involuntary weight loss or weight gain. Her patient complains of repeated episodes of headache, increasing in frequency over the last 2 months. Headache is a holocranial headache, not associated with photophobia or phonophobia, not associated with vomitings or nausea or reeling sensation. It is associated with blurring of vision, which lasts for half an hour to 1 hour. Patient had seeken medical attention for the above complaint at a hospital nearby, where he was not evaluated but treated with IM injection in the gluteus for SOB and suggested oral medications, which patient is not aware of. Patient symptoms subsided on the next day and he resumed back his work as an auto driver. 3 days later from this situation, patient had breathlessness associated with the PND attack. He had to get up from bed at 4 a.m. in the morning in view of breathlessness. Symptoms subsided with upright position. On the same day, he was evaluated at a hospital nearby. This time he was evaluated to have hypertension and bradycardia. Because of hypertension and bradycardia, patient was referred to a higher center with cardiologist. On the same day afternoon, he went to a hospital with the cardiologist care, and he was evaluated by the cardiologist on the same day and had been told that he had severe hypertension. And during evaluation, he had with 2D echo also, they have said that he had some issue with heart and he requires coronary angiogram. After controlling hypertension with both IV and oral for 3 days, patient underwent coronary angiogram on the 4th day of hospitalization through right radial artery. The procedure was uneventful. Patient was treated with 2 units of IV fluids post-procedure. And he left against the medical advice on next day with the oral medications in view of financial constraints, and has his symptoms subsided and has his symptoms improved from the day of admission. However, the cardiologist advised to stay for longer because the etiology of hypertension has not been known. 15 days later, patient had come to our hospital with a complaint of generalized weakness and SOB, class 2 to 3, not associated with chest pain, palpitations, orthopnea or PND or pedal edema. He denies history of frothing or dysuria. He denies history of hematuria, discoloration or rash over both lower limbs. He denies history of decreased urine output, even though he has not quantified, was saying that how much he is drinking, his urine output is much around the same. And he denies any history of abdominal pain, vomitings or loose stools. He was evaluated in the emergency department for the above complaint of generalized weakness and SOB, and he was referred to nephrology in view of elevated creatinine and accelerated hypertension. This is the present illness. Past history. Patient was, as I said earlier, patient was diagnosed to have hypertension in the year 2019. That is when patient age is around 30 years, 6 months. When he was treated with oral antihypertensives, however, patient is non-compliant. No history of diabetes mellitus, seizures, or severe or transient ischemic attacks. Family history: he was born out of non-consanguineous marriage, 4th in the order of birth among 6 children. In the family, father at the age of 50 years he had hypertension, and elder brother at the age of 45 years had hypertension. No family history of renal diseases or renal calculi. He is married 13 years back with a child of age 4 years. Occupational history: he is a painter since 2 years and auto driver by occupation since 10 years. Hospital course: during the course of hospital stay, patient was evaluated with routine biochemical and urine investigations and an ultrasound abdomen. And after looking at the investigations, patient was advised renal biopsy, which he underwent on the 3rd day of hospitalization. The procedure was uneventful and he received 3 injections on 3 consecutive days.
Can you summarize the?
Yes, sir. Yes, sir. Coming to summary, a 34-year-old male, an auto driver and painter by occupation, was diagnosed to have hypertension at the age of 30 years, not evaluated and not non-compliant to medications and not on regular follow-up. presented now with a complaint of SOB, initially class 2 to 3, which gradually progressed to class 4, associated with PND, associated with intermittent episodes of headache and blurring of vision, was evaluated for the above complaint, found to have accelerated hypertension, and underwent coronary angiogram to rule out any cardiac etiology, major cardiac etiology. 15 days later, patient presented with generalized weakness and SOB, which had decreased in severity to earlier, found to have elevated creatinine, and after routine biochemical and urine investigations, patient underwent renal biopsy 3 days back.
So what do you think now?
Sir, coming
Before
to the,
going into examination, what are the differentials which you would like to put?
sir, with the
Before he came to the hospital, is there any reason to think that he has a renal disease or not?
no, sir. He denies any history of renal symptoms, any symptoms related to kidney, and he denies history of any elevated creatinine also. He did not say.
But from your evaluation of the condition, do you think that kidney is involved or it's a cardiac problem from the history wise?
History wise, it is looking like predominantly cardiac.
How do you say that?
Patient predominantly had SOB associated with predominantly SOB was his major complaint associated with orthopnea and PND, and during multiple times he's had accelerated hypertension.
So even a kidney
Congrats, sir.
patient can present like that, no? A patient with renal failure could also present like that.
Sir,
How do you differentiate? Is there any way to differentiate that?
yes, sir. This could be a one thing could be these are secondary causes of hypertension in the form of renal, in either renovascular hypertension. These also can present with this, sir. But renovascular hypertension patient will be having recurrent episodes of pulmonary edema.
Here, pulmonary edema was there, I think. no?
Yes, sir. One episode
Yeah,
of
yeah.
pulmonary edema was there.
So
sir.
how to, history-wise, is there any way to tell? Of course, it is, finally, we need either an examination and investigations, but history-wise, could you differentiate the organ system before you enter into kidney?
Patient usually with renal injury, they present with pedal edema. Renal injury, predominant pedal edema, might any hematuria, either it could be my hematuria, any hematuria, or
So urinary complaints may be there, or there is a swelling. Whereas in a cardiac
complaint of urine.
wise, if there's a cardiac cause, how would the patient present?
Cardiac cause also patient presents with SOB might be associated with chest pain or palpitations in that case. Predominant cardiac.
What is the history of dyspnea in a
Sir,
cardiac condition?
associated with orthopnea and PND.
That is later stages. Initially, directly they present with orthopnea and PND, or
Sudden in onset.
exertional dyspnea should be the
Yes.
would be the starting. I mean,
Yes.
there would be a history of exertional dyspnea,
Yes.
and then it may progress. Then you told that he is not evaluated for hypertension.
Yes.
You think he should have been evaluated or not?
Yes, sir. He should have been evaluated.
Why?
Because
Evaluated
hypertension
means not for the complications of hypertension.
for the
I'm telling, should
etiology-
he have been evaluated for secondary causes?
Yes, sir. Yes, sir. Because of hypertension before the age of 30 years. Any patient with hypertension before the age of 30 years and age more than 55 years or 60 years should be evaluated for secondary cause of hypertension.
So just to add to what Dr. Rajendra Prabhu was saying, you said like whether organ involved is kidney or heart, we don't know. Fine, I agree with you on that. But the chief problem with this patient is hypertension in the young,
Yes.
30 years
Yes,
hypertension.
yes, yes.
So what's the common cause? And then could you not suspect kidney as the culprit?
Yes, that
So
can
what are
answer.
the common causes of this person presenting with hypertension at 30 years, which come to your mind?
And at this age, usually IgA nephropathy, kidney-wise intrinsic diseases, it may be IgA nephropathy. In India, it is one of the most common cause of glomerular nephritis, presenting as hypertension. And
So when I ask you what are the common causes of secondary hypertension, broadly renal and non-renal. Out of renal, which are the predominant causes in order of occurrence?
among renal, renovascular hypertension.
Is renovascular more common or renal parenchyma more common?
Renal parenchymal is more
What
common.
percentage? Any percentage? So out of secondary causes, how many are renal, how many are endocrine? Roughly. Percentage.
20 to 30% are renal parenchyma.
Endocrine is 80%.
Remaining other causes.
Renal are predominant. The remaining other causes are less. Among the remaining other causes, endocrine is predominant. Among renal causes, parenchymal are more common. So how frequently you parenchymal, how many neurovascular? Predominantly we have parenchymal. Around 70% would be that. And out of that, what would be the predominant conditions for the renoparenchymal?
Parenchymal, it is IgA nephropathy, one thing with the and glomerular diseases in the form of FSGS. That can be one predominant cause at this age, 30 years of age. And
So only glomerular causes can cause hypertension.
no, obstructive urethra, those causes also can cause obstructive cause of CKD can also present
Means
as
which
hypertension.
obstructive cause?
At this age, renal calcular diseases, which are more common 30 years of age, renal calcular obstructive uropathy can present with hypertension.
What is the most common cause? Tubular infestation cause of hypertension. It's not renal calculi and hypertension. What's the most important cause for hypertension of tubular infestation cause?
Chronic tubular interstitial. Right.
CTI is predominantly associated with hypertension or generally not associated with hypertension. Maybe. So what's the predominant like accelerated hypertension? This patient has accelerated hypertension.
Yes.
So interstitial disease causing accelerated hypertension is example. What comes to your mind? So in renal parenchyma, you have glomeruli, you have vessels, and you have tubular interstitial. All three can constitute parenchymal hypertension. Glomerular causes some renal. Yeah, on vascular cause of hypertension.
Vascular is it based on the large vessels means renal artery
Renal
stenosis.
vascular cause of hypertension.
It could be TMA, HUS, ATP.
Over to you, sir. Professor.
So when do we suspect secondary hypertension?
Sir, secondary hypertension, we suspect hypertension when patient presents with less than 30 years or more than 50 years of age. Refractory hypertension, when patient is having refractory hypertension, we suspect refractory hypertension or resistant hypertension, we suspect. And patients who had well-controlled
Refractory means?
Refractory hypertension is a blood pressure of more than 140/90 after ruling out all possible causes of hypertension, and patients on 3 maximal doses of 3 antihypertensives, out of which one is diuretic.
Yes. Not after ruling out all causes. We are trying to rule out the causes. So 3 drugs in which one should be a diuretic. And in between 30 and 50 years, when will we look for secondary hypertension?
When well-controlled, when a patient with well-controlled hypertension, he has suddenly uncontrolled hypertension, then we'll have to suspect. And when patients present with recurrent episodes of pulmonary edema, then we suspect secondary cause in the form of renovascular hypertension. When patients present with episodes of headache, palpitations, or sweating, we suggest of pheochromocytoma or these catecholamines.
That's a rare cause. When there is an accelerated hypertension on in a compliant patient who is on who was stable earlier, that is one you correctly said that. Other than that,
And
recurrent pulmonary edema is okay, but again, it's mentioned, but it's not that common as such. What are the other common?
When patient well-controlled hypertension after adding any ACR, ARB, if the creatinine increases,
Yes.
then we'll have to suspect.
So in ACE or ARB, if there is a development of progressive renal failure, then in which other subset of people you would investigate?
Any patient presenting with urinary abnormalities, microscopic uria or proteinuria, it's a sudden increase in mass of proteinuria.
What is the common association with the renal artery stenosis?
Renal artery, sir.
Any other clinical clue? Disparity pulses, that's what we want.
Renal artery stenosis, sir. Usually, in renal artery stenosis, more index of suspicion is when patient is having asymmetric kidney sizes, and you have evaluated that the cause of asymmetric kidney disease.
That is after the imaging. But before that, what I was expecting was if there is peripheral arterial disease or a
Carotid
Peripheral vascular.
so on examination, if there is or on symptoms, if there is a claudication, peripheral arterial disease,
Asymmetrical size.
30% of them may be having this one. On investigation, as you told, asymmetric kidney size, or if there is a hypokalemia, you would suspect that. Okay. So in this condition, what are the thoughts in your mind? You have a patient who's who's having a high blood pressure since 30 years, not compliant with medications, who has presented with something like cardiac failure and some renal dysfunction is there, for which biopsy has been done. So this is the information we have as of now. So what will be the DD with which you will go forward in the examination and in the investigation?
Sir, my history diagnosis will be acute kidney disease based on the time period and history, acute kidney disease, with history of recent hospitalization in the near past. With history of hospitalization in the near past and having been treated with antihypertensives, it could be pre-renal, predominantly like drug-induced pre-renal drug-induced diuretics that can cause volume depletion, or ARBs, which AC or ARBs, which had caused this.
Anuradha madam, just summarize the history so that madam can. No more.
I would like once again to summarize the
Please
case.
go ahead.
Yes. A 34-year-old male, an auto driver and painter by occupation, was diagnosed to have hypertension at the age of 30 years, who was not evaluated for the etiology of hypertension, was non-compliant to medications and on not regular follow-up, presented with a complaint of breathlessness, initially which was class 2 and gradually progressed to class 4 associated with PND, and associated with intermittent episodes of headache and blurring of vision. Was evaluated for the above complaint, found to have accelerated hypertension, and underwent coronary angiogram in view of as advised by cardiologist after doing an screening 2D echo. 15 days later, patient presented with generalized weakness, found to have elevated creatinine, and after routine urine and biochemical investigations and doing ultrasound, he underwent a renal biopsy 3 days back.
Go ahead.
Yeah. Good morning, Santosh and Ravinder.
Sir,
Continue, Dr. Ravindra Prabhu. Yeah.
sir, my history diagnosis will be acute kidney disease with recent history of hospitalization within 15 days, having been treated with antihypertensives, and my renal will be pre-renal, drug-induced in the form of diuretics, or ARBs can also cause pre-renal.
No, as I told, information here is having a hypertension which has not been
Yes.
well controlled.
Yes, sir.
He has presented with features of LV failure, like there is orthopnea and all that. And some investigations have been done and biopsy has been done. With this information, you want to put it as an acute kidney injury? You're telling acute. I didn't hear you well. You're telling AKI.
Acute kidney disease, sir, because of duration more than 15 days of duration. Usually AKI less than 7 days we keep diagnosis. Because it is more than 15 days, I wanted to keep a diagnosis of AKD.
Okay.
And with the history of
Etiology of the AKD?
AKD, sir, with the one it could be this accelerated hypertension, and the patient had accelerated hypertension, pulmonary edema, and also complaining of intermittent blurring of vision. And it could be malignant hypertension associated AKI. One it could be. And the other patient had pulmonary edema, heart failure. He was treated with heart failure, and patient had AKI. It could be cardiorenal syndrome, sir. And last DD, one of the last DD will be patient having been intervention. There was a cardiology intervention in the form of coronary angiogram. It could be atheroembolic renal disease, which is at this age 30 years is less likely. And the contrast induced nephropathy, of course, it will be my last DD because usually they don't.
What was you didn't tell us the temporal relation between the angio and the patient became with renal disease, right? And then he had the angio.
No, sir. Initially he went to a private hospital into other hospital for evaluation of SOB. There he underwent coronary angiograms.
And that time there is no details of the kidney.
No, sir. He denies any history of elevated creatinine and no symptoms of renal disease.
No records are available.
Yes, sir. Yes.
Okay. And after that, he has come here after 3 days.
15 days, sir.
15 days. Okay. So you want to keep the hypertension separate and the kidney disease separate?
No, sir. One DDs will be both if in view of accelerated hypertension, pulmonary edema, and blurring of vision. It could be an hypertensive emergency presenting with AKI. That could be one DD, sir. And the other, having been treated in the near past with antihypertensives, that could be antihypertensives. It can also lead to AKI in the form of pre-renal or renal. Either they could be any allergy and because of intervention. Even though less likely because patient had underwent an intervention in the near past 15 days back and presented 15 days later, atheroembolic is one DDC and cardiorenal. These are my 4 differential diagnoses.
So these are indications to do a biopsy?
Sir, in this.
Here biopsy has been done, no? Do you feel this is an indication to do biopsies?
Sir,
Like cardiorenal syndrome, malignant hypertension.
No, we are just at the history. So, with the history of giving the DDs, I just want to ask you, you said antihypertensives causing AKI.
Antihypertensives.
What do you mean by that? Is there any specific antihypertensive which would cause or antihypertensive causing the hemodynamic insult?
One way antihypertensives because he was hospitalized and treated aggressively for antihypertension with both IV and oral. One insult could be pre-renal in the form of diuretics, overzealous use of diuretics causing hypovolemia that can cause acute renal failure. And the other is ARBs. After adding ARBs, patient might have
With this history that he underwent a biopsy also.
biopsy.
Can you revise the order?
Yes,
Can you revise the order? I
Yes,
mean, he
ma'am.
underwent a biopsy.
Yes, ma'am.
He is in a tertiary care center.
Yes, ma'am.
So what must have prompted a biopsy?
Biopsy with then because patient underwent biopsy, patient is having hypertensive emergency in the form of accelerated hypertension, pulmonary edema, and blurring of vision. It could be hypertensive emergency induced AKI. It could be because of when we do biopsy in patients with acute kidney injury, we rule out predominantly pre-renal and post-renal. And if there is after evaluation for urine and biochemical investigations, if we have any other clue for suspecting high index, for example, any active urine sediment.
In this patient, biopsy has been done.
Yes.
So could you think of revising your order and then in which situation would you do a biopsy?
Yes,
In
ma'am.
all AKIs, we don't
Yes.
biopsy,
Yes.
right? Especially in the hemodynamic AKI,
We don't.
we don't biopsy.
Yes.
So if biopsy has been done, what are the possibilities?
One possibility is after biochemical investigations and urine investigations, if patient is having any active urinary sediment, then we will do a biopsy, madam. And to rule out in this patient hypertensive urgency with AKI, there can be a possibility of acute emergency, acute AKI. There can be a possibility of DMA.
Suppose you look into one syndromic diagnosis, whether you want to call it AKD, RPRA, or CKD with complication, or what you want to fit it. Then
AKI.
after that, you can explain the possibilities.
Yes.
So one possibility is AKI.
Yes.
Second possibility, are you willing to consider any RPRF also? rapid hypoglycemic renal failure in this patient?
Yes, sir. Rapid progressive renal failure can also be considered, sir, but
You
because
offer differential diagnosis.
Yes.
After that, as examiners discuss, you put it on order of priority and you explain the causes of this syndromic presentation.
to consider it as RP, yes, sir, RPRF can also be considered, but to consider it as RPRF, patient during the evaluation prior to 15 days back also he denies any complaints related to renal or he denies any elevated creatinine. Probably the insult might be have been onset at that time.
So, see, one thing you told here is that AKI is caused at 7 days.
Yes, yes.
So AKT or RPR?
Yes,
RPRF also has to start someday.
yes,
So
someday.
we cannot
Not
say that
that-
it is not
Yes,
RPRF. And nobody will find fault with you if you put AKT or RPRF.
Yes,
Then subsequently some urine examination and you said urine sediment might have been active and that is the reason and
that
that. So how does a urine examination help you in such a case? Did you do urine examination for this patient? Okay, so actually in a long case, you can ask for doing the urine examination yourself. So if you were allowed to do that, what all would you look at and how would that help you in coming to some diagnosis?
in this patient, if patient is having proteinuria, on routine urinalysis, if patient is having proteinuria or active sediment in the urine, or we can there is high index of suspicion of other glomerular diseases rather than hemodynamic insult, then we can
See,
go
how
for
do you go about doing a urine examination? You get the urine, how much, what do you do? How much urine,
How do you examine for
how
that?
do you examine, how do you do urine examination?
complete urine examination. One will be microscopy, one
And
will
how do you prepare the microscopy?
No, directly. what you do-
centrifuge.
This visual examination. What is the color of the urine? What is urine? is there? Visual examination. After that, you can go to microscope.
Microscopy and dipstick urine
And
analysis.
how will you collect urine? How will you do microscopy? Tell us, simple.
How much urine do you collect? How much urine do you collect?
5 ml, 5 to 10 ml of urine.
What do you do with it? 5 ml or 10 ml? And what do you do with it?
Uh,
Yeah, guidelines for a proper preparation of a urine sample for sediment analysis. So how do you do it for sediment analysis? You said microscopy.
Yes.
Microscopy, how do you do it? You take 10 ml. You centrifuge
Centrifuge,
it
yes.
for how much?
1000 RPM. 3000 to 5000 RPM.
No, there should be no ambiguity.
3000 to 5000.
Without reference base,
For how many minutes? And then what do you do after centrifuge?
And the supernatant sediment, we'll place it on a slide. And
Supernatant can't be a sediment. Supernatant is top part.
Top,
Sediment
the
is the
sediment.
bottom part.
supernatant will throw,
How much you throw? The 9.5 ml is
throw. What do you do with the remaining 0.5?
0.5.
What do you do with the,
We place it on a slide, clear a slide.
do you resuspend it?
okay. Then what do you do after that? So one teaching point is go back and read about urine examination, how to do it, because this is one of the ones where the candidate is often caught because the physics will not see the procedures. Okay. Then what do you look for in the sediment, which helps you in the diagnosis?
Dysmorphic RPCs.
Straight away, on right, on a
Polar.
regular microscope, you will look for this
Polar.
multiple.
Phase contrast.
So, right microscopy, what do you do?
What do you look for? Specifically, if you think it is a glomerular disease, what do you look for? Santosh, you're very
Red blood.
quiet.
No, we will hand over to Santosh after this urine examination. We'll hand over to Santosh.
Red blood cell CAS. Usually we see
First RBC, then RBC.
RBCs and RBC CAS.
What is a cast?
A cast when this glomerular hematuria, this RBCs, when they pass through the lumen, this lumen, they combine with the stem horse pulse proteins and they form a cast, clumping of all.
What else will you see? Dysmorphic RBC.
We are not seen on routine.
Chase contrast.
So what do you mean by dysmorphic RBC? What percentage is normal? Do you
What,
normally have?
what type of cell, what cells would you see?
What?
So what are dysmorphic RBCs? What is the total percentage of dysmorphic RBCs above which you call it is abnormal? And then what are the specific types of dysmorphic RBCs which are described, which are easy to recognize? And what is the percentage of those cells?
Acanthocytes, man, specific type, more than 5.
Good. And
5%
how do
acanthocytes.
they look like?
It's
Name of one cartoon?
Mickey Mouse.
And total number of dysmorphic RBCs?
Dysmorphic RBCs 3 to 5 RBCs per high power field.
No, total number of dysmorphic RBCs, percentage of dysmorphic RBCs, where you will call it definitely low.
20%.
What is the latest? What is the latest figure?
So, anything else, just enumerate any other thing and then Dr. Santosh takes over. So, during you said RBC, you said dysmorphic RBC, CAS, anything else?
And any, if eosinophil, allergic interstitial nephritis, eosinophils are there, eosinophiluria can also, we can think of allergic interstitial nephritis.
Spain,
Stay for your. Okay, and which condition in BP you mentioned, which also has eosinophilia?
Etheroembolic renal disease.
Over to you, Dr. Santosh.
Thank you. Thank you for your presentation. A few basic questions. I don't know whether you said and I missed it. What is the dietary pattern for this patient?
He takes a mixed diet, sir.
Any specific thing that you're interested in this patient? Anything, any particular item is more or less are you interested in knowing?
High salt.
Yeah. So how's the salt intake?
He doesn't say anything related to that, but sir, he takes regular quantities. I don't think he causes.
No, that's a very important bit of history, no, because that may have contributed to the problem. You said the family history, this patient's father and brother were both hypertensive. Is that right?
Yes, sir. Yes.
How old is the brother?
Sir, he's no more, sir. But he was diagnosed to have hypertension at the age of 50 years.
A brother, how old is the brother?
Brother is 45 years old, sir.
And is he also young hypertensive?
No, sir. He was diagnosed to have hypertension at the age of 40 years.
Okay. So 40 is kind of borderline. So if you have a family of people with hypertension and youngish or young age group of onset, what are the things that you will want to look at? Forget the specific patient. Just think what are the histories that you will want to look at.
Familial hypertension, cause of familial hypertension.
Yeah.
Could be hyperaldosteronism, sir.
Okay.
One thing could be. This men syndromes, usually they present with these catecholamine secreting tumors. Then we also have suspicion of this.
If they told you that some family member has had a stroke, what would you want to look at?
In this family history of stroke at this age, ADPKD, in renal wise, we think of ADPKD.
ADPKD is very important thing. Okay. In this patient, you said the patient had headache. So where was the headache? Which part of the head?
Sir, he says intermittent episodes, holocranial, sir. So he doesn't specify to a place or anything.
Okay. What level of blood pressure gives you headache?
Sir,
As per classic
it varies
Harrison teaching.
Sir,
Yeah, I know. It varies.
Varies from person, sir. Usually more than 160 mercury
Diastolic or systolic?
systolic.
I think I have to ask you, like ma'am asked you for reference, because what is classic Harrison teaching is a diastolic value. Okay, you can look it up. So I was a little confused about your final diagnosis. Is the patient hypertension related to kidney disease or is it unrelated to kidney disease?
Aggravated the kidney disease, might have aggravated the kidney disease.
So you think
Could
he
be
has
because there are,
acute-
as per history, there are no clues for renal disease which had caused hypertension as per history.
that's true, but putting things together at the age of 34 now, no? So at the age of
Yes.
30, 31, hypertension would be more commonly secondary, and more common of the secondary would be renal parenchymal, right? So that is one important clue. So why are you keeping it as a separate etiology? And they've gone and biopsied the kidney. Like you wouldn't biopsy a kidney of somebody who's recovering from just an acute kidney injury, no?
Yes.
See, when you say pre-renal, pre-renal is a reversible condition. We don't typically biopsy pre-renal acute kidney injuries. So I think that should not be your first diagnosis. You can say pre-renal going on to an ATN, you want to rule out, cortical necrosis or something, probably you can say down the line, but don't put that as your first diagnosis. So what is your diagnosis for this patient? Just tell me again, please.
The history diagnosis will be acute kidney disease with hypertensive emergency with AKI.
So can I interrupt you here?
Sir.
See, in our diagnosis of CKD, what's the diagnosis of CKD? I know we're not talking about a CKD case per se, but what's your diagnosis of CKD?
Diagnosis of CKD is any chronic structural or structural functional abnormalities of kidney disease for more than 3 months referred as CKD. Sir.
Yeah. So
EEG
this
for less than-
patient, if you had seen at the beginning, what would tilt you in favor of CKD? What finding would tilt you in favor of CKD?
Sir, at the time of presentation to a hospital, if he had given any history of elevated creatinine at the time of his first hospitalization, if it had been more, then it would have gone more in favor of chronic kidney disease.
Apart from elevated creatinine, anything else?
Not any symptoms suggest of nocturia, sir. CKD, nocturia, any patient.
So patients come to you, you're allowed to examine and investigate. This is at 2015 when the patient, 2019 when the patient came to you, you're examining. What are the things that you'll investigate to look for any CKD?
At that time, if examination, sir.
Yes.
On examination,
and
if patient is
investigation.
having pallor. First of all, if patient is having pallor, more anemia is more in favor of against CKD, sir.
So you said your diagnosis of definition of CKD, you said correctly.
Yes.
Structural, functional. So what are the ways you look for structural, functional abnormalities? That please elaborate.
Ultrasound abdomen, if structural abnormalities, ultrasound.
What all are you looking for at that stage?
Ultrasound abdomen will look at size of the kidneys. Usually, patients with chronic kidney disease, they have shrunken sizes.
No, in specifically in this patient, you're looking for a size difference, or size. Both should be small, or one should be small.
If both are small, the diagnosis will be chronic kidney disease. If there is asymmetrical kidney sizes, and after having ruled out other causes, renovascular hypertension can be.
Hold on. Don't go so fast. So if one side kidney is small, it is not CKD, or is it CKD?
Yes, sir, CKD.
Okay. What else are you looking for? Are you looking for shrunken kidneys, either unilateral or bilateral? Then what else are you looking for on investigation, on imaging?
On imaging, sir, one is size of the kidneys, renal parenchymal changes.
Okay,
And,
sounds slightly
and
altered.
hydroureteronephrosis, any hydroureteronephrosis, if it is there.
In this patient, why are you looking for hydroureteronephrosis?
No, sir.
No, why are you looking? Yes, you should look. Why are you looking?
Because this reflex nephropathy
Okay,
can also
that's a good
present with
answer.
hypertension.
Yeah, Supposing you don't see hydronephrosis, but it could be still reflux. What are you looking for at that stage? It could be reflux, but there's no hydronephrosis. What are you looking for? Although ultrasound is not the best investigation for that.
Neurogenic.
No, we're not talking about the bladder. Talking about the kidneys. Are still in the kidneys. There is no pelvic axial dilatation that's visible now, but the patient probably had reflux. So what will give you a clue to a past reflux? Ultrasound is not the best test for it, which you can, which will be your next question.
DMSS cancer, chronic fibromyalgia. Right.
Looking for what? What are you looking for?
Scar.
Scar. So, okay. So this patient, you look for ultrasound, and then you find the scarring. You look for sizes, what and obstruction. Anything else?
Asymmetry in the kidney cells.
Yeah, that you already said. Calculi, you can look at calculi. Size of the kidneys, polypsis. Okay. What investigations will you do?
For this patient, sir, routine biochemical analysis in the form of creatinine, sodium, potassium, chloride.
So what are you looking for? Creatinine are you looking for a normality of creatinine? Apart from that, what else are you looking for?
In potassium, sir. If,
Okay.
potassium is low, again it more in favor of renovascular hypertension. And potassium
if potassium is low, what other electrolyte abnormality are you interested in?
Whether this is potassium low.
Potassium is low, like you said. What other electrolyte abnormality are you interested in? What other electrolyte abnormality are you interested in?
So,
Potassium is low.
So in this patient coming to you at the age of 31, potassium is low. It's a good diagnosis, good finding. What other electrolyte abnormality are you interested in finding?
metabolic alkalosis.
Metabolic alkalosis. Why are you looking for metabolic alkalosis?
Some patients with this metabolic alkalosis, like Barter's or Gitelman's.
Don't get sidetracked. We're still on the call, still on hypertension in a young patient. Metabolic alkalosis, two conditions. Barter's not typically relative hypertension. Hypokalemia, metabolic alkalosis. You're at the right track. Suddenly you got sidetracked now. Renovascular hypertension.
Yes, sir.
And what about adrenal? Aldosteronism?
Hypoaldosteronism.
Hypo or hyper?
Hyperaldosteronism usually they present with hyperaldosteronism usually presents with hypokalemia. Familial hypoaldosteronism, they are present with hyperkalemia.
Yeah, so don't say the ulta thing you said just now. Okay, so this patient had come to you, you would have investigated for all this. In the urine examination, what are you looking for? You said you look for RBCs, RBC CAS. What else?
Eosinophils also.
Sorry?
Eosinophils.
Oh yeah, this I'm talking. This is 2000 and we're still in 2019.
Okay. In urine, RBCs, RBC CAS, we'll see for a protein, sir, in urine examination. If proteinuria is more than
not protein. Typical urinalysis detects only albumin. Okay, so get from the practice of saying albumin. Okay, so what would you have done if there was some albuminuria, creatinine is normal, and there was some hematuria? Nothing on the ultrasound. What would you do?
If patient at that time hypertension, we'll quantify the protein albuminuria or proteinuria. So if it is more,
albuminuria is about 400 milligram per gram of creatinine.
Usually albuminuria in patients with hypertension, if it is more than 1 gram, it is more in favor that kidney disease is the cause of hypertension, and if it is less than 1 gram, it is more like hypertension is the cause of hypertension.
Except this patient's got microscopic hematuria as well.
Microscopic hematuria, yes. RBC, then we'll go for a renal biopsy.
Yeah, okay. So the opinion is divided. In the West, people who can follow up may strictly follow up the patient. Because our patients may not always come for follow-up regularly, we prefer to biopsy. So that's a difference in our practice. That's all. Okay. So this patient, you have done a biopsy. What do you think we're coming to 2022? Okay, now we have done a biopsy. What do you think the biopsy would have shown?
In this patient, biopsy, renal biopsy could have it can be ATN, sir. Acute tubular
Again,
neck.
again, don't compare to ATM. See,
Yeah,
after so much discussion, we have told you it is biopsy has been done. Biopsy for an ATM, we will do only if there is no renal recovery. At least for,
4 to 6 weeks.
yeah. So why are you against bringing the diagnosis of ATM?
It could be
Patient has had a biopsy, patient presented with accelerated hypertension, young accelerated hypertension. You have done a biopsy. What will you think of? What could be the diagnosis on a biopsy?
malignant nephrosclerosis.
Hello.
Malignant nephrosclerosis. What are the histological features of the malignant hypertension in the kidney?
Something it will be fibrinoid necrosis, madam.
Where?
Fibrinoid necrosis in the afferent arteriole and in the capillary loops also.
Oops.
What are the characteristics of histological?
Thrombotic microangiopathy can be there.
In your investigation, somebody young hypertension presenting with severe hypertension, you would look for on investigation, patient, if the patient presents with severe anemia, AKI or AKT, we will think of microangiopathy. Then you will look for, send for other investigations to corroborate that diagnosis like LDH. Let's not go into the detail. Now we have done a biopsy. What will you find on biopsy? Anisha was asking what else.
So
You said
malignant hypertension, you said fibrinoid necrosis. PME is another enzyme. What are the other components of malignant hypertension on histology?
Intimal arterial intimal thickening, intima media thickening can be there.
Thickening
Arterial
in
hyalinosis can
chronicity. The word is not correct. What is there in malignant hypertension? Grossly, you have a pre-pituitary.
I was
Microscopically,
going
you
to
have
ask
what?
if you look at the kidney, you have a pre-bit macula.
gross.
Histology. What else do you find? What are the features of malignant hypertension?
Onion skinning,
What do you mean by onion skinning? Why do you get that onion skinning?
the
Is it chronic or what will happen to the glomerular?
there will be glomerular, there can be one thing can be glomerular sclerosis can be there.
That's not chronic.
Chronic. Wrinkling of the basement membrane can be there.
And inflammation is there.
Inside.
Itis, something is there. Itis. Okay, what are the features of PME? On biopsy.
The other possibility could be a TMI. Is it? Young hypertensive, either hypertension causing malignant hypertension can also cause TMI. Right? So what are the characteristic features on biopsy of a TMI? You have
What-
seen the case yesterday.
Yes.
So I'm sure you will come a little prepared for answering. So what is the specific histology in TMA?
One thing is in the
How do you
class
describe the PME and biopsy?
is fibrinoid
In
necrosis.
TMA, what are the glomerular changes? What are the changes in the vessels?
So in a biopsy, what all compartments you will see?
Biopsy, we'll see glomerular interstitium, tubules, and vasculatures.
Okay, so in each of these, you describe what the things you will see in a TMA. In vessels, what do you see? In glomerulus,
Vessels,
what you will see?
in vessels, we'll see fibrinoid necrosis, sir. And then patients with TMA, this fibrinoid necrosis can also
No, TMA, hallmark of TMA is fibrin
thrombi
thrombi.
in the
Where?
capillaries.
Fibrin necrosis,
Uh,
thrombi.
Fibrin thrombi in the capillary loops. Capillary loops.
These are typical exam questions. So whenever you are describing easy question, now this is not even you have to think PMA, what are the histological features? So histological features, all compartments which you already discussed, and LMI, PM, that's it. So in the flow, because these are easy questions. So what will you see in PMA? Thrombi is one, what are the
That is in the vessel. The glomerulus in that compartment. You will find in the mesangium something. Have you heard of the term mesangiolisis?
Mechanically, what happens? If some thrombi is formed, distally, glomerulus should collapse, lysis will happen. The word is itself is indicating thrombotic microangiopathy. Where is thrombus? In the micro vessels. What is that micro vessel? Where is the thrombi? And after that, what is the effect on the glomeruli and also the peripheral portal interstitium?
There can be some endothelial swelling. And you can have thrombi, between thrombi.
whenever preparing for exam, or when you get the biopsy report, just don't read the last line PMA on biopsy. What is the description you need? And for all cases, prepare all compartments, LM, IA, PM, easy. I mean, one major part of your preparation is over. So go back and read, and we can like 5 minutes to answer, then you won't be able to ask. So TMA, fine. Now I'll tell you that biopsy showed TMA for him. So what will your approach be now? How do you further investigate and manage it?
In this patient, madam, it is because of hypertension, probably hypertension related TMA. The BP control will lead to resolution of
So you are very sure that it's only because of hypertension.
no. Rule out the other cause of thrombotic microangiopathy, and after ruling out all other causes,
So when you get a biopsy diagnosis of PMA, what will be your next step? What should you do? See, you are having a patient who has presented with an RPRF. Your biopsy shows PMA. What will you do?
in these patients, madam, usually
As regards investigation, as regards management.
management.
See, because both are
Yes,
important.
yes. So we will send for this cystocytes. We'll see peripheral smear. We will see for cystocytes. We'll see for reticulocyte count. We'll see for anemia, and all collaborative evidences. We'll look for anemia, LDH,
Thrombocytopenia.
yes, thrombocytopenia, LDH, haptoglobulin, and the elevated of haptoglobin, elevated indirect bilirubin. We'll see, madam. And first we'll look at Adams 13 activity. If it is less than 10%, it is more like in favor of TTP. And if it is not available, we'll do for plasmic score, which is more suggestive of TTP. And if it is not Adams 30 or plasmic score is more in favor of TTP, or we'll think of TTP. Or else in these patients, because we'll rule out other causes, any other drugs.
So, in other words, when you have the PMA on a biopsy, you will think of all the causes of the PMA. So, how do you classify PMA?
Microangiopathic hemolytic anemia can be divided into TTP and HUS. HUS can again be divided into atypical HUS and HUS. Hemolytic uremic cell.
Because practically speaking, what all will you send? What investigations will you send? So there are so many other causes. Practically speaking, you have a PME in your ward.
Yes.
What will you do? So you
Is
said
that the present classification, atypical and typical?
classification has changed now. No? What is the latest view?
What is the classical way if it comes in a child? What do we say that?
It is in a child, sir.
Yes. Classically, presentation of a HUS
Classical presentation of HES in children will be in the form of hemolytic classical hemolytic. They will be presenting with dysentery.
So that is called as
Classical HES in the form of Shiga related dysentery.
STEX means
E called
STEX.
yes. Stex is the toxin which
Manisha,
is related.
Which toxin?
We started to for him. Yeah.
Sir,
Which toxin induced?
Shiga toxin induced.
Okay, Shiga toxin. And the other one, what you called as atypical, is called now as
Complement mediated.
complement mediated. Yes, complement mediated. Go ahead with your examination. I think time is
Examinations are probably, are you being positive on the examination? Okay, because Manisha is checking us with 3 minutes and a bell there. So probably examination, nothing was contributory, that's what he said.
But you will, just for completion, you will look at all the critical pulses, you will check between all
BP,
the
all
programs. So all
Yes,
On the
ma'am.
examination.
basic
Okay.
things.
Yes.
no an examination. How can we know whether the hypertension is recent onset or chronic?
Yes, sir. One thing is fundus examination. If we do, we'll know whether it is based on hypertensive retinopathy. We can say whether it is acute or chronic. And based on physical examination, sir, on apex beat, if it is out and downward and outward, it is more serious of left ventricular hypertrophy. That can be a sign of chronic hypertension. And
Out and down, you say?
Sir,
Out and down. What is the character of the apex beat in LVH?
apex beat is felt in usually fifth intercostal space, 1 centimeter medial to midclavicular line. Sir.
Character? What do we say? LVH.
What type heaving, testing.
Usually in this LVH it will be heaving.
Okay. And what extra sound you'll hear?
LVS3 is the issue of heart failure, sir, and LVS4 you will hear in if it is
LVH.
chronic.
Okay.
I
Okay.
think if we have a little time, Manju, are we done?
Madam,
Because
sorry,
yeah, I
last
know.
question.
Because
Last.
because the case is TMA. So finally, the other things they can read, I think, but how will you approach a case of TMA? That is more important. What will you do? Can you just tell in 2 minutes?
TM.
What will you do?
TMA means now practically TMA as a nephrologist, you're sitting in the TMA, what all investigation you order and what not. That's it.
That's it.
Just 1 minute.
Thrombotic microangiopathy, if a patient present collaborative evidence in the form of complete blood count, will look for
All
any
that is over.
Etiology wise.
Etiology was.
etiology wise, if patient symptoms, if a patient presented
You said
etiology,
Adam case 13.
yes, Adams
Then
30
what investigations
yes,
you will
ma'am.
write and give.
Adams 13 activity,
Adams PS 13.
Yes.
Tell correctly.
Yeah. Adams TS 13,
Huh.
and complement factors, madam. Complement factor full exome sequencing for any atypical mutations, antibodies, yes, ANA, anti-dsDNA to look for these cause, and this complete panel complement factor H antibodies and complete exome sequencing to look for these genetic mutations in the form of complement factor H 1, 2, 3 or factor I, factor B, P, and any other DCKE, any other mutations also full exome sequence.
In India, is it mutations or what? What would you look for?
So
Antibodies, usually factor H
Oh.
antibodies, they are more common.
The complement factor H autoantibody.
So secondary causes, you said AME. Second important secondary cause is drugs.
Drugs.
Third important secondary cause is
Infection.
infection.
Infections,
The
yes.
profile you said. Fourth important secondary cause is malignancy.
Malignancy.
So all those things, and then finally the complement enough should be done. They are costly. You can look for a low serum complement. Suppose serum complement is normal, would you stick to the complement analysis?
Yes, ma'am.
Yes.
Yes.
So and then you should know all the factors available and the techniques. So
And then
what techniques?
For
For the the genetic analysis of complement? What usually, by what method is it done?
Full exome sequence.
What's the
Exome
method? Full exome, yeah.
MPLA.
What does that stand for? Okay, fine. And then how would you
Management
manage
wise, what we do.
Management wise, there are various management based on the etiology. We will management. If secondary causes, we will manage according to that.
Yes.
And if it is a complement mediated, we will after ruling out this Adams if it is classical pitches, we'll go ahead with plasmapheresis.
So you must know how you will do it, how much you will give, how much plasma will be.
1.5 times.
How often do you do? And then along with that, what else will you do? So these are the. Manju is.
Yes, ma'am.
She was given a
So you will also start with treatment if it is available. In India, it's not available. So
What are the tests you will do in the blood which will help you in managing? Like if I want to give plasma and I have given the plasmapheresis. How do I decide when to stop or all that? If I have to tell you 2 tests to be done in the blood, which will help us in deciding now I can stop the plasmapheresis. What will you monitor?
If it is factor H auto antibodies related, we'll monitor the levels of anti-antibody.
Are not available immediately. This is now we have to do every day. No,
Every
plasmapheresis I have to do every day or alternate days.
in this,
I cannot do anti-H antibody every day.
hematological remission, if we can see, sir, hematological remission.
What will you monitor?
In the form of thrombocytopenia, if it is more than 1 lakh, you can.
And what else?
Anemia.
Anemia.
LDH.
Yes.
LDH is less
and
than 400.
platelet. LDH and platelet count. So what do you aim for the LDH?
Less than 400.
Less than twice of normal. What is the normal upper limit?
250.
Okay, 270. And supposing, okay, you have sent the anti-H and it is not.
Dr. Ravinder, I think we are running.
Okay, madam. Yes.
So I think we'll stop here.
Okay.
Thank you very much. You have to read the way you discuss the case. Your initial DD itself was not right. Because in such a case, you should never bring an ATM into the potential diagnosis, right? And especially when you have a history of a biopsy being done and a young hypertensive, you should think of either hypertension causing without TMA also it can cause, or whether it's TMA, so you need to go that way. Okay. Right.
Thank you.
And we have the next candidate.
You will present 2 short cases in sequence, madam. Short cases.
Morning.
Manisha Santosh and Ravinder Kripal Mulana, 2 short cases.
Santosh and Ravinder, these are 2 short cases.
Okay, madam.
He will do it one after the other.
Yes.
And can go backward, ask for a diagnosis and ask him how he arrived at the diagnosis. And we have been present the history.
Yes, ma'am.
Yeah, and we try to finish each case half an hour. So total 1 hour. So
And
it's an
now
examination for us. also.
time goes over.
Let's stick on to the time.
Yeah, what is the time now?
10:21.
29.
अब तो आगे चल रहे हैं 10:21.
अच्छा ठीक है आपका
10:21 must do.
ठीक है madam.
So we'll take it as 10:20.
Yes.
So we will come finish at 11:20.
Yes.
Good morning, all examiners. So I'll proceed with my first short case. I have examined a 58-year-old male, Venkataya, working as an auto driver in Hyderabad, uneducated. Date of admission to Usmania Hospital on 16th of May, and date of examination is 20th of May, that is yesterday. He presented with chief complaints of swelling of both lower limbs since 3 years and aggravated since 6 months, and exertional shortness of breath since 2 months. I would like to date back my history to 10 years back when he had an episode of giddiness and mild weakness in left upper limb and lower limb, and was admitted to NIMS hospital and was told to have diabetes, hypertension. was admitted for 1 week, underwent scans, and was put on medical management. The weakness recovered within 15 days, and patient resumed his daily living within 1 month. He was on oral anti-diabetics and single antihypertensive, but was not regularly checking his blood pressure and sugar, and he continued his daily routine of auto driving. He was apparently normal till 3 years back, when he started developing swelling of both lower limbs, insidious in onset, limited to ankle, with mild facial puffiness in the morning, relieved by evening. And the swelling gradually increased progressively and are now aggravated since the last 6 months, involving progressing from ankle to mid shin, and also in mild abdominal distension and shortness of breath since 2 months, insidious in onset, gradually progressive, exertional, grade 2, but not associated with chest pain, orthopnea, or PND. Patient had a hypoglycemic episode 2 months back, when the oral anti-diabetic drugs was changed to insulin, and since 2 months he's on insulin, and he was told to have a kidney problem. There's no history of oliguria. There is no history of decreased urine output, burning micturition, or hematuria. There's no history suggestive of any recurrent urinary tract infection. There are no voiding symptoms also. There's no history of pain abdomen or flank pain. Now, since 2 months, he's been planning to visit a hospital. Since 2 months, he's also complaining of constipation. Since 2 months, decreased appetite, and decreased oral intake, which he attributes to the abdominal distension also, and pruritus in both lower limbs since 2 months, and also generalized body ache and fatigue since 2 months. There's no history of floaters in the eye. But patient gives history of paresthesias in bilateral lower limbs. There's no history of postural dizziness. Past history: 1 year back, he underwent cataract surgery, but no other problems were identified in the eye. He doesn't give any history of retina laser surgery in the eye. There's no history of diabetes or hypertension or kidney disease in first degree relatives. Personal history: he's a non-smoker and non-alcoholic, and no addictions or no tattoos. His appetite is decreased since the last 2 months. He takes a mixed diet. He's constipated bowel. A bladder is normal. He wakes up twice in the night to void. Drug history: he was on oral anti-diabetic until 2 months back. Since 2 months, he's on insulin twice daily, and also he's on
Short case. You've already told about the.
Yes. So hospital course: he is admitted in Usmania Hospital for the last 4 days. He is receiving IV drugs and tablets. He was told to have high blood pressure. He never required any oxygen. He was admitted in a general ward. After admission, his edema has substantially decreased, and his shortness of breath also has decreased. He doesn't give any history of any procedure done, like renal biopsy, or no hemodialysis also was not done, and no blood transfusion also. But he was told to have low hemoglobin and kidney damage. Yes, this is the hospital course. So finally summarizing, we have a 58-year-old male with a history of diabetes and hypertension since the last 10 years, with irregular follow-up and poor control, with history suggestive of both microvascular and macrovascular complications in the form of paresthesias and cerebrovascular accident, and now symptomatic since 3 years, gradually progressive, aggravated since the last 6 months, with non-oliguric, with uremic complaints in the last 2 months, and a hypoglycemic episode. This is my summary.
So it's a kidney disease in diabetes.
Yes, sir.
How will you evaluate?
Sir, I will look for retinopathy evidence. I will look for proteinuria quantification. I will look for ultrasound size.
So what are all the causes of kidney disease in diabetes?
So the diabetic nephropathy, which is the classical histopathological causing diabetic kidney disease, And due to macrovascular complications like atherosclerosis, patients can have renovascular disease causing
So
ischemic.
do we directly assume it is all chronic and treated as chronic, or you want to look for any acute factors?
Acute
Any
factors,
treatable?
treatable urinary tract infection is one of the urinary tract infection. Pyelonephritis is one of the most most important acute causes in a diabetic for reduced renal parameters.
Other than that,
Other than that, accelerated hypertension also can cause increase in creatinine, urinary infection.
What are the common causes of acute deterioration? Complete the list.
like pre-renal, renal, post-renal, like that. It's better to go more logically so that you don't miss anything. So if I ask you what are the pre-renal causes
Pre-renal causes are cardiorenal.
in a diabetic,
If-
not in general.
If you are asked for acute factors for acute deterioration, what are the few things we will look for? 1, 2, 3, 4, 5.
Acute infection, sepsis, heart failure,
So
heart failure.
infections.
Can you just move forward? The exam is not able to.
Is it okay, Dr. Santosh? Now is it okay? You want me to
Yes,
change?
I can hear, man.
Yes, ma'am. Yes, ma'am.
Okay, right.
So 1 is infections, you said. 2,
2 is acute heart failure causing hypotension, cardiorenal
so hemodynamic.
hemodynamic.
2, 3,
3 is drugs.
drugs. 4,
4 is one of the causes is papillary necrosis causing obstruction. Hypertension.
Previously, absolutely. These
so
are
these
five
are the
common.
5 common acute deteriorating factors.
Others can also be there, but this is common.
Which drugs will you look? Which drugs will you ask for? Which can cause?
Sir, any recent history of taking ACRBs or SGLT2 inhibitors, which can cause transient increase in renal dysfunction?
Then
NSAIDs,
NSAIDs. Then
Diuretic.
if he has had any imaging,
contrast-induced nephropathy.
IV contrast. Yes. And what factors in this patient would predispose him to pre-renal failure?
Using diuretics, heart failure, like microvascular disease, MI, heart failure, and using diuretics.
Then
SGLT2 inhibitors also can cause dehydration.
I'm not asking about drugs. From his disease itself, does the diabetic milieu itself predispose to pre-renal? In
Yes,
what
sir.
way?
Hyperglycemia can cause mechanical
Hyperglycemia will cause what?
shear stress and acute diabetic ketoacidosis and
No, osmotic diuresis.
Os-
An uncontrolled diabetes will have osmotic diuresis. It will be hypovolemic. Then what else? You described so many things like which could predispose. So that's why I'm asking you. Anything to do with the nerve? Neuropathy? Neuropathy, anything can predispose to the
Yes.
pre-renal?
it can cause diabetic cystopathy and secondary neurogenic bladder and can
Cystopathy will not cause pre-renal. It may cause post-renal. I'm asking pre-renal. Autonomic neuropathy, can it predispose to a pre-renal?
yes, sir. Yes.
How?
It can cause postural dizziness and postural syncope.
What about the gut? What happens to the gut?
That it causes alternating constipation and diarrhea. It can cause and
So there can be diarrhea, which
diarrhea.
can diarrhea and gastroparesis. They can cause. Then in the renal parenchymal, what does it? What are the things which you would look for acute factors?
Acute factor renal parenchyma. One of the most important causes pyelonephritis.
that you mentioned. What else?
Yes. Drug-induced interstitial nephritis.
Yes, interstitial nephritis and infections you already mentioned. Yes. Postrenal is?
Postrenal is obstruction by infection itself can cause obstruction sometimes.
Infection, how will it cause obstruction?
If there is papillary necrosis.
Yeah, papillary necrosis. Infection does not cause obstruction.
Can you go with any findings on examination?
Yes. He's 58 kg.
Positive findings. Short please.
Positive findings. He has a significant uncontrolled hypertension, a significant high blood pressure of 180 by 110 in both right and left arms, and he has a pitting pedal edema up to ankle, which was there up to mid-shin, but now after the hospital admission it has come down, and he has pallor.
How about the peripheral pulses?
All peripheral pulses are palpable, sir.
What are the things you look for in a diabetic?
I look for microvascular and macrovascular complications. All peripheral pulses.
So don't, here you don't want.
Yeah. Peripheral pulses.
Yes.
Ulcers. Any ulcers.
Non-healing ulcers.
Non-healing ulcers.
Yes.
And nervous system examination, any paresthesias or sensory neuropathy. Then fundus. Then
Pulses, what all you check here, that's it. What all you check?
pulses, I will see for atherosclerotic changes also in the pulses.
See, don't tell theory. Atherosclerotic means what do you look for?
How do you look for it?
Calcium, like heart vessels,
Okay,
calcium.
What else? Heart vessels and all of that later if we have missed all the earlier things. How do you look for peripheral vascular disease?
Ankle
check for
brachial
the
pressure
pulses.
index.
What is that? What is that?
Ankle brachial pressure index.
What
So,
is it?
difference in the blood pressures.
How do you calculate it? I want to know whether you use it. ABI, we read clearly, but do you apply it? What is it?
So
How much is normal?
0.9.
0.9.
BP is more in
More
lower
in
limbs
the-
or upper limbs?
His VP is more in the lower limbs.
Is it normal or normal?
It's normal.
If it is lower in the lower limbs,
Then it is abnormal. That he has
So
peripheral.
ABI is not subtraction of something. It is what?
It is ratio.
It's a ratio. So ABI, because calculating the amount is okay for me. This. What is what other pulses? This you have checked, legs you have checked. What else?
Carotids.
Carotid, yes.
Carotids, because sometimes carotid.
Okay, what other examination? So you have told vessels.
Neuropathy, retinopathy,
Neuropathy you have told. What else?
Yes.
Neuropathy, anything else?
And
You said
sensory motor neuropathy, bladder, autonomic neuropathy. I look for postural drop.
How do you look for it?
I'll check the blood pressure on supine position with the cuff in situ but deflated. I will ask him to stand up, and after 30 seconds, 1 minute and 3 minutes, I will check the blood pressure. And if there is significant drop in blood pressure more than 10 mm systolic, then it is. I'll confirm that it is one of the signs of autonomic neuropathy.
Retinopathy, what are you see?
I'll see for any non-proliferative diabetic retinopathy, aneurysms. Intraretinal aneurysms, proliferation, neovascularization.
Suppose there is no retinopathy, would you ask for a fluorescein as well? What's
Yes.
the idea?
Usually,
So should we use fluorescein to rule out diabetic retinopathy, or what's the standard treatment? So should we use fluorescein to rule out diabetic retinopathy if the general examination doesn't show, or it's not required?
we should advise me. Fluorescein and OCT are both advanced investigations. If we miss on general fundoscopy, early stages of diabetic retinopathy.
Fluorescein itself is nephrotoxic. So it's not the standard determination. So it's not. So are you sending all for fluorescein before you
No.
are proceeding to biopsy?
No.
So any of this patient had a diabetic retinopathy, proliferative diabetic retinopathy.
What is the association between retinopathy and nephropathy?
In type 1 diabetes, it is
Type two.
type 2 60% there is concordance.
Why?
Because of the onset, like type 2 diabetes, we don't know the history, how, when the onset of the disease.
That's okay. What percentage of patients will have nephropathy at diagnosis? And what percentage of patients will have proteinuria at presentation at diagnosis? These are figures you must know.
Yes. Proteinuria at the diagnosis of type 2 diabetic nephropathy, around 30% will have. Overall concordance of type 2 retinopathy and nephropathy 60%.
Why?
Because macrovascular disease also is common in type 2 diabetes.
And patients with type 2 diabetes have non-diabetic renal disease.
Yes,
What percentage?
40%, 40 to 45%.
No. 30. So more than 30 to 35% patients with type 2 diabetes will have a non-diabetic renal disease. So they will not have retinopathy. And we were talking about some cystopathy, avoiding symptoms.
Yes.
What is diabetic cystopathy? How will it present? And what will you do?
Yes. Due to autonomic neuropathy, so patients will have a secondary neurogenic bladder. They will have urinary incontinence. They can have urinary incontinence, or they can have urinary dribbling, lower motor neuron bladder, lower motor neuron kind of bladder, where there is a predominant retention of the urine and there is dribbling, due to which they are predisposed to infections. So I can prescribe a anticholinergic drug for them to.
Straight up. What will you do? What specific investigation will you do?
I'll do an uroflowmetry and
Uroflowmetry only, or a complete urodynamic study?
complete urodynamics.
So do you know how to interpret the urodynamics?
I'm not confident.
You must know.
Yes.
The diabetic nephropathy is one of the commonest diseases that you encounter. So what are all the graphs? Have you ever seen a urodynamic graph?
Yes, I've seen.
What all they look at?
They'll put the storage
They
and
look
what.
at the abdomen. No. What are all the parameters based on which they will say what type of bladder dysfunction he has? So you spoke about diabetic cystopathy, so you must know about diabetic cystopathy, how you would investigate, what is urodynamics, how you do, and how you would interpret the graphs of urodynamics. So since it's a short case, I'm just telling you what you should read, right? Okay, Santosh. Before that,
Let Santosh talk.
Santosh.
Okay, just a couple of questions because being a short case.
Yes.
You said that you wanted to look for early stages of diabetic retinopathy in this patient. Actually, how relevant is that for your looking for non-diabetic kidney disease? You want to do OCT and fluorescent angiography and things that you wanted to do. How relevant is that for in this patient who you have diabetic kidney disease? Early retinopathy, how important is it? Is it important to know early retinopathy, find early retinopathy, or not that important? This percentage concordance you gave is for diabetic retinopathy overall, or any particular type of diabetic retinopathy?
The concordance 60% is for non-proliferative and proliferative diabetic retinopathy.
No, it's for proliferative diabetic retinopathy predominantly. So the early stages may not mean much. It may coexist with non-diabetic kidney disease. So that's not that important for us to exclude doing a biopsy. If you have a doubt, we should do a biopsy. You heard of Mogensen staging and all?
Yes.
And okay. For which type of diabetic nephropathy?
It's
Is
for
it
type
one
1 diabetes.
Can you just enumerate the stages quickly, please?
Yes. So 5 years to 10 years, there will be microalbuminuria. From
So what's the first stage?
first stage is renal hypertrophy.
No, what is the clinical counterpart of that?
Hypertrophy.
Clinical counterpart of that. What stage is it called? Stage of?
Stage of hyperfiltration.
Okay,
And
that's right. Second stage?
what happens? Kidney size, nephromegaly.
Yes. Clinical stages, stage of hyperfiltration. Then is incipient.
Before there's one like stage 2, something is there. Stage of apparent normalcy or silent stage.
Silent
silent stage. Then is
but where you have histological changes, but you will have proteinuria during periods of poor metabolic control or exercise. This is stage 2. Stage 3.
Stage 3 is incipient diabetic nephropathy. Next is over diabetic nephropathy, and last.
So what is incipient diabetic nephropathy?
Where only screening will tell us about proteinuria, microalbuminuria.
So that term has been changed now, no?
Change. Microalbuminuria is now called moderate albuminuria.
Moderately elevated.
Moderately.
albuminuria. Okay. What is the level of BP control you want? You said the BP is very high.
Sir?
You said BP was very high, 180, 110. You said now the
Yes,
BP was, no?
Yes.
What is the level of BP control you need for this patient?
Sir, according to the recent KDIGO guidelines, BP of 120 by 80 is I would target.
You complete your sentence very quickly. You're probably right, but they mentioned it has not been studied for diabetics, no? But they've extrapolated for diabetics based on those with insulin, those with impaired fasting glucose in the SPRINT trial. So diabetic patients, we don't actually have a target. We're using 120/80, but we don't have a target. Ma'am, over to you. No more questions from me, ma'am.
Last question from me. Acute kidney injury, has it any role in the pathogenesis of diabetic kidney disease?
Yes, sir. So recurrent acute kidney injury will progress. They will progress to CKD fast, and the recovery also will not be like in other population, general population. Any AKI in a diabetic kidney disease will leave a scar, and they will progress fast.
How will you define persistent microalbuminuria? Define.
Proteinuria in the range of 30 to 300 mg per gram of by urine albumin creatinine ratio. So it's called the microalbuminuria, 30 to 300.
Persistent. When I say persistent, in how many samples over what period of time?
Yeah, actually, madam was asking regarding the non-diabetic diseases and diabetic diseases, 70 and 30.
Yes.
In the diabetic also, how much percentage will be proteinuric and how much will be non-proteinuric? And the management different will be there in this question.
Around 70% will be proteinuric, sir, but now we have seen a new phenotype of 30% can be non-proteinuric.
How do you manage them? What is the prognosis? Is it better for proteinuric or non-proteinuric?
No, prognosis is actually bad. Prognosis is actually bad for non-proteinuric.
Why the prognosis?
Because predominantly inflammation is going on in them, interstitial inflammation. That is why they are non-proteinuric, and that's why they progress faster.
Inflammation, vascular.
This diabetic nephropathy patient, should you screen them for a cardiac involvement? How
Yes.
frequent is congestive heart failure? What percentage of diabetic nephropathy are fixated? How do you screen? What are the guidelines for screening for?
All diabetic nephropathy patients should undergo cardiovascular evaluation by non-invasive, by at least by TMT. Apart from
Which
ECG.
guideline are you speaking? So whosoever with diabetic nephropathy comes to you, you screen routinely and do a TMT, or what do you do? Straight you go to TMT? What are the guidelines?
The diabetes in CKD guidelines 2020 KDI says we have to screen for macrovascular. Like if there is any past history of cerebrovascular accident, then we'll have
Nothing
to.
is there to diabetic patient. Nothing is there. What are the guidelines for screening for a cardiovascular disease for a stage 3? Suppose it's GFR is around 35, stage 3.
I look.
Routine patients will come
Yes,
to
I
us.
look for other lipid profile. I will do and see for dyslipidemia, and I look for HSCRP and non-invasive markers of coronary artery disease and atherosclerosis.
Suppose he doesn't have this lipidemia, would you start his statin for him?
If his GFR is
35,
30, I will start.
irrespective of this.
Yes.
Okay. Yeah, so just like, how common is CHF in him, and do you need to screen for CHF for all that is nephropathy?
All- Stage
I'm
3
not
up
asking
more.
about ASCVD, CHF.
More than stage 3 CKD, especially in diabetics, I will screen for because they can have silent MI. They will not have any.
What's the
Just
guideline?
we'll have to do an echocardiogram.
Isn't it completely asymptomatic?
Yes,
ECG, you know,
ECG and echocardiogram.
everybody, these kinds of things.
Yes.
I think we'll close because it's 10:50. Santosh and Ravinder, if you're okay, can we go with the next case?
Yes, madam. Second case will go.
Yeah, half an hour we have finished with this case.
Yes, madam.
Yeah, yeah.
I've examined a 30-year-old female, Saidamma, from Nalgonda, who is a daily wage laborer in the stone breaking industry. Date of admission is 19th of May and date of examination is 20th, that is yesterday. She is asymptomatic at present and has been admitted to the hospital for an IV injection, which she has been taking every 15 days and has completed 4 doses. I would like to date back my history to 1 year back when she developed rash. Predominantly started off in the back, in both the arms, and then progressed to involve chest and back, and also face, and it was reddish, painful, and along with the occasional pustules, with an involvement of face with both cheeks. Also had lesions in the oral cavity, say similar kind of lesions in the oral cavity and scalp also. So all these skin lesions progressed over 3 months, but there's no history of photosensitivity. She used topical medicines from a local doctor. Pustules used to heal, but the predominant rash progressed. So there's also she also gives history of joint pains in both small joints, equally in both the upper limbs, also involving elbow and knee, with non-deforming, inflammatory with associated with early morning stiffness since the last 6 months. She lived on taking analgesics, which she reports taking analgesics only once a week or once in 10 days. So in the background of rash and joint pains, 3 months back, she consulted a dermatology department at Osmania Medical College. She was admitted in the dermatology ward, underwent skin biopsy, and she was admitted for 15 days, during which she took IV and oral and topical medications. During admission in the dermatology ward, she was found to have hypertension and proteinuria, and was shifted to nephrology, where she underwent renal biopsy and was given IV medications for 3 days and was discharged. 1 week later, following the biopsy report, she was told to have a proteinuric kidney disease, and was advised IV injections for 3 months and prolonged oral medications. There is no history of hemodialysis or any special dialysis or blood transfusion being given during the hospital course. There was no history of swelling of legs at any stage of the disease. Only there was mild facial puffiness that was observed only in the skin ward after giving many IV injections. There is no history of fraudhuria, dysuria, or hematuria. There is no history of cough or hemoptysis, no history of headache, seizures, or altered behavior. There is no history of pain abdomen. There is no history of fever or bluish discoloration of any of the fingers or limbs. Coming to obstetric history, She's married since 15 years. She's para 3, living 3. All 3 deliveries were full-term normal vaginal deliveries. First one was at the hospital with good antenatal checkup. Next 2 at home with no proper antenatal checkup. Last childbirth was 10 years back, but she doesn't give any. She denies any history of abortions or miscarriages. Menstrual history. She has regular cycles, 3 to 4 days per month, and only complaints of mild dysmenorrhea. She past history. There's no history suggested of any other medical illness other than the last 1 year. Family history, there's no similar complaint. She has total 5 siblings, 3 male and 2 female. Okay, other than occasional NSAIDs, which is once a week or 10 days for 2 to 3 months, she doesn't give any history of taking any other drugs apart from the prescribed from the dermatology ward. Personal history, there's no addictions or tattoos. Hospital course, she was admitted on 19. She was some blood tests were done, blood and urine tests, and she was one IV injection was given, which lasted for around 6 hours. And there was no reaction during the injection, and she is ready for discharge today. So summarizing, we have a 30-year-old female, para 3, living 3, with no abortions, miscarriages, with 1 year history of diffuse skin rash involving upper arms, neck, chest, and back, and also face, and 6-month history of symmetrical, non-deforming polyarthritis, inflammatory, and 3 months back was incidentally detected to have hypertension and proteinuria without any significant pedal edema symptoms, and underwent renal biopsy in the nephrology department, and has been taking injections once in 15 days since the last 2 months, and 2 more doses she says are remaining.
Diagnosis.
So
Blood pressure?
there's no
BP?
hypertension. History wise, she told she was diagnosed with hypertension in the
On
neck.
examination.
Examination now blood pressure is 110/70.
What's the diagnosis?
So my syndromic diagnosis will be nephritic syndrome. Nephritic syndrome, etiology probably not connective tissue disorder, and probably lupus, systemic lupus erythematosus.
Why is it nephritic syndrome?
Because there was hypertension and proteinuria and mild renal dysfunction.
That makes it nephritic.
Yes. And predominantly there is no edema, which is like in nephrotic.
How do you define a nephritic illness?
When proteinuria is less than 3 grams and there is active sediment.
Define acute nephritic syndrome. 1, 2.
Acute nephritic syndrome, you won't have proteinuria at all.
We'll have proteinuria. The
So
proteinuria,
always it will be non-nephrotic range.
no matter.
Okay, so let's not deviate.
So active sediments in the urine and hypertension and hematuria and high colored urine. The classical description of acute nephritis.
Clinical. It says
Clinical
symptom symptoms and signs.
symptoms will be predominantly hypertension related, headache, and also hematuria patients can have, and symptoms of renal dysfunction also.
Classical way, like if I say a child comes with a post-infectious,
High colored urine.
how
High
will the-
colored urine.
a child comes with post-infectious glomerulonephritis, the classical acute nephritis, what will be the presentation?
Presentation will be high colored urine, oliguria, hypertension and edema, and renal dysfunction.
Sudden onset, gradual onset,
Sudden onset.
Okay, so you think this is lupus nephritis?
Yes, sir.
Going by the history and what the drugs, what sort of treatment she has received? What do you think she has received?
Probably she has received cyclophosphamide. Because once in 15 days, she says she has completed 4 doses and 2 more doses are remaining. So probably she has received cyclophosphamide.
Cyclophosphamide, which
Urolupus protocol.
ELIT.
ELIT.
So probably it is what class?
Probably it is class 3 or 4, proliferative lupus.
What are the various renal involvement in lupus? Apart from lupus nephritis.
Apart from lupus nephritis, it can cause interstitial nephritis, and it can involve the vessels by non-inflammatory, inflammatory non-necrotizing vasculopathy, TMA, and also non-necrotizing vasculopathy. So vessels can be involved, and interstitium also can be involved isolated in form of acute interstitial nephritis. Other than the glomerular classic 6 classes of lupus nephritis.
No. Apart from lupus nephritis, there only you said hypertension and drug. Any other? What are the various renal involvement in lupus?
The vasculature, it can cause TMA, madam.
TMA you said.
And by isolation of APLA, it can also cause TMA.
Okay.
It can cause necrotizing vasculopathy, vasculitis, lupus vasculitis.
Okay.
And it can cause interstitial inflammation.
It can cause tubular interstitial.
Interstitial nephritis. I see.
Anything else?
And lupus nephritis, glomerular, 6
If
classes.
there is renal,
Any other glomerular involvement apart from lupus nephritis? What is lupus podocytopathy?
Lupus podocytopathy is like an MCD-like picture with ANA positivity.
What
It can-
percentage?
Around 10% can cause lupus.
10%?
1 to
If 10% of lupus patients
No,
develop
1.
podocytopathy,
2%.
about 1 to 2%. How do you diagnose?
By electron microscopy, if
What
there
will
is,
it show?
it will show diffuse food process effacement of more than
Treatment?
80%. Treatment will be oral steroids, just like how it we can
So
see.
this is the only condition where only steroids are
Only
used.
steroids.
Otherwise, in all other lupus nephritis, steroids alone have no role.
Yeah, Dr. Ravindra, Dr. Santosh, do you want to ask? Then I'll ask a couple of questions from each of you.
so what is the percentage of people who present with lupus nephritis, and ultimately how many will develop over the course?
So 25 to 50% will present with lupus nephritis at the start of diagnosis, and eventually 60% will develop lupus nephritis.
So in this patient who presented with extrarenal features,
Yes.
how would you know that the kidney is involved?
By screening, by by proteinuria, hematuria, complements, and other antibodies like dsDNA.
Yeah, urinary. It may come as asymptomatic urinary abnormalities or one of the classical syndromes. Okay, so which are the classes which you told?
Classes, histopathological classification. The
histopathology.
ISNR is classification. Class 1 is normal. Class 2 is minimal mesangial expansion. Class 3 is focal proliferative lupus nephritis. Class 4 is diffuse proliferative. Class 5 is membranous nephropathy. Class 6 is diffuse mesangial glomerulonephritis.
So among the immunological profile, which is the one which is classically associated with lupus nephritis?
dsDNA antibodies titers are classically and anti-Smith also.
Okay, why is that?
Your
Why only?
type 2 is mesangial expansion.
Yes.
Is it mesangial expansion?
It's expansion or something?
Is it something else? Because you have to
Mesangial
clarity.
hypercellular.
So there must be clarity in what you say.
It is mesangial
Mesangial
hypercellular
expansion is seen in
diabetes. Mesangial hypercellularity should be greater than 4 cells.
so it is mesangial hypercellular.
Hypercellular.
So what is the typical urine? Dr. Santosh, are you willing to take the next?
Yeah, okay. Couple of questions only.
Yes.
Have you heard of multi-targeted therapy?
Yes, sir.
Tell us about it, please.
Sir, it's a Chinese study where for induction they have three immunosuppressive drugs: steroids, glucocorticoids, and mycophenolate mofetil, and CNIs were combined together for lupus nephritis induction. Where they compared with the IV cyclophosphamide, and they found similar outcomes of remission in this is a multi-target regimen, and the MMF dose used is 500 to 1 gram per day, and the tacrolimus levels, trough levels targeted was 5 to 7.
It's only an induction study, is it? Or
Induction. Yes.
only induction or anything more? Was any maintenance arm? Maintenance arm was there?
I'm not sure, sir.
The same group did these patients after induction there was a maintenance arm, right?
Yes.
With less adverse effects, less dropouts, and the benefit was maintained.
Yes.
Okay. Have you heard of any newer therapies for lupus nephritis which have come out in the recent past couple of years?
Yes, sir. So oclosporin, CNI, low-dose oclosporin in the AURA LV trial, and belimumab was tried, both of them in induction, and Nobility trial is trying obinutuzumab also.
Okay. What is obinutuzumab?
It's a humanized anti-CD20. Just like rituximab, how it is chimeric, obinutuzumab is a humanized anti-CD20.
What's the advantage of using obinutuzumab or one of the other drugs like ofatumumab versus Ritux?
Infusion reactions will be less.
Yeah, infusion allergic reactions are less. You said about class 3, class 4. No, just can you differentiate what is class 3, what is class 4?
Class 3 is focal proliferative lupus nephritis, which involves less than 50% of the glomeruli will be having proliferative lesions, whereas diffuse proliferative lupus nephritis will have more than 50% of the glomeruli having proliferative lesions.
So if you do a biopsy sample and you find 12 glomeruli and you find 6 are involved, is it 3 or is it 4?
3 plus 4.
3 plus 4? 7.
No, sorry, 4, sir. 4.
But you said more than 450 is 4 and less than 50 is 3. So where's 50 falling?
Mostly 4. We will have to consider 4 because it will be unsampled.
Is that your impression or is it ISNRPS impression?
Sorry, sir, I'm not sure.
See, the WHO said 50 or less was 3. ISNRPS said 50 or more is 4. So there is a definite change. You're right. Your answer is correct, but not for your personal reason, but ISNRPS reason.
Yes.
That's all from me.
What is telescoped urine?
Telescopic urine is classically seen in lupus nephritis, where there is evidence of all compartments of the nephron being involved.
Is it all compartments? Is it something else?
So what is telescope urine? I mean, when will you do a urine examination and say this is telescope urine and this is characteristic of SLE?
Where there is proteinuria, hematuria, and
So that can be there in
Class.
so many other things. We say telescope urine is specific, very specific for SLE. Very specific means we need to specific for SLE. What is so specific about telescope urine?
because all compartments are involved, like tubules, interstitium, glomeruli,
So how does that
vasculature.
reflect in the urine? How is SLE different from, for example, other diseases? You have activity and chronicity. How does that reflect in the urine? What is the
Cast.
manifestation of activity?
Activity will be hematuria and proteinuria.
Gases can be
Cast.
given activity.
red cell casts will be there in activity, whereas
What are the features of chronicity?
chronicity are hyaline casts can
Hyaline and not chronic.
no broadcasts.
Broadcast.
Broadcast.
Whenever you have broadcast along with other two
Yes.
casts or any other active segment, then you call it a telescope theory.
Because lupus is a pleomorphic disease.
Yes, when there
At
is
the same time, you will have
active and
features of
chronic.
activity, features of chronicity. That's one way how you differentiate an infection-related disease proliferative from lupus class 4.
What is a hematoxin in body? And how it's important? Suppose you see that in the biopsy. How do you
It
look
is-
for it? How does it look like? It's not something what old examiners ask, because now I'm an kidney national big article on that. So
It is one
how
of
does
the
it look?
pathognomonic
Is
features.
it an in vivo, in vitro?
Where do you see it? How does it look like?
It's seen in light microscopy.
Is something engulfing something.
Can I'm not able to recall.
So how would you treat lupus nephritis grossly? Now, US FDA has approved 2 drugs. Which are the ones which are approved now?
Oclosporin and belimumab.
Very good. So would you how would you choose your patients for these therapies? So this lady, suppose a biopsy shows class 4 and she is non-presenting and she's around 35 years. So what therapy would you choose? What is the latest KDIGO say? I mean, you have to use one
Latest
after the other,
KDIGO
or you can
says,
choose between
Urolup-
so many.
We can choose between 4 options. One option is urolupus IV cyclophosphamide. One option is MMF with the glucocorticoids. One option is multi-target regimen, and the other option is either oclosporin or belimumab with glucocorticoids and MMF.
So you can use these drugs upfront, belimumab and voclosporin.
Yes, madam, we can use
Are they
that.
only for induction or they have role in maintenance as well?
Belimumab has a role in maintenance as well. But prolonged duration of 2 years, they have tried belimumab.
So, I mean, given a choice, this patient, class 4, young female, with significant activity, what would you go for?
This patient
I mean,
has
if these drugs were to be available in India at a reasonable price, that won't happen. But out of these, what will you choose?
if she has preserved renal function, then I will go for low dose oclosporin along with glucocorticoids.
We have data. What madam is asked precisely with a lot of regimens, what is the efficacy of each regimen?
What's the long-term outcome, SLE, with therapy? How many go into CKD ESRD? With ELNP, with NIH, with MMF? How many, I mean, what's the long-term data?
Long-term
Voclosporin and belimumab, there is no long-term data as of now.
long-term data are comparable between
What do you mean? How many proceed to CKD? Does CKD occur still in lupus
Yes.
nephritis, even in adequately treated patients?
yes, madam, at 15
So
years.
what's the data with NIH, ELNP and MMF? And what's the Indian data? Do we have any Indian data available?
Yes, madam, Indian data, they have tried.
They means who?
I mean, one publication from PJ Chandigarh was there, which tried IV cyclophosphamide urolupus versus multi-target regimen.
Who was the lead doctor?
Vivek Jasar,
Say once, he was not the lead doctor.
Hazaram,
No, he is membranous person.
Manish Rathi.
Dr. Manish Rathi. So, any study on long-term outcome data? So this was also not a long-term outcome data. Suppose
The
we go to
ARMS
the
trial,
patient-
ARMS trial has long-term outcome data, where mycophenolate was used as induction, and they have continued with mycophenolate maintenance, and they have long-term data which are comparable to.
What are the different trials? ARMS is one. What are the induction trials? And
Induction trials are NIH, urolupus, ARMS. ARMS has both induction and maintenance, multi-target regimen, and LUNAR trial and rituximab trial for
You
rituximab.
would need to mention rituximab in your induction choice at all.
Yes, rituximab is also one of the choice, but
Yeah,
it is usually reserved for refractory groups.
What does
Has-
Critico say
has-
now?
has
Can you
it-
choose it upfront?
Has it been used for induction?
Yes, ma'am, it has been used in lunar trial, lunar and rituximab trial. Rituximab can also be used, ma'am. It is also one of the options.
So how do you go for gonadal preservation when you embark on IV cyclophosphamide regime?
Less dose, I mean, low dose will,
So which females are at more risk for gonadal toxin?
if there is more than 9 gram cumulative, there is oocyte failure, and 18 grams means there is definite infertility.
Older females are more prone, younger females are more
Younger
prone.
females.
Sure. Who has a better ovarian oocyte reserve? Younger or older? Should you take a consent before giving IV cyclophosphamide?
Yes, ma'am.
You take legal you give and the patients use you. So should you take this consent?
I mean, not, if not before all the 6 doses, but at least before starting of the regimen, we should.
And do you advise, like coming back to the first question, what are the oocyte preservation therapies available? What about the rule of G and average analogs? Do you prescribe in your setting? But it's not required, or what is the guideline?
So what are the treatment regimens available? What is their efficacy? Number one question. Number two is how long do you use these immunosuppressive medications? When you want to stop it?
Immunosuppression, according to the new guidelines, should be tried for minimum of 36 months.
It's years. How many years?
3 years minimum, and 1 year should be, disease should be quiescent.
Year, 5.
3 to 5, but one more minimum 3 months, and 1
Minimum
year
3 years.
minimum 3 years, and 1 year the disease should be quiescent. There should be no activity. Patient should be in complete remission for 1 year continuous, and then we can do a histopathology repeat biopsy.
Remission is defined by histopathological remission or clinical remission?
There is both clinical and histopathological remissions. If the activity index is less than 0, then it is histopathological remission.
No, what do you follow? What happens after 3 years, patient doesn't have much proteinuria.
Yes, sir.
Do you consider that remission as remission, wait for 1 year to withdraw the medication?
I'll wait for 1 year.
You do the biopsy?
Biopsy. No, sir, I'll wait for 1 more year. So it is 48 months. Then if the patient, there is any significant toxicity, or if the patient wants to not take the further medicines, then I will do a biopsy. If the activity index is less than 0 and there is no immunoglobulin deposition, then I will start to taper the medicines.
Efficacy is interesting. Lot of protocol, NIH
Yes,
protocol. What is
NIH
induction agents which are used and how much percentage can result in a complete remission? 80%, 90%. Urolupus protocol, what is percentage of remissions? MMF alone, rituximab.
Around
Only the maintenance regimen
around
is
75% is remission rates are seen with both NIH and urolupus. Only thing is NIH has more toxicities.
45% they don't respond.
Yes.
Then what do you do?
Then we can change to another first line regimen, other alternative first line regimen, which is rituximab or MMF based.
Maintenance, which is better.
Maintenance in ARMS trial has showed MMF is better than azathioprine, but maintain trial has showed
Without steroid? With steroid.
with steroid.
Time is done.
What are the prognostic factors when the patient enters you look for, which will show a poor prognosis?
Sir, like to classify as clinical and histopathological. Histopathological will be activity, chronicity index will tell us the prognosis, whereas
Clinical factors, like patient comes in and it gives you a feeling, okay, this is not going to do well.
Dialysis requiring at the presentation, the high serum creatinine, dialysis requiring at presentation.
Dialysis requiring, usually we don't see that. I mean, you say it's totally missed out and directly comes with requiring dialysis. It's not a common scenario which you would encounter in this. This has extra renal features, no?
Yes, sir.
Usually it comes to light. So what are the features which will tell you that it's a poor prognosis? What about the age?
Male gender has poor prognosis.
Yes, male gender, age-wise.
Age-wise, any reproductive age group have a good prognosis, and
That
older
is the
age.
common presentation. Reproductive age females is common. If it presents in pediatrics, pediatric age group or older age, male gender, then you told dialysis requiring, no? If there's a renal failure at presentation, that has a poorer prognosis. Then any higher creatinine. Then
Associated with APLA syndrome.
yes, APLA has a poorer prognosis. Any other laboratory features? Hematological.
There is severe anemia presentation.
Yes, anemia, thrombocytopenia.
Yes. There is TMA picture, ILDH.
Shall we stop, madam?
Yeah,
Yes. Yes. Last before you go, what is the experimental model for lupus arthritis?
So you should try experimental models for all, and any HLD or genetic associations for all. Exam cases, गिने चुने हैं 15, at least उनका मालूम रहना. Okay.
Thank you. Thank you, sir. Thank you, sir. Dr. Santosh and Dr. Thanks.
Thank you.
चाय देते ना
ఏం బ్రేక్ లేదా మంచిది కావాలా
Good morning, examiners.
You're doing a long case or?
Yes, ma'am, I'm doing a long case. So my patient is Mr. Casey. He's a 52-year-old gentleman hailing from Medak district. He's a farmer by occupation. He's married with 3 children and has not received any formal education. Informant is himself and he's reliable. He was admitted on 11th May and was examined by me yesterday. Presenting complaints, he presented with the complaints of generalized swelling of the body since 6 months, shortness of breath since 2 months, oliguria since 1 month, and fever on and off since 2 months. History of presenting illness, patient is a known diabetic and hypertensive. He was diagnosed 3 years back when he went to the local physician for fever and cough, and on routine blood investigations, he was told he has high sugar, and on blood pressure examination, he was told he has high blood pressure, and he was started on a single medication for both, and he's been taking the medication regularly and has had no complications till 6 months back. 6 months ago, patient initially noted swelling of the bilateral lower limbs, which was insidious in onset and gradually progressive, which was splitting in nature and progressed up to mid-thigh and was also involved with the scrotal swelling. Along with that, he also noticed that he developed a facial swelling, which was initially in the periorbital area, more in the morning, and later developed, included the whole face. And also, along with the facial swelling, he noticed that he had swelling of the upper limbs and the abdominal distension. Patient also developed shortness of breath 2 months ago. However, which is NYHA grade 2. However, there was no cough, wheeze, palpitation, chest pains, or orthopnea or PND associated with this. Patient noticed oliguria since last 1 month, which was noticed by the fact that his frequency of urine decreased from 4 to 5 times a day to going to 1 to 2 times a day. On asking a leading question, patient also gave a history of froth in the urine. However, he did not give any history of any cola-colored urine, dark urine, dysuria, flank pain, nocturia, frequency, urgency, or any other symptoms suggestive of lower urinary tract symptoms. Patient complained of fever, which was low grade, intermittent, and decreased on taking medication. He did not give any history of any cough with sputum, any headache, any night sweats, weight loss, any back pain or any other bony pains, rash, joint pain, yellowish discoloration of the eyes or urine, or passage of black tarry stools, or any altered bowel habits, and or any history of blood transfusion. He did not take any NSAIDs or herbal medicines in the last 6 months. On asking leading question, patient gave a history of tingling sensation or burning sensation or bilateral sole in the feet, and also decreased or blurring of vision in the left eye. However, he denies any similar complaint over the hands. He does not give any history of claudication pain, angina, erectile dysfunction, or increase or decrease sweating episodes, constipation or bloating sensation after taking food, or any dizziness or reeling sensation on standing up from sitting positions. For the above mentioned complaints, patient was referred from a local physician saying that he has a kidney problem to a tertiary care hospital. In the tertiary care hospital, he was admitted 1 month ago and he was started on IV medication, after which the swelling decreased. He was told that he has some kidney problem. The exact nature he was not told, and he also underwent a renal biopsy for the same. 3 days, which was the post-procedure, patient did not develop any complications. 3 days later, patient was referred to another hospital, and where he underwent 2 procedures, which seemed like there was a right inguinal lymph node excision surgery and surgery on the iliac crest, which seems like a bone marrow aspiration and biopsy. 5 days post the procedure, patient's family was told that they will need a special treatment in another hospital, and he was discharged with oral medication. Patient was taking the oral medication and he was supposed to go for the other hospital after 1 month. However, 15 days ago, patient developed sudden onset worsening of his symptoms in the form of shortness of breath, cough with pinkish sputum, and decreased urine output. He was again admitted to the tertiary care hospital and he was started on IV medications. At this time, he was also initiated on dialysis via a right IJV non-tunnel catheter. He underwent 2 sessions of dialysis and 1 unit PRBC was transfused during the same, after which patient underwent a second renal biopsy, which was also uneventful. Currently, patient is off hemodialysis for last 3 days. His urine output has improved in the form of he's now again passing 4 times urine per day. His appetite is improved and his shortness of breath has decreased. Past history, patient is a hypertensive and diabetic for last 3 years. And he has had a cataract surgery of the left eye 4 years ago. He has no other significant past history in the form of any serious coronary artery disease, renal stones, or any other significant history. Family history, patient's both parents died, were nil comorbid and died of old age. He is the third of 6 siblings, and none of his family members have any hypertension, diabetes, CKD, or any other significant family history. Personal history, patient takes a mixed diet. He's from low socioeconomic status. His sleep is normal. His appetite initially was decreased, now has become normal. Bowel and bladder have also now currently normal. He's a non-smoker and no alcohol use, and he does not have any high-risk behaviors. Drug history, patient initially for his hypertension and diabetes was on amlodipine 5 and metformin. Currently, he's admitted in the hospital and he's on some medications, including IV medications, the names of which patient does not know. So this is my history now. Should I summarize my history? My patient is a 52-year-old farmer, gentleman, known case of type 2 diabetic and hypertensive for 3 years on a single medication, which was apparently when controlled, symptomatic since last 6 months, with the symptoms of anasarca and oliguria and shortness of breath since last 2 months, with intermittent fever episodes since last 2 months. He has had 2 admissions in the last 1 month. One admission, the first admission, he was controlled with IV medication and underwent a renal biopsy and also 2 procedures suggestive of right inguinal lymph node biopsy and a bone marrow aspiration and biopsy. After 15 days, he was discharged in a hemodynamically stable state. 15 days later from discharge, he was again admitted with worsening of symptoms in the form of oliguria, shortness of breath, and underwent 2 sessions of hemodialysis with 1 session of packed red blood cell transfusion, and another renal biopsy was done 3 days back. Currently, patient is off hemodialysis for last 3 days.
How is his urine output?
Urine output has improved, ma'am. Urine output, he's saying that since last 3-4, he's off dialysis for last 3 days, and he's saying now he's again passing increased urine output of around 4 times.
Finish off your general examination.
Okay. On general examination, my patient was conscious, cooperative, and alert. He's well-oriented to time, place, person. He has decubitus of choice. His weight is 58 kgs, height 167 centimeters, and BMI of 26.4. He currently has a right IJV non-tunnel catheter in situ. Pulse is 82 per minute, regular rhythm, normal volume, normal character, no radiofemoral delay. All peripheral pulses are well fed. His blood pressure was 130/18 right arm supine position. There were and 126/18 the left arm supine position. There was no postural drop after 3 minutes of standing. His respiratory rate was 12 cycles per minute. He was afebrile. On examination, he had pallor present, no icterus, no cyanosis, no clubbing. There was a lymph node present, which was 2 centimeters in the right axillary region, which was a central node, which was firm in consistency. It was mobile. The skin overlying the lymph node was normal. There were no other palpable lymph nodes present in any other areas. He had a significant edema present, which in the first was spitting and was up to the mid thigh, and also scrotal area was involved. His hair is normal. He has periorbital puffiness. His nails are dysmorphic and suggestive of maybe a long-standing fungal infection. In the skin, he has a scar present on the right inguinal region, which is healed by primary intention. He has a tattoo present on the right forearm, and he has a burn marks on the abdomen. He has in the lower limbs, he has decreased hair growth. The lower limbs are shiny. There is a oval depigmented macular lesion with irregular borders present on bilateral lower limbs, a shin area, which is non-scaly and does not have any pruritic marks around it. And there are evidence of healed ulcers on the toe. In the neck, there is a right IJV in situ, and the left neck veins are not normal, not engorged. On systemic examination, GIT patient has a poor dental hygiene. Abdomen is distended, umbilicus is normal in position, inverted, flanks are full bilaterally, shifting dullness is present, no fluid thrill, no organomegaly, bowel sounds are present. In cardiovascular system, patient's apex beat is maintained in 5th intercostal space, medial to mid-clavicular line, S1, S2 is present, there are no additional rubs or murmurs. On respiratory system, basal creps are present on both lower zones, trachea is not shifted. On the central nervous system examination, his higher mental functions are normal. Fundus, left eye was seen post cataract surgery, so there is a fake lens and could not be seen. Right eye, he has vision only up to hand movements and cataract is present. So fundus could not be examined. His motor system are normal, deep tendon reflexes are normal, plantar reflexes are mute, maybe thick skin and is withdrawal. Sensory examination, he has a decreased sensation to touch and pain on bilateral lower limbs, but till the L5, S1 region, vibration sense is diminished in the toe and the ankle region, and joint position senses maintained. This is my examination. Gait is normal.
Did you do urine?
No, ma'am, I have not done
Do you want the urine report?
Yes, ma'am. If possible, I would want the urine report.
2 plus protein RBC 5 per 100.
So it is a significant urine report because 2 plus protein means that he has albuminuria of at least 300 milligram per gram deciliter, and also 5 RBCs in a spun centrifuge urine is also significant, and we will have to evaluate him for both proteinuria as well as hematuria. And I would also like to know if there are any special casts present.
No, negative.
So, ma'am, we'll have to see for proteinuria. We'll have to.
Now with this, can you give us your diagnosis or a differential diagnosis?
Ma'am, a syndromic diagnosis will be.
Syndromic, yes.
A syndromic diagnosis will be, one is adult onset nephrotic syndrome with AKI or acute on chronic kidney disease.
1 minute.
first biopsy you said was done 1 month ago. It was 4 months ago.
Patient care told one.
So that's what I'm getting. The first biopsy was all that was 4 months ago. More than 3.
Your syndromic diagnosis is either a nephrotic syndrome
With AKI or acute on CKD, ma'am. CKD component being he's a diabetic for 3 years. So,
So all diabetics have CKD automatically.
no, ma'am, we are just, we don't know his other parameters. So it can be a diabetic nephropathy or a non-diabetic kidney disease also. Any kidney disease in a long-standing diabetes can be also there.
So what renal syndrome would you put it into?
Syndromic diagnosis.
Because he's symptomatic for 6 months, that is why I have given a diagnosis of acute on CKD, ma'am, because it has already been 6 months since he's having symptoms.
Based on 2 biopsies actually. They have done 2 biopsies. Does it prevent?
acute 1 month back.
Again, he was admitted, ma'am, with acute worsening of symptoms. 15 days back, he was admitted.
The 2 biopsies.
2 biopsies.
Within a short span of 15 days.
1 month, 2 months.
2 months.
Okay. So if it's already 3 months, then
CKD is okay.
you will call it a CKD.
The timeline is a symptomatic patient, more than 3 months, we can take it as a CKD with acute worsening in the current episode.
What do you think is the etiology? You said syndromically, probably we'll go with the acute on CKD.
Okay, you can accept that. So you said if 2 reports of creatinine, high creatinine are available more than 3 months apart, you will call it CKD. But one more thing is that if there was no normal creatinine in between the 2 reports, the patient may have 2 episodes of AKI,
Yes,
and the distance between them may be more than 3 months. So automatically don't say that because that information is not available to you. Anyhow, accept it. Like with fair enough if you say that this is some acute deterioration of an underlying CKD, accept it. What could be the cause of CKD?
ma'am,
With the history you have.
diabetic nephropathy or DKD is one cause because he has other symptoms suggestive of diabetic microvascular involvement in the form of peripheral neuropathy is there and cataracts are there. So both retinopathy could not be evaluated. So because there is peripheral neuropathy, microvascular involvement is there. That is why we can keep diabetic nephropathy as one of the etiology of the CKD.
So you said cataracts are there, therefore you are thinking diabetic nephropathy.
No, ma'am.
So don't say that. Okay, diabetic
You
nephropathy.
have not been able to see the
Fundus, yes.
And you said the other comorbidities are there.
Yes,
And most of the cases of diabetes have nephropathy as the primary renal disease. So okay, accept it. Anything else can be there?
Yes, ma'am. Along with diabetic nephropathy, there can be a superimposed non-diabetic kidney disease also in this patient, ma'am.
Like,
And-
why do you say that?
Ma'am, because he has had sudden worsening. His diabetes was well controlled till 6 months back. He has been going to some physician and he has been taking medicines and he has been told that his sugars are under control, though he has not got any other evaluation done. And he was asymptomatic reasonably well. Only 6 months back, he's been having this problem. So we should also think of some superimposed condition. Also, we should not just keep diabetic
What
nephropathy.
condition? What are you thinking?
Ma'am,
With the available investigations.
Ma'am, with the available investigations of RBCs in the urine, one thing that we should think of is glomerular involvement. And for glomerular involvement, most common in diabetes will be infection in the form of IRGN. That will be, and because he had lymph nodes also, so infection is one possibility. Second is because he's an elderly gentleman, I would like to keep paraproteinemia also as a DD in this case.
What's the definition of elderly? How old is he?
Is 52 months.
All of us are elderly. So see, elderly we should not use. these,
anyone
especially
over-
if you have
Above
examiners.
80, above 80 will be elderly.
Anyone over
You
40.
have it. So for all studies, elderly is what?
60, 65.
Oh,
Anyone over
generally
40, we
65.
should suspect of paraproteinemia. Anyone over 40 with unexplained worsening of creatinine or unexplained kidney damage, we should also think of paraproteinemias.
Yeah, and here you have a history of bone marrow biopsy, which you picked up.
Yes,
Bone
ma'am.
marrow aspiration was done, some lymph node and all that. So, fine, and that is reasonable.
Reasonable.
Okay.
So
Then-
how would you, no, we can go for discussion only when you give us the biopsy report.
So what other investigations would you want?
For this,
Okay, keeping in mind your possibility of an IRGN,
yes, ma'am.
because you said there is RBCs in the urine.
Yes, ma'am.
But usually IRGN, did he have a worsening of, did he have severe hypertension at that point? Was he oliguric?
Oliguria was there, ma'am. Oliguria he is complaining of since last 2 months, the form of decreased frequency, and also he is complaining of fever also, on and off since 2 months. So that
With
is,
the possibility of IRGN in mind, what investigations would you ask?
ma'am, for IRGN, I would like to do some basic blood investigations like complete hemogram to see for the leukocytosis. And I would also like to see for any CUE to see for urine pus cells. And I would like to see a urine culture.
She has given you the urine report.
Pus cells,
No.
not there, okay. Then sometimes they might have pyelonephritis, ma'am. So pus cells may not be present in the urine. So for that, I would like to see a urine culture. I would like to see an ultrasound to see for any obstruction, ma'am, any hydroureteronephrosis, any obstruction, because these the diabetic patients may be prone to papillary
So
necrosis.
IRGN is not only infection restricted to the urinary tract.
Yes, ma'am, it can be anywhere.
So it could be anywhere, okay? But what specific investigations would you ask for? One is to look for the cause of, to look for site of infection. That you need to really do a meticulous workup, okay? What about specific investigations?
Ma'am, because he had a lymph node, like in this case, because he had a lymph node, I would like to go for a chest X-ray to rule out a tuberculosis, ma'am.
Tuberculosis causing an IRGN.
Tuberculosis long.
You said the possibility of IRGN.
Yes, ma'am. Pneumonia, ma'am. Pneumonia also is a
What
possibility.
investigations would you do? Like in the kidney, what are you expecting to see?
Ma'am, in the kidney infection related, if it is a very severe IRGN, they may present as crescents, or there will be just proliferation, ma'am. Neutrophilic exudative endocapillary hypercellularity will be there, ma'am.
So, what investigations would you, is it complement mediated?
Yes, ma'am. Complements will be low, ma'am. C3 will be low in sorry, sir.
ASO, CRP.
ASO and CRP and C3, ma'am. That is, and blood culture, urine culture.
Complement low.
Ma'am, C3 or C3 and C4 both, ma'am.
What would you expect?
Ma'am, if it is an infection, then I would expect C3 to be low, though in some cases C3, C4 both can be low also.
What else can be there with the low complement?
Ma'am, with low complements, you can have autoimmune conditions. So in his case, because this gentleman doesn't look, but he may have an autoimmune condition, which is like SLE, or because he has a history of tattoo. So HCV is a possibility. In cryoglobulinemia, you can have C3 and C4 both low, where C4 will be lower than C3 in that. So cryoglobulinemia also, and that can also present like this.
Any other condition? If you are suspecting IRGN, if you follow these cases, C3 is low.
C3 glomerulopathy, ma'am. Sometimes if the C3 is low for a long time, 12 weeks or more, then we should also suspect a C3 glomerulopathy, ma'am, in these cases.
Why do you think that?
So we'll have a biopsy report and then hand over to.
Okay, so biopsy report is MPG and C3G.
So biopsy report is MPG and C3GN. Then I will have to divide this as in C3 glomerulopathy, because MPGN can be divided into immune complex mediated and C3 mediated. So in C3 mediated, we can have C3 glomerulopathy or a dense deposit disease. For that, for dense deposit disease, we'll have to have an EM to see for the dense deposit disease. In C3 glomerulopathy, We have to rule out any paraproteinemia which is causing C3 glomerulopathy or
C3 glomerulonephritis.
C3 glomerulonephritis
So either it is C3 glomerulonephritis or a DDT.
or a DDT. Yes.
C3 glomerulonephritis, you will look for infection.
Infections,
You will-
autoimmune, and paraproteins.
and malignancy.
Histological pattern in a light microscopy, they may have MPGN, which will be PAS positive and silver negative, ma'am. And in EM, we have to see what is the deposits. So if case it is a small unorganized, we'll have to see the size of the deposits, ma'am. If it is an amyloid, like in this case, it may be a possibility. It will be a small 5 to 10 nanometer size unorganized deposit.
Before you go to EM, any other findings on LM would you want to know with the differentials you have thought?
Ma'am, in LM, if we are thinking amyloid, then it will be Congo red positive, ma'am. So we'll have to do a Congo red staining, and in LM, the
How
Congo.
common is mituria in an amyloid? I mean, what is the typical presentation of amyloid?
Ma'am, mainly long-standing amyloid can be primary or secondary, and they mainly
How do they present?
What
Usually,
syndrome it presents with?
Usually-
Syndrome, what is present with?
if there is a nephrotic presentation,
syndrome.
especially in an elderly, so the first diagnosis in an elderly nephrotic, you think of amyloid. So
Amyloid.
usually they will have a nephrotic.
nephrotic presentation, ma'am. And one of the paraproteinemias is present as nephrotic syndrome.
So what other things you look for in
Um,
LM?
Ma'am, if it is infection related, then we can see for any neutrophilic. If it is infection related, we can see for ma'am any endocapillary capillary hypercellularity. If it is immune, if it is not sure.
Santosh and I think they tell you what now.
Adult onset nephrotic syndrome, what are the different etiologies?
Yes, sir. So adult.
That was your first diagnosis, right? What are the
Yes.
etiologies?
So the most common cause of adult onset nephrotic syndrome worldwide and in India is diabetic nephropathy. Otherwise, it can be podocytopathy, which can be primary or secondary. Secondary is most common in adults, so we'll have to rule out any malignancies. Malignancies can present as nephrotic syndrome. So it can be secondary podocytopathy like membranous or minimal change disease.
Diabetic, I agree, diabetes. What are the other causes?
Other causes can be, sir, primary podocytopathies. Sometimes minimal change disease can
Minimal change disease.
Then, sir, it can be membranous. Membranous may be secondary to some solid organ malignancies.
Okay, membranous. Then minimal change, membranous, diabetes.
Then, sir, as I said, paraproteinemias like amyloidosis can come with nephrotic syndrome, sir.
Okay. So diabetes, MCD, FS. What about FSGS?
FSGS also can present, sir. FSGS.
Membranous. Then one more.
Minimal change, membranous, FSGS, and
which this patient has got pattern wise.
So IRG and C3 glomerulopathies can. MPGN pattern.
I'm just talking about the pattern.
Yes, sir.
Any other systemic disease which can cause nephrotic syndrome?
So lupus can come as a nephrotic syndrome. Class 5 lupus can present.
No, if I ask for 6 common causes which present as nephrotic, you told diabetes, MCD, FSGS, membranous, MPGN. One more classically presenting as nephrotic syndrome. Systemic, it can have systemic involvement. It presents with low blood pressure.
Amyloidosis can present with
Amyloidosis.
low, amyloidosis can present
Amyloidosis.
with low BPS.
Yes. So all the other things will come as a
I think this case, the fact that the difference, the time between the first and second biopsies is more than 3 months, and now the patient is on dialysis, I think it is more towards CKD.
Ma'am,
Not the
patient underwent dialysis 2 times, ma'am. But our last 3 days and with blood transfusion, but last 3 days he's not received any dialysis and his urine output has improved, ma'am.
So you say nephrotic progressing to CKD.
Yes.
CKD you can call,
CKD, yes, ma'am.
not ESRD.
Not ESRD, yes, ma'am.
in a immune, in an infection related GN, can patient have nephrotic syndrome?
Yes, sir. Patients can present with nephrotic syndrome in IRGN.
In which
especially-
situation? Which situation?
Sir, if it is a crescentric.
Presentic will have nephrotic.
No, crescentric will more likely come with acute symptoms. IRGN can present with nephrotic, but instance I don't know.
what percentage of patients during the acute IRGN, what percentage of patients can have nephrotic range proteinuria? I think that's what he wants to know.
10 to 20, but I'm not much sure.
Yeah, they're almost right.
And which are the infections which will commonly, which may come with nephrotic syndrome?
For LRTI, skin infections.
Infective
Yes, sir.
endocarditis,
Yes, sir.
visceral abscess, shunt nephritis. These are classically described that those chronic type of infections. Acute nephritis, what is the differential? Apart from post-infectious, what are the other things you look for?
So one is C3 glomerulonephritis. In case we are suspecting and then the complements remain low for more than 12 weeks, then C3 glomerulonephritis we should also keep in mind. And other than that will be deposition disease. Sometimes they may also present with low C3. So
No, acute nephritis, I'm asking differentials.
Acute nephritis can be, sir.
Which are the infections? Apart from streptococcal, which are the other infections which can?
Staphylococcus can also, sir. Nowadays they are saying in elderly diabetics, staphylococcus is more.
Yeah, staphylococcus. Then
sugar negative.
Patient has had 2 biopsies.
Yes, ma'am.
3 biopsies if you count the lymph node and you didn't ask for the report.
Yeah, that report's also required, no, for you to put everything together and tell us.
Yes. So lymph node and bone
It's
marrow.
follicular lymphoma.
So that can also actually come as MPGN pattern. Lymphoma can present as MPGN pattern, and that nephrotic syndrome can be because of secondary podocytopathy. Like lymphoma can be, if it is NHL, FSGS can be there, or sometimes solid organ lymphoma can also be because of membranous. Membranous can also come. So even maybe nephrotic syndrome is secondary to lymphoma only.
Is it solid? Usually lymphomas are associated with?
Ma'am, it depends on Hodgkin's, non-Hodgkin's, or solid organ lymphomas. Hodgkin's lymphoma is associated with mostly FSGS. Non-Hodgkin's lymphoma is associated with minimal change, and solid organ lymphomas are associated with membranous, secondary membranous.
So what about the renal biopsy report, second one?
Second one is again MPGN, the chronicity.
Ma'am, that may be because patient has not yet started the treatment. He was told to go to MNJ hospital for treatment, but he has got a later date. He was supposed to go at the end of this month. So maybe the chronicity, maybe because of the lack of the treatment has not yet been started for him, ma'am, and he's been symptomatic for last 6 months.
Early chronicity, so some this thing, but in between, yeah, so what I was asking you was like, in that light microscopy, I said CPG and NPG, that's what they reported. So before you label it as CPG, would you ask for something else? What is the role of pronase ligation? What is it?
Ma'am, pronase digestion is to see for the cryptogenic epitopes. So sometimes, especially in a case of proliferative glomerulonephritis with monoclonal immunodense deposit diseases, you may not get to see the IF restriction, lambda restriction, or restriction may not be seen. So if you do a pronase digestion, these epitopes which are hidden will come up, and then you'll be able to see the restriction pattern, ma'am. So that will help you in diagnosing. So that is why sometimes, like in MPG, masked, yes, ma'am, proliferative glomerulonephritis.
I have also asked for restriction. Did the biopsy show any light chain restriction or what? So just have kappa. Number is not there. So
Ma'am,
other investigations you can ask. When you know, like we give you MPG and there is a
light chain
lymphoma,
restriction.
NHL, kappa restriction.
Then, ma'am, whether he, because of the light chain restriction, whether he has developed any cast nephropathy or whether Fanconi's syndrome he has developed or not, we have to rule that out.
Any of the presentation was not like that. Biopsy showed MPG.
Then,
What all? Suppose I mean, you also suspected paraproteinemia. What other investigations would you like to have?
ma'am, serum protein electrophoresis, serum immune fixation electrophoresis, and serum free light chain assay.
Free light chain assay didn't show anything, and the protein electrophoresis, it was an abnormal pattern, but no clear-cut impact.
Then, ma'am, serum immune fixation electrophoresis. And apart from that, we can do a bone marrow to see for any plasma cells in the bone marrow to see whether it is multiple myeloma, not more than 10% plasma cells.
Bone marrow was negative for multiple myeloma.
So then, ma'am, most probably then it's a monoclonal gammopathy of renal significance.
How do you define that?
Ma'am, if the plasma cells are less than 10% and there is no myeloma defining event in the form of hypercalcemia, renal abnormalities, anemia, or bony involvement, but there is a renal involvement, then we will call it as a monoclonal gammopathy of renal significance. Only renal involvement, ma'am.
So do you think that lymphoma has something to do with it? NHL, follicular?
Yes, ma'am. Lymphoma can actually either, there are different ways in which the cancer can affect the kidney. One is direct infiltration, which is very rare. Then other is, ma'am, this MPGN pattern. It can come as MPGN pattern deposition disease. And the third is it can cause podocytopathies, which can cause this nephrotic syndrome like presentation.
Dr. Santosh, over to you. You are there, right?
Yeah, just a couple of questions. You said this patient had healed ulcers in the feet.
Yes, yes, sir.
Yeah, so what's the duration of those ulcers?
Sir, exactly he was not saying, but he's a farmer. He does, he walks barefoot. He had thick soles. So he said that there are, for last 1 year, he's been noticing he has some small ulcers and they take long time to heal, but they were healed only, sir. So almost 1 year he has noticed ulcers, and there was also diabetic skin changes also, sir, over the shin in the form of look like diabetic dermopathy, sir.
Okay, so you aren't thinking of cryoglobulinic foot changes and ulcers?
He had actually, sir, a history of tattoo in the childhood, and because there was a tattoo and because he had a sudden onset nephrotic syndrome, and since madam said complements are low, that is why I thought of maybe cryoglobulinic also as a possibility.
That's a good answer. What percentage of cryoglobulinemia causes glomerular nephritis? Presence as glomerular nephritis?
So 20%.
A little less than that, about 15%, and nephrotic syndrome presentation is about 22%, a little more than 20%. And some people may, over 10% can even present straight as CKD without a problem. So how will you diagnose cryoglobulinemia in this patient? Your clinical clues you said was C3 and C4 were low,
yes, sir.
and C4 lower than C3 being low.
So we can check for serum cryoglobin levels in this serum. Only thing is that we have to make sure that the serum samples that are sent are sent at a maintained temperature of 37 degrees or more. So that is one way in which we can check for serum cryoglobins. Another thing is we have to check for any cause of cryoglobinemia like HCV. So we have to check for serum HCV and the HCV viral RNA titers to see whether he has any cryoglobinemia. And also sometimes in the biopsy we can get cryoglobinemic deposits in the LM.
So what does it look like on LEM? Your answer is correct partially. So what do you see? How will you say is cryoglobinemia when you have an MPGN pattern? What will make you think of cryoglobinemia?
Sir, if you have an MPGN pattern which is PAS negative and silver positive, no, silver negative, PAS negative.
No,
and silver.
you said something about deposits. Now you're going away from that answer.
Cryoglobin deposits will be seen, sir, as a collection, eosinophilic pale collection, sir.
Yeah, pale acellular large clumps will be present. You can't miss it. If you've seen it, you can't miss it. Okay, so this patient had his final biopsy was C3GN. How will you treat C3GN?
So for C3GN treatment, we have to we have to see for sometimes because of IRGN also C3 may be low. So we have to look for any source of infection, and we have to wait for 12 weeks to see if the C3 levels are going down or not. If they are not going down and there is no source of infection, and on EM also there is deposits, then we can.
If they are not going down, they are not coming back to normal.
Okay. Sorry. So then we will term it as a C3 glomerulonephritis, and we may try immunosuppression, sir. If the patient can receive immunosuppression after ruling out any infections in the form of any chest X-ray, MAN2, there is no TB, then we can try for immunosuppression, sir, either in the form of steroids or maybe rituximab.
Just monotherapy with steroids, right?
Yes, sir.
Monotherapy with steroids. You don't want to give any antiproliferative agents.
No, steroids and some other these things are like MMF can be right.
MMF or
rituximab
has been tried.
Yes, sir.
Cyclophosphamide has not been tried.
It can be tried. I'm not aware of any trials. Cyclophosphamide can be given, sir. We give for some patients.
So which pathway of complement is involved in C3G?
The alternate pathways involved in C3 glomerulonephritis. So
which are the other pathways?
Sir, classical pathway is there, and mannose binding lectin pathway is there, sir.
So if you have a lectin pathway involvement, what will you get? What glomerulopathy will get?
I think IRGN or IgA they say is now being associated with mannose binding lectin pathways, IgA nephropathy. That is why they are trying some medications for against.
Now there's a rarer glomerulopathy which is similar to C3. Triple D is there, C3G, like the same pattern will be there, but the glomerulopathy.
Collagenofibrotic.
C4 glomerulopathy.
Yes, I've heard, sir. C4 glomerulopathy. I've not.
So what will be the difference there?
So C4 will be persistently low, and the classical pathway will be activated. But I've never seen, sir, that case. I mean, I've read it, but I've not seen that case.
No, as differentiating from C3 on the biopsy.
The deposits may not be. Dense deposits may not be there in the.
No, it will be pattern will be dense deposit disease only.
I'm not sure.
What is the long-term prognosis of C3?
Long-term prognosis is not
Or
good.
if it is not, if it is not, there is no malignancy, say. If there is, then you treat the malignancy.
Ma'am,
Otherwise-
still 50% may go to ESKD, ma'am. Even with the treatment with immunosuppression also, long-term prognosis is not good. More than 50% may go to ESKD and require renal replacement therapy.
Within
1 year, ma'am, maybe 1 year within.
In this case, what do you think? MPGN is due to what?
So most probably it is malignancy related only, sir. More malignancy related MPGN pattern with nephrotic syndrome. So maybe dense deposition disease, sir. For that we have to do an EM. Whether EM was done now for because lambda restriction is there, so maybe a light chain.
How does malignancy relate to deposition disease? Here already Madam told NHL is there. It's a milder variety. Does it associated with deposition disease?
So mostly myeloma is associated with the deposition diseases. NHL, but in this case, since he's having an
This inguinal biopsy was done that showed lymph node biopsy shows NHL.
yes, sir.
Any other lesions are removed? Any other area you have lymph nodes?
Sir, he has a lymph node in the axillary area, sir.
Multiple or
One lymph node which is 2 centimeter in the central group, and it is firm and mobile, but no other lymph nodes. I checked thoroughly; there were no other lymph nodes present.
So how do you manage this patient? Then do you connect this NHL and kidney involvement together, or that is separate?
No, sir.
And he is also diabetic. Huh?
Yes, sir.
Any diabetic changes are there?
No biopsy.
No,
Madam,
but we don't know
examiner,
EM has been sent. EM awaited.
No biopsy
You are the
findings.
student, madam is examiner.
Biopsy findings I didn't know, sir.
So
So
biopsy finding she doesn't know, she's asking biopsy finding. So EM as of now awaited, so we don't know, we cannot totally exclude that.
So, sir, the approach to this patient will be multi-pronged. One is his diabetes control. So, for diabetes control, we'll have
Is there
to.
any link between all this? Diabetes is there, NHL is there, and you are saying MPGN is there, non-diabetic kidney disease is there. So, holistically, how do you address this problem and how do you manage this patient?
Sir, a multi-pronged approach to management of the patient. We'll have to manage his diabetes and we'll have to manage his malignancy. Because malignancy, if we treat the malignancy, most probably if it is because if the kidney
Diabetes, how
disease,
many duration? How much?
3 years duration, sir, but he already has signs of peripheral neuropathy. And
Do you
that,
think that no kidney involvement is there because of diabetes?
sir, I think kidney involvement should be there because of diabetes because he already has peripheral neuropathy. So kidney involvement may be there, and also many diabetes may have kidney involvement. We don't know his blood sugar control.
I don't think you should say kidney involvement should be there.
No, may be there.
Or not all diabetics will have renal involvement.
No.
If they have peripheral neuropathy or some other traffic.
Maybe there.
Maybe there. You can't categorically say it will be there. Right? And she says, Ellen, there is nothing to suggest.
Any GBM thickening?
What will EM show?
Ma'am, EM, there are different classes for EM. The class 1 is GBM thickening, ma'am, more than 395 in females and more than 430 in males over the age of 9 years. Then class 2 is mesangial expansion, mild or moderate, less than 25%, more than 25%. Class 3 is Kimmelstein-Wilson nodule, and class 4 is diffuse global glomerulosclerosis. So because he does not have LM findings in the form of mesangial, so maybe even if he has, he may have only class 1, which is GBM thickening.
KW lesion is an LM finding, no?
Yes, ma'am. So
I specifically asked you, what do you find in EM? So EM, this last glomerulosclerosis,
EM
KW lesion and all this LM finding.
EM finding only thickening,
Basement
basement membrane thickening.
How do you compare the thickness of the basement membrane like microscope?
With the adjacent capillary loop, sir, it should be 20.
What is thickened GBM means what? How do you compare? Some comparison should be there.
We compare it with the in the light microscopy. We compared it with the tubule, sir. Tubule. It should be less than the thickness of the tubule. If it is
Tubule
more,
total or tubular basement?
tubular basement membrane, sir.
If it is more than that, thickened membrane.
Thickened. That's gross.
Okay, there's no diabetic involvement. Only MPGN is there. Then how do you address that? And some NHL is also there.
So we have to first treat the cause of the NHL, sir, follicular lymphoma. So we will give him chemotherapy
Does
based.
all NHL requires treatment, or you can just
He's a symptomatic case, so
with what?
he has kidney involvement and things.
But you are not associating, no? Are you sure that kidney involvement is due to only NHL?
His restriction was there in IF, sir. Lambda restriction was there in IF. So that is why I'm assuming that kidney involvement may be there.
Kappa restriction.
Kappa restriction was there in IF, sir. So.
What are some of the latest anti-cancer drugs with the renal toxicities that's going to? As a nephrologist, you should be aware of. Can you need some immune checkpoint?
Immune checkpoint.
And the renal toxicities, because now starting him on some drugs may land may add to, apart from leakage, glomerulonephritis as well.
Yes,
So then you need some anti-malignancy drugs
Yes,
which cause glomerulonephritis.
ma'am, one is immune checkpoint inhibitors. The name I don't know, but it can cause hypercalcemia and it can cause AKI, ATN and AKI. ma'am.
Gene, vasculitis,
Uh,
like picture.
Lenalidomide, thalidomide, lenalidomide can cause.
It's an immune checkpoint inhibitor. What are the immune checkpoint inhibitors?
Name I don't know.
Dr. Bhushan has presented a component to conference. So you should know what your
Name I don't remember.
Which is the most diagnostic histological lesion in diabetes?
Kimmelstein Wilson, not even know.
Yeah, there are some differences like what? Pathognomonic.
Thick and G. Membranous.
I
Diffuse
don't think nowadays.
So you mentioned the glomerular histology. What are the tubular histological lesions? Just ask.
in diabetes, ma'am. They may have AIN.
So what is harmony Epstein?
Drops, hyaline drop and capsular drop. Capsular drop may be seen in diabetes.
The tubular
Drop, Karyorix is
There are
no, light. Tubular drop, capsular drop, and one more was there.
tubular cap capsular drop or in the glomerular. Tubular
Have you heard of harmony Epstein lesion? That is the pathognomonic interstitial lesion in diabetes.
This patient was on a single drug for hypertension and sugar. What drug that could have been?
Ma'am, I asked the patient, it is amlodipine and metformin for him. Sorry, that if it was a single drug, then it can be SGLT2 inhibitor. But he was
Dr. Sandhu, Dr. Prabhu.
Those I think he wants to leave early. 12:20 has some other meeting. He will leave by 12:20. So we can ask.
Santosh, I think you'll be leaving early, I heard.
So we can.
No, I'll just go and come. I have another meeting now. I'll just go and come.
So we can.
Okay.
Dr. Prabhu.
This malignancies, what are the different ways in which can affect the kidney?
Sir, it can kidney can be affected in various ways. One is the direct infiltration of the malignant cells into the kidney, leading to obstruction. Or secondly, it can sometimes cause
Direct invasion will always lead to obstruction. You said the infiltration.
direct infiltration. Not always. Not always, ma'am. But it can directly invade the kidney malignant cells, or it can lead to a secondary podocytopathy, sir. in the form of membranous nephropathy or MCD or FSGS, or it can also cause deposition. Light chain cast nephropathy can be there, sir. So tubulopathies can be there in the form of light chain cast nephropathy or Fanconi syndrome.
Shall I tell you how you should answer this? When you're asked, you be very specific. Have in your mind some classification. You said due to disease itself, due to the treatment that is given for the disease. So like that, then you'll get some answers. The disease itself, you said direct infiltration.
Yes,
Then it can cause obstruction.
yes, ma'am. Then it can affect the glomeruli. In the glomeruli, podocytopathy can be there. Secondary podocytopathies. Then it can involve the tubules, ma'am, in the form of cast nephropathy or Fanconi syndrome. Then it can
Any electrolyte abnormalities?
yes, sir. Fanconi's can be there, sir. Fanconi syndrome.
So any electrolyte abnormalities can affect the kidney.
Calcium, sir. Hypercalcemia. Hypercalcemia can lead to a pre-renal AKI, sir.
It is the commonest case.
So go
Then
for
Then-
tubular vessel, tubular interstitium like that. So the vascular,
Vascular
that's not the previous case. that we-
TMA can be there, sir, ma'am, in vascular process.
And drug induced?
Drug use, checkpoint inhibitors are there that can lead to AKI-18, and also some other chemotherapeutic drugs like
It may be nephrotoxicity or due to destruction of cells. What will happen?
tumor lysis syndrome can happen, sir. So tumor lysis syndrome can also lead to electrolyte
This is
imbalance.
the classical described. Other things are later on. Which other drugs can cause, especially in myeloma, it's very common to get the patients with AKI due to any other drugs?
What is on? Melphalan or lenalidomide.
NSAID induced. Almost 25-30% AKI is due to NSAIDs in myeloma.
When do you use the term tumor lysis? Or it's just loose term?
No, ma'am, you have a specific criteria for tumor lysis. It can be
Criteria and what are they?
international staging. I'm not name. So there has to be potassium more than 6.5, phosphate more than 4.5, hypocalcemia, and hyperuricemia more than 7, uric acid more than 7. And there should be a history, clinical history of either taking treatment for malignancy, or there should be a very high load of tumor in the blood, high levels of tumor in the blood.
Is it common with this? Suppose we give him chemotherapy. Do
He,
you think
ma'am, lymphomas, we'll have to see what is his tumor burden. So after that, if we give him chemotherapy, we have to make sure that hydration is proper. We have to give him a proper hydration, at least 3 liters of fluid per day. And we'll have to give him some kind of uric acid inhibitor in the form of either febuxostat or rasburicase.
what are the indications of these? Allopurinol versus febuxostat versus rasburicase in prevention and treatment. What's the difference between uric acid, febuxostat, allopurinol, and rasburicase?
Ma'am, allopurinol, they say it is not recommended because if the patient has a renal problem, then allopurinol should not be given. And allopurinol works on only preventing the further formation of uric acid. Whatever uric acid is formed, it will not act on that. So, and it may cause crystal problems. So, we give febuxostat and rasburicase, ma'am.
So febuxostat, how does it act? Does it act on the reformed uric acid?
Xanthine oxidase inhibitor, ma'am. So it will act on preventing the further formation of uric acid. And for
So what does allopurinol do? Where does it act? What does it do? To both act on xanthine oxidase?
one allopurinol.
What's the dose? Rasburicase is available?
Yes,
How
ma'am.
much dose?
Rasburicase is available.
And what's the problem with rasburicase?
We have to give more hydration, ma'am. Hydration should be maintained if you are giving raspberry kiss.
Does it have any, I mean, some instruction about the uric acid monitoring subsequent to raspberry kiss? Is it used for prevention or treatment, raspberry kiss?
Ma'am, prevention, because I think it acts also on the uric acid that is not formed. It prevents the formation of.
Both are can lead a good
Yes. Thank you.
So, thank you.
Thank you, ma'am. Thank you, sir. You will present 2 short cases, madam. Short. Half an hour.
Good afternoon, ma'am. Good afternoon, sir.
Professor,
Good afternoon, everyone. Shall I start, ma'am?
Dr. Ravinder is there.
is there?
Yeah, shall I start?
Yes.
Yeah, my patient, 24-year-old male patient named Shiva Kumar. He is presently admitted in Usmania Hospital on 16th of May and he was examined on 20th of May. He is a resident of Jahirabad. Presently, he has been admitted with chief complaint of left lower limb swelling from groin to ankle heel from 1 week, left lower limb pain from 1 week, low grade fever from 1 week. I would like to date back my history 4 years before. So 4 years before, patient had bipedal edema and facial puffiness for 20 days with frothing in the urine. So patient was evaluated by local physician and he was told to have some protein leak in the urine and he was referred to tertiary care hospital 4 years before from Jahirabad. Patient patient was referred to Usmania. Patient got admitted in Usmania hospital in 2018 and he was admitted for 2 weeks. Their battery of test was done. 24-hour urine protein test was done, but he is not able to recall. He was told to have normal renal function, but there is some protein leak in the urine, and he required renal biopsy. Left-sided renal biopsy was done, but he doesn't recall the report. And after renal biopsy, he was started on Visolone tablet. He remembers the name of the tablet to be Visolone. He gives history that initially he was started on high dose tablet and he was told to continue that high dose for 4 to 6 weeks, followed by tapering of the dose. And he remembers that he took treatment for around 4 to 6 months. As per the patient, he responded to treatment within 10 days of starting steroid. And he stopped treatment as advised by the doctor. He was following up irregularly in Usmania. In between, in these last 4 years, patient had almost every year 4 to 5 relapse per year. And every time he used to respond to steroid. Every time the relapse used to be preceded with cold and cough. Around 3 to 4 days before the relapse, he used to have cough and cold, followed by that he used to have relapse. So in view of frequent relapse, in view of most likely frequently relapsing disease, he was told to that he required some costly drug and he remembers the name of the drug and he was started on tacrolimus 2.5 mg BD in Jan or Feb 2020. But he tells that due to financial issue, he was not compliant to treatment and from last 6 months, he has totally stopped treatment. So from last 6 months, he is not taking tacrolimus and Visolone. He tells that after taking tacrolimus and Visolone, whenever he used to take, he used to be in remission, and in between he was non-compliant and he used to get relapse. Now presently, patient is admitted in hospital, Usmania hospital, for left lower limb swelling from groin to ankle, left lower limb pain, and on and off fever from 1 week. There is proturia is present. There is mild facial puffiness is also there. There is no history of hematuria, dysuria, loin pain, flank pain. There is no history of cold, cough, expectoration before the symptoms. There is no use of any alternate medication, diuretics or NSAID abuse. Coming to past history, there is no history of diabetes, hypertension, TB and asthma. Coming to personal history, he is having mixed diet, non-smoker and non-alcoholic. treatment history, as previously mentioned, he was on steroid and he took tacrolimus on and off, non-compliant to treatment because of financial issue. After admission, he tells that he underwent some lower limb ultrasound, and after that, he has been started on some injections. Most likely, it may be an anticoagulation. And coming to family history, sir, he is born out of a third degree consanguineous marriage. He is third in order. He is having 4 brothers and 1 sister. All are having no renal issue. None of the family member is having hypertension, diabetes in the family. Shall I summarize now? So summary, 24-year-old male patient, a case of adult onset nephrotic syndrome, steroid sensitive, frequently relapsing, started on steroid sparing drug, that is CNI tacrolimus. In view of financial constraint, he is non-compliant to treatment, and presently he has been admitted with relapse of nephrotic syndrome with suspected left lower limb deep venous thrombosis. So my provisional.
Ravinder sir.
Hello.
Yes, sir.
Yes.
So, what are the causes of your diagnosis? Is nephrotic syndrome, adult onset nephrotic syndrome with a deep vein thrombosis.
Yeah, frequently relapsing nephrotic syndrome, steroid sensitive, started on steroid sparing drug, non-compliance to treatment, presently admitted with relapse of nephrotic syndrome with most likely left lower limb deep venous thrombosis.
So presently is in relapse with and he has got a thrombotic manifestation.
Yes, sir. Yes, sir.
So what is the etiology of the nephrotic syndrome?
Sir, the etiology, it may be adult onset nephrotic syndrome. Since the patient has come with thrombotic tendency, my first differential diagnosis will be membranous nephropathy. Down the order, it will be minimal change disease, focal segmental glomerulosclerosis, and it may be IgA nephropathy down the list.
But this terminology you are applying, like frequently relapsing.
Yes, sir.
This is applied to membranous or what?
No, but the terminology has been given to primary podocytopathy. So the relapsing and all this terminology, actually it was built for primary podocytopathy, minimal change disease and focal segmental glomerulosclerosis.
Yes. Do you think membranous will respond to steroids? That too so fast.
Usually membranous nephropathy, it is told that it is not to be treated with single drug. Always it has to be treated with some other drug along with steroid.
Yes. So how fast he has responded to the steroids?
He tells that whenever he used to take steroid, within 10 to 12 days, he used to respond to the treatment, sir.
So this kind of response within 2 weeks is typical of?
It is typical of minimal change disease, sir. Early responders.
Yes. So that would be the first, even though it's adult onset, since the response is so fast. I think the first diagnosis putting membranous for a person who responds to steroids within 12 days.
Will be less than
do you want to continue with membranous or?
Yeah, now since the patient has come with thrombotic tendency, that's why I kept it in the first, but now I will the differential diagnosis will be podocytopathy, most likely minimal change, followed by focal segmental glomerulosclerosis. Down the list will be membranous and IgA nephropathy.
So thrombotic tendency, you say, is an indicator of the etiology? Like if a nephrotic comes with thrombosis, it indicates it's membranous, is it?
No, sir, it does not indicate membranous, but among the podocytopathies and nephrotic syndrome, membranous has more tendency to go for thrombosis.
Why?
Because the loss of anticoagulant like antithrombin 3, protein C, protein S, it is more in membranous compared to other podocytopathy.
Why should it be that?
Because the deposits are subepithelial deposits in membranous. Because of the other in MCD and FSGS, there is no deposit. There is simply because of some soluble factors, there is simply effacement of the food process. As such, there is no subepithelial deposits. But in membranous, there is typical subepithelial deposits. Because of these deposits, the loss of antithrombin 3 protein C proteinase, it is more. Exact mechanism is not known, but mostly it is because of subepithelial deposits, which has led to some configurational changes. Because of this, there is more loss of this anti-clotting factors.
Okay, so there is loss of clotting factors, which is be there in all nephrotic syndrome.
Yes, sir. Yeah.
And it's a predilection to the syndrome itself. And the diagnosis, making a diagnosis based that this person has a DVT to put it as membranous, I don't think so.
Yes, sir. Yes, sir.
It's a biopsy diagnosis. Okay.
Yes, yes, sir.
So since it's an adult, you want to favor MCD or FSGS?
Since the patient is just 24-year-old, he's a young patient, but the way he has responded to steroid within 10 days, I would like to keep MCD ahead of FSGS, sir, since he's an
Okay.
early responder.
So FSGS, when will you think of?
FSGS, usually the patient comes in adulthood, and it will also have similar FSGS. It is like primary and secondary FSGS. When the patient comes with nephrotic syndrome, it is most likely primary FSGS. If the patient is having nephrotic to subnephrotic range proteinuria, it will be a secondary FSGS. That is totally different. But the patient age is more than 20, then we think more of FSGS, and the patient is below 60, 20 to 60. And
What are the
patient,
features? What are the features which will make you think that it may be FSGS apart from the age?
in children, steroid-resistant nephrotic syndrome, always we have to think of FSGS.
Okay.
And
So
below 1
steroid
year,
resistant.
below
Okay,
1 year
steroid
of
resistant.
yeah.
Okay, steroid resistant. Older the age, more likely FSGS. Steroid resistant. Then what else?
Less than 1 year, always we have to think of FSGS.
Less than 1 year.
Yeah. If the patient, because typically MCD presents are between 2 to 7 years. So if the patient is having nephrotic syndrome in less than 1 year, infantile and congenital and infantile nephrotic syndrome, we have to think of FSGS.
Genetic causes.
And genetic
You
causes.
want to tell genetic causes,
Yeah,
not the pattern.
Yeah.
The genetic causes are more likely the younger the age.
And positive family history.
So apart from age and the non-response or a late response to the steroids, what are the other features which would point towards
Whenever
FSGS?
the patient comes with hypertension and deranged renal function, microscopic hematuria, that goes against minimal change disease.
So hypertension and renal failure would point you towards
1/3 of the FSGS, they can have
FSGS.
microscopic hematuria and they can have hypertension in the beginning or deranged renal function in the beginning. 1/3 of FSGS.
What percentage of patients of minimal change can have hematuria?
Less than 10%, ma'am. Less than 10%, they can have atypical features like hypertension or microscopic hematuria. Less than 10% of the MCD can have.
Okay, you told primary and secondary. What are the differentiating features for primary and secondary?
Pardon, for primary and secondary,
FSGS.
Primary FSGS, they usually comes with nephrotic syndrome. Whereas secondary FSGS, it usually comes with nephrotic to subnephrotic proteinuria. It doesn't present as with nephrotic syndrome. And it may be adaptive, like most likely secondary FSGS, like in Columbia classification, we have NOS type, which can be both primary or secondary. Collapsing type, which is usually secondary FSGS. Perihilar, which is usually secondary FSGS. Tip lesion, usually primary FSGS. Cellular FSGS, which is usually primary. So whenever there is adaptive FSGS, it is most likely secondary FSGS, like hyperfiltration injury, or patient has underwent some nephrectomy. So most likely it is a maladaptive FSGS.
What else will favor the presence of secondary FSGS apart from the fact that you differentiated based on nephrotic syndrome versus nephrotic range proteinuria? What else favors the presence of secondary FSGS? What else makes you suspect?
Clinically or sir, on biopsy?
You have to tell me.
Sir, clinically nephrotic syndrome and this one hypertension or renal artery stenosis or any vesico-ureteric reflex or any history of CKD of any other disease, it will most likely favor secondary FSGS, sir.
So in one word, if I have to tell, what is it? You told reflux, renal artery stenosis. Renal artery stenosis.
Any
Okay.
kidney disease can have secondary FSGS, sir. Any other kidney disease can have secondary FSGS. That is
Due to?
clinical. Yeah.
Due to what?
Due to any glomerular disease, because of because of the glomerular sclerosis.
Why the FSGS develops?
Because of the glomerular sclerosis, the remaining glomeruli, they have to go for hyperfiltration injury. Because of the hyperfiltration injury, they will
Nephron
get
loss. You have to tell nephron loss.
Nephron loss.
So whenever there is a nephron loss, then the secondary FSGS can develop in the other nephrons.
Yes, sir.
The remnant nephrons. So nephron loss may be a surgical, a nephrectomy or some diseases which lead to nephron loss, like your reflux and all that. So those can cause. Then what are the other features which tell you that there is a secondary FSGS? Yes.
On biopsy, whenever there is perihilar variant, it is most likely secondary FSGS. Whenever there is collapsing variant, it is secondary FSGS. And the other remaining glomeruli, they have gone for glomerulomegaly. Compensatory, the
glomerulomegaly will tell secondary FSGS. Glomerulomegaly. Then on electron microscopy,
the food process effacement, it is if segmental and focal effacement, it is mostly secondary. Diffuse effacement, it is mostly primary FSGS.
Yeah. Diffuse versus segmental, how to differentiate?
Usually in primary FSGS, the effacement will be more than 80%, whereas less than 50%, it will be segmental.
Yes, correct. Over to you, madam.
So this patient had swelling of the left lower limb. So your differential diagnosis, you put what?
MCD, ma'am. MCD, FSGS.
Differential diagnosis with swelling.
Deep vein thrombosis and with cellulitis, ma'am. Deep vein thrombosis with cellulitis. Since patient is also having fever and.
So what percentage of nephrotics have these thrombotic complications?
Usually thrombotic tendency has been described more with membranous nephropathy. Less than 10% of the patient usually they have thrombotic tendency.
What about FSGS? What percentage have? Overall, how many? Membranous, how many? FSGS, how many? MCD, how many?
Ma'am, in MCD and FSGS, it is less than 5%, and in membranous, it is less than 10%, ma'am.
Membranous is 10%, but less, what you are mentioning, or it's more than that?
With treatment, ma'am, it is less than 10. Without treatment, it is around 20 to 25.
So depends on the level of albumin.
Yeah, if the serum albumin level is less than 2, then it usually.
So suppose, so this child has a thrombus.
Yes.
So what will you do?
Ma'am,
how will you treat it?
What are the guidelines for anticoagulation in adults?
Ma'am, the guidelines, one is the guidelines, it says that whenever the patient is having serum albumin less than 2.5, 2.5, he should be started on oral anticoagulation. Initially, it should be bridged with heparin, then it should be started on oral anticoagulation. If the patient is having bleeding risk, then we can switch to aspirin.
So how do you assess the bleeding risk? One is level of albumin for starting anticoagulation, you said that. What about, so what are the criteria? More than 3, 2.5 to 3, less than 2.5?
Albumin less than 2, we have to start, ma'am. 2 to 3.1, it depends upon the bleeding risk and the thrombotic risk. More than 3.1, it is not advised to start, ma'am.
So how do you assess the bleeding risk for this?
Same like in atrial fibrillation, what score is there? That
what score is there? What are the scores available?
Score is Chadbus score. I'm not able to recall that.
Haslex score, what is that? Haslex score, what is it? At least what components you look for? Who has a high bleeding risk?
Bleeding risk, ma'am, any patient is previous history of any hemorrhagic stroke or any aneurysms is there, or any platelet count, previous history of any bleeding tendency. These are the patients who have
hypertension, renal impairment. So all those things are. So what would you do for this child? He has a numbers.
No.
What would you do?
Ma'am, initially I will start with the injectable heparin, and after and I will start warfarin. After 3 to 4 days of overlap, I will switch it to warfarin, and my target of INR will be between 2 to 3. And in meanwhile, I have to control, I have to treat the relapse of the nephrotic syndrome. This is the main culprit. So I have to treat both DVT and nephrotic syndrome. And after 3 to 6 months, usually we can stop oral anticoagulation and we can just treat the nephrotic syndrome part now. Usually it resolves within 3 to 6 months, the DVT part. The oral anticoagulation has to be continued till 3 to 6 months.
Can you use low molecular weight heparin or heparin? And if heparin, what dose? Low molecular, which one, what dose? And what about the role of newer directly acting oral anticoagulants for management of anticoagulation?
There is no study, man. Till now, there is no study in which newer anticoagulation has been tried. So ideally, it should be warfarin based only. So newer anticoagulation has not been recommended in DVT, secondary to nephrotic syndrome. And initially, warfarin, ma'am, we will start 5,000 international unit QID. Heparin 5,000 international unit QID and low molecular weight 0.6 mg BD, ma'am. And then it has to be overlapped with warfarin, and INR target should be 2 to 3, ma'am. But newer anticoagulation, no study has been done in which it has been recommended till now. So warfarin only we have to hold anticoagulation, just like atrial fibrillation.
What could you do for this child? I mean, when do you do a genetic analysis? What are the indications of genetic analysis in nephrotic syndrome? And do you think this child needs that?
Ma'am, I don't think this child requires, because he is a case of steroid responsive nephrotic syndrome. As per this patient, ma'am, I don't think, because his presentation, when he had nephrotic syndrome, his age was 19 years and he was an early responder. He was a steroid sensitive. He is a frequent relapser, but he does not require as per the guideline. And the guideline, the indication of genetic testing is, one is congenital and infantile nephrotic syndrome. One is steroid resistant nephrotic syndrome with facial, with dysmorphic features. These are the guidelines, ma'am. But steroid sensitive nephrotic syndrome, there is no guidelines for genetic testing.
Dr. Prabhu?
So how will you decide when to stop the anticoagulation?
Sir, we have to do repeat ultrasound at the end of 3 months, and if there is canalization and it is told that after 3 to 6 months we can stop oral anticoagulation, because here the main reason of DVT was the patient was having relapse of nephrotic syndrome. So once we have treated the relapse of nephrotic syndrome, his serum albumin would have come up, and his
So when the albumin comes up above what level, you can stop?
Above 3, sir.
3 grams, yes. Once it's above 3 grams, you can decide to stop. But it's a minimum of 3 months. If the proteinuria is persisting, hypoalbuminemia is there, still you would definitely continue.
Yes, sir.
It's not based on your recanalization or anything. You can go to next case, madam.
So coming to second case, sir. She is a 27-year-old female patient, resident of Mehboob Nagar, farmer by occupation, born out of second degree consanguineous marriage. Now the chief complaint is she is having vomiting 3 to 4 episodes per day, nausea, decreased appetite, breathlessness on minimal exertion from last 1 month. So she is symptomatic from last 1 month. For following complaint, she was admitted in Usmania Hospital on 9th of May, and she was examined by me on 20th of May. I would like to date back my history three years before. So 3 years before, in mid 2019, she tells that she had fever with chills, dysuria, bilateral loin pain, vomiting, and decreased appetite for 10 days. So she was evaluated by a local physician in Mehboob Nagar, and she was told to have some kidney infection renal dysfunction. She does not remember the creatinine value, but she was told to have some kidney infection, renal dysfunction, and there is some renal stone, and the kidneys are bilaterally enlarged with full of cyst. So she was told that she will require dialysis, and she was referred to tertiary care center. That time she remembers that the urine output was adequate. There was no history of hematuria, prodyuria, graveluria. There was no history of nocturia, polyuria. There was no pedal edema, facial puffiness. There was no breathlessness, cough, expectoration, hemoptysis. No, there was no history of any alternate medication use. So, for following complaints, she was admitted in Usmania Hospital for around 20 days, and she was given 3 sessions of hemodialysis, and she was treated with some IV injection. Most likely, she was given some antibiotic. She was given 3 sessions of dialysis via right neckline. So she was discharged of hemodialysis, and she was told to have some renal dysfunction and some and she requires regular follow-up, but she does not remember the value, the creatinine value at the time of discharge. She was also advised to go for some genetic test in 2019, but she did not go in view of financial issues. She recalls that she used to follow up regularly in Usmania every 3 monthly, but she does not remember the value of creatinine. Second time, 2 years before, in mid 2020, she had similar complaints like before. She had fever, dysuria, chills, loin pain, and vomiting for around 7 to 8 days, for which she was again admitted in Usmania Hospital, and she received 3 sessions of dialysis, and she was again treated with IV antibiotics. She was told to have some urine infection which has precipitated some renal dysfunction. So again, she was discharged of hemodialysis. Baseline creatinine value she does not remember, and this time she opted for genetic test, and she was told that it has come positive, but she does not remember. She does not know what genetic test was done. Now this is her third admission, and now the present complaint is 3 to 4 episodes of vomiting per day, nausea, decreased appetite, and breathlessness on minimal exertion. Now she is symptomatic from last 1 month. There is no history of fever, chills, dysuria, loin pain this time. The urine output is adequate. There is no history of hematuria, graveluria, nocturia, polyuria, prothuriia. There is no facial puffiness and pedal edema, no orthopnea, PND, chest pain, and palpitation. For following complaints, she was admitted in Usmania on 9th of May, and she was given 5 sessions of hemodialysis via right neck line, and even 1 packed RBC was transfused. And now she has been told that she will require continuous renal replacement therapy or renal transplant. There is on further questioning, there is no history of any arthralgia, myalgia, skin rash, oral ulcer, or photosensitivity. There is no history of recurrent UTI during childhood. There is no history of straining during micturition or any double voiding or any poor stream of the urine. There is no history of any NSAID abuse or alternate medication. Coming to past history, there is history of hypertension during pregnancy. She is para 3, living 3, A1. So she recalls that she used to have hypertension in each pregnancy. She had hypertension at the end of the pregnancy, but after delivery, the BP was controlled and she was never started on any antihypertensive. And presently also she is not into any antihypertensive. There is no history of diabetes, tuberculosis, any coronary artery disease, or cerebrovascular accident, or thyroid disease. Coming to personal history, because of all these following complaints from last 1 month, sleep has been decreased, diet has been decreased, bowel is normal, bladder habits are normal, habits nil. Obstetric history, para 3, living 3, A1, all 3 normal vaginal institutional delivery, and there was 1 spontaneous abortion. Menstrual history is normal. Family history, she is born out of 2nd degree consanguineous marriage. Father, mother, no, none of the family. She is having 4 siblings, and none of the sibling, father, mother, they are having any renal dysfunction or hypertension or diabetes or any form of other illness. So shall I summarize? So coming to summary, she is a 27-year-old female patient, a case of recurrent UTI, recurrent urinary tract infection, urosepsis, requiring multiple admissions, IV antibiotics and hemodialysis with bilateral enlarged and cystic kidney disease with positive genetic test, but she does not recall the test, presently declared as CKD ESRD and requiring renal replacement therapy or advised renal transplant. So, shall I give my differential diagnosis? My differential diagnosis is CKD ESRD, stage 5, dialysis dependent, native kidney disease, most likely being CIN CKD, with anemia of chronic disease, post status 1 PRBC transfusion, with past history of pregnancy-induced hypertension, gestational hypertension. And the differential diagnosis are cystic kidney disease, most likely first being tuberous ADPKD, tuberous sclerosis, von Hippel-Lindau, or acquired cystic kidney disease. Down the order by psychoureteric reflex, down the order xanthogranulomatous pyelonephritis or malakoplakia.
Why you have given so much, whatever it is there in the book?
Everything, all cystic diseases you have given as PD.
Because ma'am, I was not able to point out because there was no positive family history and there was no hypertension, patient being himself non-hypertensive, no positive family history. So I could not limit to ADPKD.
But the one people in the tuberous sclerosis, xanthomatous pyelonephritis.
So does ADPKD always have a history, family history? What percentage don't have a family history?
But almost 80 to 85% of the patient they have family history. 10 to 15% they can have negative family history.
So because
This
it's
is the
so,
commonest cystic disease that we see, especially you yourself.
ADPKD, ma'am. But her age being only 27 years, she is being CKD, SRD, dialysis dependent. So I was like,
What else? What other cystic kidney disease can present as renal disease?
at
You
tuberous
did not mention that. Right?
tuberous sclerosis and von
What about
Hippel-Lindau.
human nephropathy?
The patient was told to have bilaterally enlarged kidney, so it
You
goes.
probably want to classify cystic kidney disease.
Cystic kidney disease can be classified as cystic kidney disease with enlarged kidney size and with normal to reduced kidney size. If the kidney size are enlarged, then our differential will be ADPKD, ARPKD, tuberous sclerosis, von Hippel-Lindau. And if the kidney size are reduced, shrunken kidney, it can be with acquired cystic kidney disease because of long dialysis vintage, juvenile nephronophthisis, and medullary cystic kidney disease. But since the patient was told to have enlarged kidney size, I didn't keep medullary cystic kidney disease and juvenile nephronophthisis in my differential diagnosis.
That is what, can it be just reflux nephropathy?
Yeah, it is in my differential diagnosis, but the patient does not have give history of recurrent UTI during childhood, and there was no history of hypertension.
She told us she had multiple cysts in the kidney.
Yeah, ultrasound twice it was done, sir.
No, she told you that she has.
Yeah, she was told that she is having some
Enlarged kidney or cystic kidney?
enlarged kidneys are enlarged and there are some water in the kidneys.
Can be there in reflux also. No? Kidneys can be
Reflux
enlarged.
nephropathy usually comes with the shrunken kidney as
No,
a,
no.
and they will
Any
have
obstruction will be there. It can have enlarged kidneys and also these things.
acutely they may have, but in long term chronic component they can have acquired cystic kidney disease, but on long term they will have reflux nephropathy which will present as shrunken CIN CKD with hypertension.
Parenchyma will be thinned out, but kidneys can be large.
Yes.
yeah, so how do you differentiate, just extension of Dr. Rivati's question, cysts in polycystic kidney and the cystic lesions, looking lesions in hydronephrosis, reflux?
Polycystic kidney disease, they usually bilateral, it will be
It
viral.
can be there in reflux also.
Yes, ma'am. Multiple cyst, bilateral, both cortex and
reflux
medulla.
also.
How enlarged kidney size? Kidney size is
Can occur in reflux also, it's not always shrunken.
the pole upper and the lower.
It's not, I mean, definite, I mean, anything else which will definitely,
They'll
I
communicate.
mean, differentiate.
Non
So what are communicating and non-communicating cysts?
the communicating system, the cyst will be communicating. The cyst is the communicating.
Can it happen in which condition out of these two?
ADPKD can have both communicating and non-communicating.
Mostly it's not.
Non-communicating. Non-communicating.
The pathogens of cysts,
Mostly it is
from the
non-
views and all that, it's non-communicating, whereas in the other, it's communicating.
Communicating system. Yes, ma'am.
Dr. Prabhu, what would you like to ask?
How do you establish a diagnosis of polycystic, this autosomal dominant polycystic kidney disease?
Sir, diagnosis, it is a clinical diagnosis. So any patient, there are criteria, Ravi's criteria is there with positive family history and negative family history. So if the family history is positive and the patient age is between 15 to 40 years, then total 3 cysts in single or combined, I mean, bilateral, both kidneys, total cysts should be 3. When the age is 40 to 60, 2 cysts should be there in both each kidney. And when the age is more than 60, it should be 460 in each kidney. If there is negative family history, then 10 cysts should be there in both kidney minimum. So this is the Raven's criteria.
Or
Plus the kidneys, if negative family history, there should be 10 cysts in both kidney, plus the kidneys should be enlarged, and there is history of, there is on finding, there must be some, there may any plus any one of the following: bilaterally enlarged kidney or liver cyst.
yes, liver cyst should be there.
Yes, sir.
What are the factors which predict faster rate of progression? Any way to calculate that?
Yeah, pro-PKD score is there, sir. So pro-PKD score, male, the scoring has been given. So male patient, the scoring will be given 1, and hypertension below 35 years, the scoring will be 2. Any urological event before 35 years, the scoring will be 2. And non-truncating mutation, the score will be 2. Truncating mutation, the score will be 4. So total the score is 9. If the
PKD 1 and 2.
Pardon, sir?
PKD 1 or 2.
PKD 2 score is 0. PKD 1 में non-truncating mutation, the score is 2, and truncating mutation score is 4. So total score will be 9. If 6 or more score, it suggests faster progression. Or simply kidney size more than 16.5 centimeter, it also suggests faster progression. Mayo score 1C, 1D, 1E suggests faster progression.
The clinical predictors of progression, you've talked about the pro-PKD and all, but everybody may not have a genetic maths done. Clinical predictors.
Ma'am, clinically hematuria before hypertension before 35 years, any urological event like hematuria, cyst infection or cyst rupture before 35 years, and then kidney size more than 16.5 centimeter, patient coming with having proteinuria, these all suggest faster progression.
So what about this patient? This patient, do you think she had risk for faster progression?
Ma'am, at the age of 27 years, means she is below 35 years, and she is having multiple urological events, and her kidney size was enlarged. We don't know the size of the kidney, whether it was more than 16.5 or less than that. So she comes into faster progression now, and she is having deranged renal function before she has come with the deranged renal function. So she comes into category of faster progression.
Suppose she had a family history.
Yes.
So does that prognosticate, I mean, is it also a prognostic marker? Suppose family history of ADPKD.
It doesn't come into any prognosis factor.
Suppose somebody, her father or mother had ADPKD and went into renal failure at an early age. So can you predict the age at which she will go into ESRD?
Normally, ma'am, it is told that in PKD1, 60% of the patient they develop ESRD by 60 years. So if the father and mother they have developed CKD, ESRD below 60 years, so it suggests that indirectly we can say that she will also have faster progression. 60 years is the limit, ma'am.
What is anticipation? Anticipation.
Ma'am, normally the GFR fall we are expecting about 2 to 4 ml per minute per year. But if the size of the kidney is more than 16.5 centimeter or volume is more than 750 ml, then we can anticipate that the fall of GFR will be more than that. It will be around 5 to 6 ml per minute per year. So we can anticipate the fall will be more.
I wanted anticipation in some other context. It's okay. So what about genetics of ADPKD? Do you think she has a spontaneous mutation?
Yeah, ma'am, because there is no positive family history, so most likely it is spontaneous. No, there is no first degree, second degree, third degree. No, none of the family member is having any positive family history. So I expect it to be spontaneous mutation.
Okay. So if somebody has the gene, will they always manifest in case of ADPKD?
It does not, ma'am. It is like ADPKD. Usually, it has a complete penetrance. So usually the family member they will present, but the age may vary. They may present.
So what is penetrance and what is expressivity?
Penetrance means it will be passed to the next generation, ma'am. So ADPKD has a very good penetrance, Expressibility means the disease is there, but it may express either late in the life or early in the life. So it has a good both good ADPKD holds both good penetrance and good expressibility, ma'am. It holds both good, ma'am.
How do you choose your patients for tolvaptan in case of ADPKD?
Ma'am, there are two trials, ma'am. One is Reprise trial and Tempo trial, ma'am. So whenever the patient GFR, the basic criteria is the GFR should be more than 25. So if the GFR is more than 25 and the patient kidney size is more than 16.5 centimeter, the kidney volume is more than 750 ml, we can give a trial of tolvaptan, ma'am.
At what dose?
Ma'am, initially we give ma'am 45 mg in the morning and 15 mg in the evening. And if the patient is tall, we avoid night dose because of diuresis. So 45 mg and 15 mg, it has to be started with 60 mg cumulative dose. Then we can titrate it up to 120 mg or 150 mg. But we have to look for liver function test, ma'am.
What else will you monitor?
Mainly
Patient is not proper.
liver function test we will monitor, ma'am.
And any instructions you will give to the patient?
Diuresis, ma'am, it can cause, yeah, ma'am. This ADPKD, the basic pathogenesis is increased ADS. So we tell the patient to drink minimum 3 liters of water. Ideally, the ADS should, the more the patient drinks water, the more ADS will be suppressed and the basic pathogenesis will be halted, ma'am. So he has to take more water.
What is the difference between Tempo and Reprise?
Ma'am, Tempo trial, it was done in the patient whose GFR was more than 60 and Reprise was done in between GFR 25 to 60. This is the main difference, ma'am.
They say in Reprise they have gone down on the
To
GFR.
25 ml per minute per year, GFR.
And how do you monitor response to
Ma'am,
done and how long would you give?
ma'am, there is no time frame given, ma'am. We have to give, if the patient is tolerating, so we can continue this medication, ma'am. There is no time limit given, ma'am.
And how do you monitor?
We monitor, ma'am, one is urinary sodium, ma'am. We can measure, one is by urinary sodium, one by the kidney cyst size we can, ma'am. We can. Urinary sodium, cyst kidney, ultrasound by.
So you know the formula how you measure the kidney volume.
Height adjusted total kidney volume.
Tuberous sclerosis, you told, no?
Yes, yes, sir.
So what would be the clinical features of that?
Sir, from head to toe in tuberous sclerosis, usually it is also an autosomal dominant disease, but with poor penetrance. So the family history may be there or may not be there, unlike ADPKD, where usually family history is there. So head to toe, the most common is adenoma sebaceum, Sjogren's patch will be there. And even in kidney, there may be angiomyolipoma or renal cyst, or in heart, there may be rhabdomyoma. So main features are adenoma sebaceum, Sjogren's patch.
CNS, what will they present?
Epiloia. So they will have epilepsy, low intelligence, and cortical tubers may be there. Subependymal nodules may be there.
And typical CNS, this MRI features. It's a classical diagnosis on the MRI or the CT scan.
Tubers, cortical tubers.
That patients with ADPKD who have a genetic abnormality, do you think all of them will have a phenotypic presentation? They will all present with ADPKD?
No, ma'am, it is no, means patient is having phenotypic or genotype.
Genetic mutation is there.
Yes, ma'am.
Will all of them present?
All of them.
See, you said penetrance is high. Agreed. What about the expression?
Expression is also high, ma'am, in ADPKD. All may not develop, but expressibility is also high. They may have other mutations which are not known till now. We just know only few mutations like.
So what is the second hit?
Second hit.
So they need another hit for expression. How will you manage this patient? She's in now end stage.
And is there legal disease?
She is for, and you
See,
have explained to her or she has been told about renal replacement therapy?
Yes, ma'am.
How will you decide?
So ma'am, now she has been.
How will you, if she's for a transplant, how will you select the donor?
Ma'am, donor, we can, since it is a disease which runs in the family, so we can, still we have to screen the family member, and it is told that at the age of 30 by MRI, if there is a no single renal cyst, then we can take that person as a donor. He does not require any genetic test. So I will search, I will go like his father, mother, or sisters are there. So all who have crossed, we can't take the family member as a donor whose age is less than 30 years. If still the genetic test is negative, then also we can't take. So the minimum age should be 30 years, and at the age of 30 years, I would like to go for an MRI. If there is not a single renal cyst, then I can select them as a donor. So I would promote live related renal transplant rather than a cadaveric, in spite of being
Would you
a.
require an MRI or CT?
It is an MRI based, not CT based. Then after that, I would like to promote as a family member as a donor, because there will be less requirement of induction and less risk of infection, because we have to give most likely non-depleting agent if the family member is a donor. So now coming to donor.
It will be general for all the people. Why you are saying of it in this case? You recommend live transplant to everyone.
Yeah.
It is not specific for this.
No, since it is a familial disease, many people may think of cadaveric transplant. Mainly that.
That is different.
Still, live transplant should be promoted in a case of ADPKD.
It's everywhere.
In every, like you said, everywhere.
Not specific for this ADP.
Yes. And
explain to actually why this patient developed ESRD at the age of 27. You also said actually she got repeated admission.
Maybe sir,
So what percentage of nephrons will undergo a cystic change?
Ma'am, very less, around 5 to 10, less than around 5 to 10% only of the
Why
nephron.
does it develop renal failure?
Ma'am, the cyst, they grow in size and they compress the neighboring normal structure. It is not that only around 5 to 10% of the
So
nephron
what are
will
the
have cyst.
other factors which are responsible for progression of disease in ADP?
Ma'am, it is the compression of the neighboring structure leading to RAS overactivity.
Apart from that, you only told that this patient
Truncatic mutations and
you got this patient repeated admission because urinary tract infection.
pyelonephritis and all these.
You only told, no?
Hypertension, renal stone disease.
Slow. The question comes here. Why he got repeated? Why she got repeated admissions?
Because of cyst infection, mostly cyst infection. Because
How do you differentiate the cyst? Was it cyst infection or
Assembly
urinary
infection.
tract infection? How will you differentiate?
ma'am, a lab report wise, we can go for PET CT, ma'am, and MRI is that.
No. Everybody will not go. When there is an infection, you won't go straight for a PET. How will you differentiate?
Clinically, ma'am, ADPKD, usually the cysts are non-communicating.
First,
So
listen to madam. She's asking question. She's not yet completed the question.
How
Don't
will you
answer.
differentiate a cyst infection from a parenchymal infection?
ma'am, here mostly on complete urine examination, there won't be urinary abnormality because the cysts are usually non-communicating. So in cyst infection, the reports may come as normal. CUE may come as normal, blood counts may come as normal, inflammatory marker may come as normal since it is a non-communicating cyst. But in otherwise pyelonephritis, usually it will be communicating. So we will have urinary abnormality, leukocytosis, raised procal, positive urine culture. But here we may get negative urine culture and normal urinary reports.
Okay, why she progressed very fast? If at all only she had repeated cyst infections, parenchyma is spared. If at all she has repeated pyelonephritis, parenchyma is also involved. The progression will be faster in that. So in that scenario, are you suspecting any reflux nephropathy also in this patient apart from ADPKD in this patient? Because your diagnosis was CA and CKD.
Yes, sir.
So in that you are also contributing any component of reflux in this? What is association of ADPKD and reflux nephropathy?
As said, there is no causal association. Yet it's known that ADPKD, which may be a coincidental association, but as a direct causal association is
You
not
have to
there.
think, no, because at 27 years, since ADPKD, she went to ESRD. You're not expecting that the ADPKD to go to ESRD by that time.
I'm expecting there must be some any truncatic, de novo truncatic mutation. Because of this, he has developed everything very fast.
Is ADPKD a slowly progressive disease or does it progress fast?
Slowly progressive disease.
So by 27 years, she has gone into ESR.
Any stones are there? Are you thinking of any stones?
She was on ultrasound one small stone, but as such, she has never underwent any surgery for stone, so I don't expect it to be.
The issue is at the age of 27, she got ESR with ADPKD. You have to think of other reasons.
She also had PIH, so that may be one of the PIH was also there in all three pregnancies. She had pregnancy-induced hypertension, so even that may be a contributor.
What is impact of pregnancy and ADPKD progression? Does it have a negative impact or positive impact?
Any pregnancy-induced hypertension means there will be
No, pregnancy, not pregnancy, pregnancy and ADPKD. Cyst growth. I'm specifically asking cyst growth, pregnancy.
there is no, sir. The ADH is suppressed in pregnancy, so the cyst want to be enlarged in pregnancy because the ADH, the main driving factor is ADH, and in pregnancy the ADH is suppressed itself. So
Why it is suppressed?
because it is a hypervolumic state, pregnancy is a hypervolumic state, so ADH is suppressed there. So I don't think there will be any cyst enlargement in pregnancy.
But what is the impact of hormones on cyst growth? What hormone is high in the
Estrogen and progesterone is there, but as such that is also not mentioned anywhere. It has an indirect impact.
What happens to liver cyst during pregnancy?
Liver cyst, ma'am, it enlarges because of the estrogen, ma'am. But renal cyst, they don't have a direct correlation with estrogen and progesterone.
What are the eye findings in ADPKD? Fundus findings typical which can help you make a diagnosis?
Ma'am, usually they have hypertensive retinopathy because these patients are prone to have hypertension. So most common ocular finding
That's
is
non-specific. Any specific finding which will help you make a diagnosis. Why is the eye examination important in such a patient? Where there's, I mean, you have polycystic kidney disease. So why we should not miss a fundus examination? What diagnosis can you make as a spotter?
like other cystic kidney disease, they have some retinal hemangiomas and that. In ADPKD, just it may mimic cystic kidney disease.
Polycystic kidney, ADPKD.
ADPKD, ma'am. Polycystic kidney disease for retinal hemangiomas.
So if retinal hemangiomas are there,
Usually it favors other cystic kidney disease rather than ADPKD.
I mean, it is characteristic of which disease?
Von Hippel-Lindau.
So in that, do you have autosomal dominant polycystic kidney disease?
Von Hippel-Lindau is an
Is it
autism.
autosomal dominant?
Yeah, ma'am.
Is it
Von
polycystic kidney disease?
Yes, ma'am.
Is it ADPKD?
But ma'am, they will have less cyst in the kidney and more of pancreatic cyst.
VHL bears the gene mutation.
Gene chromosome number 3, VHL gene chromosome number 3.
So it's a different disease.
Different disease.
Okay. So what are the characteristics when do you suspect VHL in such patients?
Ma'am, VHL we suspect when there is a family history maybe there because it is an autosomal dominant and the cyst won't be as multiple as in ADPKD. Like there will be few cysts in the kidney and more of pancreatic cyst will be there, and there will be more of hemangiomas in the brain or in the spinal cord or in the retina, and these patients are more prone to develop renal cell carcinoma.
So any asymmetric kidney size, family history, rapid growth of kidney size, always rule out VHL.
VHL.
In such conditions where you are thinking of ADPKD, it might be not ADPKD, maybe VHL.
Yes.
Dr. Ravindra Prabhu.
Or does this patient need a nephrectomy prior to transplant?
As such, sir, there is means if the patient is having refractory hypertension, refractory, it is a source of infection, or there
No,
is
in this patient.
She may require because there is 2 to 3 times history of repeated cyst infection is there, so it may be a source of infection. So in this patient, we may require donor this one patient nephrectomy.
What are the indications in a polycystic to do a nephrectomy?
The indications are that, sir, the space is that the native kidney is very large and it is there is space issues are there. We are not able to put the graft in the we are not able to put the graft in iliac fossa. So this is one of the indication. Other is that the native kidney is a source of repeated infection and repeated it is a leading to refractory hypertension. If the patient is having refractory or resistant hypertension, or then it may be a indication for nephrectomy.
Is it a predisposition for malignancy?
Sir, there is as such ADPKD does not increases the risk of RCC, sir. There is no increased risk. It can go for RCC like common 1 to 2% any cystic kidney disease. But
So
there
what
is
type
no,
of, what RCC will be there?
usually they will have sarcomatous RCC. Sir.
Multicentric.
Multicentric sarcomatous RCC. Bilateral RCC.
What's the youngest stage of occurrence of ADPKD?
Youngest in utero also we can have, ma'am. So it can be from in utero to anyone. Like
So if you have a child with ADPKD, how do you differentiate it with ARPKD?
a child, ma'am.
Okay, suppose this baby had onset around 19, 20 years.
Ma'am, ADPKD and ARPKD, by liver we can differentiate, ma'am. One is ADPKD will have both cortical and medullary cyst, and the cyst will be big. Unlike in ARPKD, where the cysts are relatively smaller, in liver in ADPKD there will be cyst, whereas in ARPKD it will be fibrosis will be there more of. So the changes of portal hypertension will be there in ARPKD, and in utero, like the patient may have Porter syndrome and all this. All goes in favor of ARPKD. Porter syndrome, lung hypoplasia.
Porter's phenotype? Since you only brought it up, what's Porter's phenotype?
Porter's phenotype means.
Yeah, but now Porter's phenotype.
If the patient is having this one oligohydramnios, so there will be, because ARPKD patient
Patient mother will have oligohydramnios.
Yeah, lung hypoplasia, ma'am.
I'm saying patient's mother will have oligohydramnios. Patient is the baby.
Yes, ma'am.
So Porter's phenotype is in the baby.
Lung hypoplasia.
What a phenotype you can see, no? You only said that if the child has a Porter's phenotype, you said. So you are correct. What is Porter's phenotype?
Poor like lung hypoplasia. Porter's
You cannot see no?
at the phenotype, the babies that the nose it will be because of the oligohydramnios, the membrane and the baby won't have the place to grow.
Yeah, you have got the concept, but what are the manifestations of that?
The bridge of the nose will be flat nose will be there, and flat head, and the poor facial growth will be there, ma'am. The facial disfigurement. Limbs will be it will be adducted limb, ma'am, because of the lack of space, the adducted limbs will be there.
We just will have adducted limbs only. All we do are we born like this. You are right, we are not using the proper terminology to clear. To go back and read Porter's phenotype.
Yes, ma'am. Yes, ma'am. Thank you.
Okay, thanks.
You are finished. One session is done. Marking. Our session is ending.
Thank you so much, the examiners, Anuradha Madam and Manisha and Gangadhar. Thank you so much for being here. Thank you, sir, Dr. Ravindra Prabhu. I think we'll have a short break of about 15 minutes and rejoin back for the subsequent session in the afternoon. So we'll start the session by 1:30, 1:35. So kindly join by 1:30.
Okay, ma'am.
Right,
Okay.
right. Thank you so much. And I think we break for lunch. Please join in 15 minutes. We come down on your lunch break because we were just going to forget you. So 15 minutes break, have lunch, be back. The people who are presenting the supplement cases examiners are already here. Please clear you. Madam, thank you, madam. Thank you, thank you, thank you so much for coming. Sir, we'll break for lunch and then join by 1:30, 1:35. Right, yeah.
Lunch లేదా? పొద్దున్న నుండి 3 hours. అవునా?
You know, in DAT exam, they will give you cashew nuts. Nadia will give you cashew nuts. नहीं, cashew nuts, high quality cashew nuts. आज बिस्किट भी नहीं दिया तुम लोगों ने. I saw no biscuit. No cashew nuts. No insect.
Sir, good afternoon. You're ready, sir? You're okay
Yes,
now?
yes, ready,
We'll
ready,
start?
yes.
Yeah, yeah. thank you.
Okay.
So good afternoon. Welcome you all back for this post-lunch session. So we have again a series of long cases and short cases. For this session, we invite the examiners, the external examiner, the internal examiners, Dr. Urmila Anand, who is senior consultant nephrologist at the Yashoda Hospitals. Along with her joining is Dr. Bhushan Raju, who is professor, Unit 2, Nephrology and Exams Institute. And along with them is Dr. Kiran Mai, who is professor at Usmania Medical College. So we continue to have the excellent examiners, Dr. Ravindra Prabhu and Dr. Santosh. So I request the examiners to stick to the time of 1 hour for long case and 1 hour for 2 short cases. And without much ado, I think I call upon the next presenter. Who is the next presenter? Everybody heard my voice? See, everybody is so alert.
ఇంకా టైం ఉంది కదా కాదు మనం సంతోష్ జాయిన్ అయ్యే వరకు వెయిట్ చేద్దాం
Between exam, I can go out, have some cashew nuts and come out.
Sir, we will start, sir. Dr. Ravindra Prabhu, sir.
Yes, yes, please, please go ahead.
Yes.
Good afternoon, everyone. Good afternoon. I would like to begin my case presentation. So, my patient is Mrs. Sana Begum, who is a 23-year-old lady hailing from Hyderabad, currently staying at home, married since the last 3 years, has not received any formal school education. She has presented to Osmania General Hospital for routine follow-up visit after live-related ABO-compatible renal transplantation with father as donor and is currently asymptomatic. I would like to predate my history from 2018. She was apparently all right till December 2018 when she developed fever. Fever was low grade. It was associated with myalgia. There was no diurnal variation, no night sweats, and it was temporarily relieved with medication. It was the fever lasted for about 15 days. She simultaneously noticed bilateral lower limb swelling, facial puffiness, which was insidious in onset and gradually progressive and was present throughout the day. She also noticed history of headache, which was present on and off, bilateral temporal, and it was temporarily relieved with medication. For these complaints, at around day 5 of her illness, she went to a private practitioner where she was told to have some infection, the details of which she is not aware of. And she was also told to have a high blood pressure of around 180. She doesn't know the exact reading, but she remembers it as being around 180. She was treated with IV fluids and was discharged after 5 days. She was also advised to take single antihypertensive drug. However, she stopped it after a period of 10 days. She does not recall any particular investigation being done at this time. She did not follow up again for around 1.5 months. During this time, on inquiry, she did not have any history of decreased urine output, cola colored urine, burning micturition, no history of frequency of micturition or frothy urine. There is no history of waking up frequently at night to pass urine. There is no history of lower urinary tract symptoms such as hesitancy or poor stream of urine. There is no history of passing stones, no history of previous such recurrent symptoms. There is no history of breathlessness, abdominal distension. There is no history of abdominal pain, jaundice, loose stools or vomiting. There is no history of skin rash, joint pain, sore throat, bleeding symptoms. There is no history of anorexia or weight loss. There is no history of oral ulcer, excessive hair loss, difficulty swallowing, skin tightening or discoloration, or blanching or discoloration or ulceration of fingers. She does not give history of visual symptoms such as blackening of eyes on and off. There is no history of seizures, paresthesia of limbs, limb weakness or altered consciousness. She also does not give history of intake of NSAIDs or alternate medicine use. She consulted a doctor again after 1.5 months of the symptoms onset, where she was referred to a nephrologist who on evaluation told her to have a creatinine of 8 milligrams. And she was advised for immediate initiation of dialysis. She was started on dialysis via right IJV catheter and her symptoms improved after around 2 to 3 sessions of dialysis.
This was in 2018.
2018 December.
So you get 10 minutes. So
Yes.
in that 10 minutes, you have to decide which is the important history.
Yes.
Yes.
So meanwhile, on further evaluation on renal scan, she was told to have small kidneys. However, she is not aware of her other blood or urine reports. So she was on maintenance hemodialysis 3 times per week via IJV catheter, which was converted to left arm AV fistula after 1 month. Her dialysis sessions were of 4 hours each session, and she's not aware of taking any hepatitis B or pneumococcal vaccination. She received iron injections once in 2 weeks and EPO injections. There is no history of access related infection or access failure. She also does not give history of blood transfusion or hospitalizations during this period. During this period, her BP was well controlled on 2 tablets. She then underwent live related ABO compatible renal transplantation with father as donor at Osmania Hospital on 27th February 2020 after a dialysis vintage of 1 year and 2 months. A father at the time of donation was 50 years old. He was a chronic smoker prior to donation, but he stopped smoking 7 months prior to renal transplantation. He also has no history of hypertension, diabetes, renal calculi, or cardiovascular disease. The transplant history, she is not aware of receiving any specific injection suggestive of ATG or basiliximab. She had uneventful hospital stay post-transplant with Foley's removal on POD post-op day 4, drain removal on day 6, and she was discharged on day 10 with the tablet Visolon, MMF, and tacrolimus. However, she is not aware of the exact dose at the time of discharge. She is also not aware of the creatinine at the time of discharge. However, on follow-up, she was told to have creatinine of 1.1, which was around 1 week after the discharge. She had hypertension in the post-transplant period requiring amlodipine 5 mg once a day. She does not give history of developing deranged sugars. She was asymptomatic on regular follow-up from February 2020 till 8 months back when she developed fever, vomiting, and myalgia, which on evaluation was told to be related to COVID. She does not have history of breathlessness or need for hospitalization, hence was managed at home. She gives history of receiving some expensive IV injections for around 2 days, but she is not aware of the exact injections given. She was, however, warned to not discontinue her immunosuppression or reduce the dose, and hence she was managed at home conservatively. She was also told to have creatinine of 2 milligrams at the time of diagnosis of COVID, which was retested after 15 days and was found to be 1.3. At the same time, she was also told to have some protein in urine, the exact value of which is not known. She is also unaware of her tacrolimus levels during this level. She was monitored for the renal function and protein leakage in urine, which was found to be persistent even after 1 month of diagnosis of this COVID illness. And she was told to have creatinine of around 1.4. Hence, she underwent renal biopsy at Osmania Hospital without any procedural complications. She was told to have graft dysfunction, but she is unaware of the exact diagnosis. During this time, she was admitted and treated with 3 days of pulse methylprednisolone, followed by 2 injections of 2 costly injection, which was 2 injections of IVIG, which was given continuously for 3 days. And this was given after about 1 week of receiving this methylprednisolone pulse. And she was told that this is required because she has not responded well to that methylprednisolone. Then she was also told to receive this IVIG injections, 2 injections per day on follow-up, which was given twice at 2 weeks interval on follow-up. She does not give history of receiving any special dialysis suggestive of plasmapheresis. On follow-up, her creatinine was the same, but she was told to have improvement in her proteinuria levels. She is not aware of any changes in her immunosuppression tablets during this period. She developed watery stools lasting for 4 to 5 days, around 5 to 6 episodes per day in February 2022, which was not associated with fever, abdominal pain, or vomiting. She remembers getting an expensive blood test being done for some infectious agent, and she was told that it is negative. She is not aware of her tacrolimus levels at this point also. During this period, she was again found to have a creatinine of around 1.5, for which she underwent renal biopsy for the second time without any procedural complications. And she was told to have the same findings as the previous report, which has not improved. She is again not aware of the exact diagnosis. She was told to continue the same treatment of MMF, TAC, and Visolone, and she was not advised any extra injections. Currently, she remembers her MMF dose being 500 mg BD, TAC 1.5 and 1 mg. She does not remember the dose of Visolone. She remembers her current creatinine being around 1.3. So this is the present history.
You have presented the at stage, but let me ask you, was there any positive family history?
Yes.
Mic, yes, please.
Good afternoon, everybody.
So-
So you have presented at length. I just wanted to know what is the family history? Is there any positive family history that you have not mentioned
Yes.
during your
I have
presentation?
separated.
And what do you think the native kidney disease is?
So regarding family history, ma'am, she's born out of a non-consanguineous marriage. Her mother is currently 50 years old. She's a known diabetic and hypertensive since the last 10 years with poorly controlled sugars and blood pressure. And she has history of developing coronary artery disease 3 years back, which was advised to be treated with bypass surgery. But in your poor BP and sugar control, she's not followed up the same advice. And she has also recently, around 2 months back, developed some renal dysfunction with creatinine of 3, which was treated, and she's told to have her creatinine having been normalized. The patient here, she is the 5th in birth order out of 7 siblings, and none of her siblings have any similar complaints. They have not been evaluated also.
What do you think the native kidney disease would have been?
So in view of her history of sudden onset presentation with accelerated hypertension and some fluid overload features, which was precipitated by underlying infectious illness, I would like to consider probable underlying chronic glomerulonephritis as the cause of her CKD, which was probably IgA nephropathy with the crescentic transformation, or thrombotic microangiopathy due to atypical HUS, because infectious illness is also known to precipitate the disease presentation, or an anti-GBM disease with isolated renal involvement. The other isolated renal
I'll just
involvement.
stop you there.
Yes.
Do you think all these diagnoses, Osmania wouldn't have done anything before the transplant? That
Ma'am,
history you never gave us. If you say somebody is anti-GBM, somebody is atypical HUS, isn't it? And the patient just comes and gets transplanted.
she
You
was
think,
evaluated, she remembers, ma'am, but she doesn't know the reports exactly, and she was told to have small
No,
kidneys.
that is true. But
Yes.
if you have a small kidney and you give so many differentials, all the 3 differentials you give, IgA presentate, TNA, and the third one was anti-GBM, are known to recur very rapidly in transplant.
She underwent transplant around, actually in the beginning itself, her father was willing for donation, ma'am. She underwent transplant 1 year and 2 months after the diagnosis.
That is why
Yes.
our concern is, see, all the history that you give, madam is asking. See,
Yes.
the important thing in your history is for us to understand what is the native kidney disease. How is it important post-transplant?
Because the native kidney disease also decides the post-transplant course in terms of recurrence. So if the native kidney disease is something like thrombotic microangiopathy due to atypical HUS, the chance of recurrence is high depending upon the underlying cause of the
So
this
do you
one.
think Osmania wouldn't have checked into all these parameters before they went into transplant?
Possible. My
So
first
what is more
differential is
common? What
IgA.
is more common as a shrunken kidney in our
Ma'am,
part of the body?
chronic interstitial nephritis is also a differential, but presentation in a manner directly with
How is it
accelerated
not
hypertension.
How is it not? What is the natural history of chronic interstitial nephritis?
So they present with chronic indolent progressive
end
loss of.
stage? At end stage, can you differentiate?
It
them
is
from
difficult.
CGN?
No, it is difficult.
What was the age of the patient at the time?
She's at the time of diagnosis, she was 19 years, 20 years old.
20 years old. So what would be the commonest reasons of the kidney failure in a 20-year-old woman?
Bilateral dysplastic kidneys itself can cause chronic interstitial nephritis.
Rather than
At the age of 18.
18, at the age of 18, she had renal failure. She just getting into adulthood. So what were the most common frequent etiologies of kidney failure? You just classify it that way. So don't look at the presentation alone. So you should have several differential diagnosis. You should know how to differentiate between the CGN and the CIN when they come with the small kidneys and you don't have any other indication of it, something like doing a kidney biopsy or something like that. And no other clinical, external, physical or morphological features of suggesting a syndrome or a disease.
Yes.
So you have a differential diagnosis only of two things, something like either the glomerular compartment involved predominantly or the tubular interstitial compartment involved predominantly.
Yes.
So you classify according to that. Just see whether you are more putting into CGN or a CIN. What happens to the classical? You must have seen a lot of ESRDs
Yes.
at 18 and 20 years or 17, 15 years.
Yes.
So how many patients of your chronic glomerulonephritis you are seeing with ESRD at that particular time? Unless they had been on your follow-up since a very, very long time.
Yes.
Isn't it?
Yes.
So on the contrary, the CENs usually, as you said, it's indolent course and they slowly progressive. And before, at the time of declaration of ESRD, they would have had some manifestations, especially accelerated hypertension. So if it were to be the other way around, accelerated hypertension, even hypertension would have manifested much earlier. It's easier, isn't it? And the swelling of the feet and the facial puffiness and gradually progressing to anasarca, which is, she would have been symptomatic for a long time. So you see the chronology of events much before and the duration of the symptoms and with which they presented to the doctor, and of course age into consideration always, because you know that every disease has got the age limitation, like during which period. So we need to have the most common.
Yes. Yes.
Always. But I feel personally the presentation, whatever you told, is a chronic interstitial nephritis would have been the most common etiology. And one thing which you did not really mention is about the symptoms suggestive of the chronic interstitial nephritis.
Sir, I've told about.
Did you tell anything about the urinary complaints, urinary
Yes.
symptoms?
Yes. No history of passing.
What were the double voiding and nocturia?
I didn't tell about double voiding. So
That's
yes.
what. If you happen to tell me,
Nocturia.
then I would have thought that reflex nephropathy
Yes.
at one thing. And one which is very common in that
Yes.
age group, by the time they would have actually manifested. We also would have hypertension much earlier. But by the time when you see the 20s, 30s, 40s, and even 50s now, we can see the reflex nephropathy, which was there in grade bilateral or unilateral grade 3 or grade 4, something like that.
Yes.
Isn't it?
Yes.
So you could have actually elicited a history suggestion of a test similar to MCUG,
Yes.
either before, at the time of diagnosis or before the transplantation.
Yes.
At least I know that, at least I can predict that you have a differential diagnosis of reflex nephropathy, which behaves like a chronic interstitial nephritis and presents with end-stage renal disease in that particular region.
Yes.
Okay.
Yes.
You did not tell those things. Nocturia, as you told?
Yes, sir.
Yeah. Double voiding and those things are important.
No, sir. There's no ma'am. There's no history of nocturia.
We need to sort it out.
Yes. There was no history of nocturia or I asked her about lower urinary tract symptoms. She didn't give the history.
Veneresis, nocturnal
Aneurysm.
That
So
was
please
only that the
ask,
tract is good.
Yes.
So we should please ask from
Ravindra
Prabhu
Prabhu?
and Dr. Santosh.
Yeah.
Yes.
And Santosh, both of you have.
Can you summarize the case?
Yes.
Can you please summarize?
Yes.
Because
So,
Santosh is joining the plate.
Yes. So she's a 23-year-old lady who is presented with history of hypertension and chronic kidney disease in 2018, requiring maintenance hemodialysis. Who has undergone live related ABO compatible renal transplantation after a dialysis vintage of 1 year and 2 months, who has developed COVID related infection followed by graft dysfunction associated with proteinuria, probably a chronic which has been persistent over the last 8 months. So probably graft dysfunction related to a chronic allograft rejection or infection related.
So pre-transplant, what are all the important histories you lost, apart from trying to get the etiology? In terms of preparation for the transplant, what are all the historical events you would want to look at?
So, so regarding identifying her risk for rejection and regarding identifying risk for recurrence of the underlying disease. So, for the risk for rejection, history of sensitization, I would like to know. So, transfusions that she has, blood transfusions that she has received, and pregnancy. She is married since 3 years. So regarding whether she has conceived at any point, even if there was a miscarriage. Also, history. The for donation, who is the person who is going to donate to her? That also would matter because that would decide HLA mismatches. And the donor age also matters for if the donor age is more than 60 years. And regarding recurrence of her native kidney disease post transplant, again, the chance of recurrence is more if there is history suggestive of thrombotic microangiopathy or C3 glomerulonephritis or a membranous nephropathy. However, here in her case, membranous nephropathy is less likely.
What about the initial vascular access? Is that important?
Vascular access, yes, sir. So if a vascular access was placed in a femoral, so the chance of her developing damage to the femoral vessels and later on.
Yeah, so that you should have asked.
Yes.
And regarding blood transfusions, you told, what other important thing you would like to complete before the transplant?
So considering her age of presentation, in her avoiding cystourethrogram is important to look. Also looking at the anatomy of the urinary tract is important. So if any reflux disease is present, so this would affect her post-transplant outcomes because of increased risk of infections. So,
another thing is the vaccination status.
yes. So regarding her vaccination status, she has on inquiry, she all the deliveries of her mother were at home, and there was no antenatal checkup, and she has never been vaccinated anytime in her childhood also.
And this dialysis vintage is 1.5 years.
Yes.
So what are the problems you could anticipate in terms of having a longer dialysis vintage for the transplant?
So longer dialysis vintage is associated with the higher chance of chronic inflammation, and this itself can affect the post-transplant outcome by increasing sensitization.
So what will be the state of the blood vessels?
There is also increased risk of calcification and atherosclerotic changes in because
So
of
we need to assess the vascular calcification because that would impact the anastomosis and all that.
Yes.
Yes. Now she has a, what is the diagnosis you have made now? You are going ahead with examination. What are the things which are there in your mind now?
So considering her age of presentation, I would like to also look for any dysmorphic features also. And she's a young.
No, I'm not asking about the etiology of the native kidney disease. What is the working diagnosis at present?
So currently, her current diagnosis is persistent graft dysfunction because of probable underlying chronic allograft injury, which has been precipitated by a COVID infection 8 months back, which has not resolved since then.
Okay. So how would you go about this now? Next steps, what would you take?
So first of all, I would like to work her up blood reports wise. So blood reports wise, I want to see because she for the last 8 months she has been having graft dysfunction. So
no, I'm not asking what is the evaluation you will do. What are the diagnosis which is there in your mind?
So the chronic graft dysfunction could be either due to chronic graft rejection, which can be antibody mediated rejection or cell mediated rejection. The other thing could be if there is an underlying chronic glomerulonephritis as the cause, it could be a recurrence of the disease. And
chronic graft dysfunction, how will you classify it? Algorithm.
So chronic graft dysfunction, as per Banff classification, it can be due to chronic
No, not histology. Banff is histology.
So etiology wise, it can be immunological mediated or non-immunological mediated. So immunological mediated can be due to cell mediated rejection, chronic cell mediated rejection, or chronic antibody mediated rejection, or a combined chronic cell mediated and antibody mediated rejection. And it can be due to drugs itself, chronic calcineurin inhibitor toxicity, or toxicity related to other drugs that she has been taking if she's had a history of taking NSAIDs. It can also be due to infectious agents. The chronic allograft injury can be related to chronic BKV nephropathy, and if there is history of recurrent urinary tract infection, that itself can cause chronic pyelonephritis related and scarring. Also, there can be scarring related to reflux itself, and ureteric stricture can develop because of recurrent UTI. That can cause back pressure and associated graft dysfunction.
Santosh, anything?
Yeah, Santosh, I think you are joined. And any questions?
Yeah, a few questions. You were discussing about the native kidney disease etiology.
Yes.
What percentage of patients approximately in our country, the first presentation of CKD is CKD stage 5?
I'm not exactly sure of the exact percentage.
It's about 55% or so. And see, when you have a shrunken kidney, it's very difficult to say the etiology. Therefore, the duration may not be a known duration. It may be the silent duration. So it's very difficult. And I disagree with your third diagnosis of anti-GBM disease because of the hypertension. It's usually commonly doesn't come with hypertension. We talked about dialysis vintage and the effects it has on the body. What is the effect of dialysis vintage on transplantation?
Sir, so a longer dialysis vintage is associated with more risk of presensitization before transplantation, because there can be more exposure to bioincompatible environment because of and this can lead to inflammation.
If you've balanced out the requirement of blood transfusions, apart from that, what is the effect? What is the present understanding of the effect of dialysis vintage on graft dysfunction? See, earlier it was thought that dialysis vintage causes graft dysfunction and plays a major role. But the last 10 years, the data seems to suggest that it doesn't really affect the graft function much.
Okay.
Can you tell us about how you would evaluate? The sir was talking about immunological, non-immunological, pre-transplant immunological workup. Can you detail for us as to what you would do for the patient?
Okay, so immunological workup would require first of all HLA typing to see the donor and recipient HLA. This would help us to identify the number of HLA.
You want to do donor and recipient HLA?
Yes.
Okay, that's a correct answer. Why do you want the recipient HLA?
This will help us to identify the number of mismatches. So the number of mismatches, more the number of mismatches, higher the chances of patient having post-transplant DSA, and this would require induction therapy to prevent the development of.
Okay, so the first step is doing pre-transplant is to do HLA for both. Is that your first step?
Sir, immunologic workup wise HLA.
Okay, fair enough. Although many people would do something else.
Is also necessary, sir.
Yeah, no, not the ABO. We're talking about HLA immunology. Along with the HLA typing, what else would you do? Maybe simultaneously.
CDC flow cross match is also necessary, sir.
Okay.
So
what is flow cytometry?
So CDC cross match and flow cross match. So CDC cross match is the one where.
Yeah, I'm asking about flow cytometry cross match.
Okay, flow cross match is it involves identifying the presence of DSA by detecting T cell flow cross match and B cell flow cross match. So here the donor serum is mixed with the recipient antigens that are immobilized on a solid bead. And
Are you sure it's donor serum and recipient antigens?
Not beat, flow, not beat, flow. He's talking of flow, flow cross.
Sir, sorry. So the recipient whole blood is mixed with the donor serum, and the
Whom are you looking for antibodies in, the donor or the recipient?
so the donor serum and the recipient whole blood is
see
sorry, the donor whole blood and the recipient serum is mixed together, sir, and it is passed through a impedance flow cytometer, and this helps in detecting the antibodies on the basis of the medium fluorescence intensity as a ratio of the control. So the median channel shift, if this is more than 250, it is suggestive of.
Okay. How does the flow cytometry principle differ from donor specific antibodies based on single antigen bead antibody test?
So in the single antigen
Single allele. Yeah.
Yes.
Go on.
So in the single antigen bead testing, the antibodies that are detected, not all of them may be donor specific. So it will detect all the antibodies that are present in the recipient serum, and this has to be matched with the donor. This has to be matched with the donor HLA to cross check as to whether the antibodies are specific to the donor. Whereas
So
if
in
a
both
flow
you're
cross
checking
match is
for
positive.
DSAs, no? In both you're checking in DSAs, right? So what is the difference in the two?
between the two?
The sensitivity in terms of detection of antibody levels, the flow cross match detects antibodies. The sensitivity is lesser compared to the single antigen bead technique.
In terms of measurement, I agree, but something fundamentally different is there, no? Because
So non-complement antibody, non-complement.
no, you're going up a different track. See, for doing a single antigen bead antibody, we advise people on a disease donor waiting list to do SABs and wait. That should give you a clue as to what is different between this and flow cytometry. We advise people on disease donor antibody waiting list to do SABs, right?
Yes.
Why? Why do we do that? So we'll know by the degree of sensitization, we'll know CPRA, we'll know when we get a donor to see whether the HLA of the donor this recipient has antibodies towards it. Whereas flow cytometry, you're actually taking the donor cells and looking for antibodies against it. In one, you're not actually looking at the donor cells at all.
Yes.
Okay. So that's a fundamental difference between the two. This patient, you said, had a biopsy and was given 3 injections followed by 2 injections.
Yes.
What do you think the 3 injections were and the 2 injections were?
Actually, the 3 injections that were given back to back, she was told that first we'll see the response for that injection. And if she does not respond to it, she would require further treatment. So on the basis of that history, it is presumed that it is probably methylprednisolone pulse that was given.
Okay, and then there were 2 injections given 3 days.
Yes, so and consider she has given history that those injections were expensive, so it can either be ATG or IVIG. Usually ATG is not given at 2 weeks gap. So it is presumed that it is IVIG probably that she was given.
Okay, let's assume it's IVIG. What's the total?
Rituximab is given 2 weeks.
She usually for antibody mediated rejection, the rituximab dose that has been advised is single dose of 375 mg per meter square.
So how much IVIG would you think you should give for this patient?
So the dose that has been recommended is 300 mg per kg given once in 2 weeks for a repeated periodically for up to total of 3 months. So, but in a chronic antibody mediated rejection, the grading is low for this.
See, that's another
Total cumulative dose.
Sorry, sir.
cumulative dose.
In in active antibody mediated rejection, the cumulative dose is 2 gram per kg body weight.
Ma'am, go ahead, ma'am.
No. See, can you find out what was the dose? Do you know how much one IVIG vial contains?
Ma'am,
If
there
you
are
had got, you would have known. No, the commonest one in India.
5 grams.
So if you had asked how many vials, that might have given you the idea with the
So she
dose.
received around 30 grams.
Okay. She received how many vials?
30 grams on follow-up during hospital stay. She received 30 grams, total of 60 grams. She weighs around 55 kgs. 1 gram per kg.
The other question which was asked even from the initial, this is a 19-year-old girl. Can you, by looking at her, by taking a clinical examination, tell us when actually the kidney disease started?
So
It's
if,
very easy to do in a pediatric child.
if there is a height restriction,
Was she all right?
her height is 158 centimeters.
So also asked, what is classical with an interstitial nephritis child and a glomerular disease child, which is more common? What kind of problem you see in them more common if they have a chronic interstitial nephritis?
So anemia,
Anemia is there.
then they'll usually be lean and dry.
What is the other problem? What is the
Salt
absorption of
wasting.
interstitial?
Sorry, ma'am?
Interstitial
What is the
nephritis.
most common complications when compared to the glomerular?
What does it? If you say this is an interstitial problem, just two, three functions is related to interstitial.
Salt wasting.
Salt wasting.
Then salt
Erythropoietin?
sensitive hypertension is seen.
Erythropoietin, then
Anemia.
two more.
Still, mineral bone disease.
Yes. And what is the tubules do? Another function which we don't do besides salt and fluid.
Nocturia and
Metabolic acidosis is much commoner in this case. So that would have, as you said, was the child with breathless.
Does the urine output at the time of transplantation?
That's right.
she says that prior to onset of initiation of dialysis, during the course of illness, she did not have any oliguria. However, after initiation of dialysis, she has developed oliguria with residual urine output variables.
At the time of presentation, she had normal urine.
She had normal urine output.
Would you think TMA people with vascular involvement will not have that kind of?
So your differential diagnosis is actually quite big and quite vague. And,
The most common is interstitial disease. Most common is interstitial disease. So presuming this as an interstitial disease. Yeah.
Your differential diagnosis are actually quite big and vague also at the same time. I was wondering actually how you could come to an anti-GBM disease and these things. I don't know. You please don't give such a super class statements and bigger differential diagnosis, which are not compatible. And also, they're not commensurating with whatever they presented. So don't do such an exotic statements. If their differential diagnosis is not good, unless you are quite confident and in supporting evidence of having your own.
Or you say native kidney disease unknown.
That is also okay. Presume CG and CNs are okay.
When
Even
you
put
say
a
it's
differential
chronic
diagnosis,
IgA,
CN, CGN also okay.
Yeah.
But don't get some of the things which are no way related to the context.
more male preponderance is seen with chronic IgA.
Yes,
than at
yes.
female. So in female, it's interstitial disease more. So what are all the different presentations of reflex nephropathy? How can they present actually? Can they present this late?
Yes. So congenital anomaly of kidney and urinary tract, they can present with ESRD up to the age of 30 years also, 30 to 40 years also. So in the infancy and childhood, the predominant complaints would be in the infancy, the predominant complaint would be excessive crying during micturition or noticing an abdominal mass or abdominal fullness. And later on as they pass, the mother would notice poor stream of urine, nocturnal enuresis, and having to double void urine. And further on, recurrent urinary tract history of infection also will be there. And the patient will can also develop growth disturbances related to development of CKD. Other than that,
See, if they are not presented in the first decade, they can directly present with ESRD in the second decade also. Sometimes they can present with an AKI superimposed on CKD and presenting with calculation disease. That is also one of the manifestations of reflex.
Okay.
So assuming this as a chronic interstitial nephritis and there is no clue for you also, how to confirm your diagnosis? What is the investigation you will do to confirm your reflex nephropathy? Even your MCUG might have shown a normal picture. Then how will confirm?
DMSS scan will show scarring of the kidneys.
A question that Santosh asked: why is hypertension not common in anti-GBM disease? Which are the glomerular diseases where you don't see hypertension? And that gives you a clue. Why is hypertension not common in anti-GBM? Have you thought of it? And is it a good marker or a poor prognostic marker?
You have another antibody.
Finally, what do you think is happening with the kidney?
Right now, she has presented immediately, like
If you
during
you use the words chronic allograft rejection, we don't use those words anymore.
chronic allograft injury.
With your biopsy, you said IVIG has been given, did not respond to methylprednisolone. So you have to tell us whether it's an AMR. If so, is it acute? We don't use the word active. I mean, acute and chronic active or chronic AMR.
Yes.
What do you
So,
think is happening?
Considering since the last 8 months the graft dysfunction is persistent, it is probably chronic ABMR.
What do you think precipitated this AMR?
So, COVID has been known to precipitate.
Do you have any data from India on this?
There are publications.
Any data to say COVID precipitates chronic AMR?
Indian data, I haven't seen them. I had read a systematic review of multiple data from abroad.
There is a data from one. And you said during COVID, what was her immunosuppression given to her?
During COVID, she has, I asked her specifically, she's told that she hasn't changed her immunosuppression. So that is why immunosuppression not being compliant to it and that precipitating rejection seems less likely. She was also following up regularly.
The second biopsy was the same, nothing more.
She was told to have the same finding.
Manisha, is it okay?
We have support that.
What is the complete diagnosis at the end?
Post-transplant persistent allograft dysfunction due to chronic antibody-mediated rejections, precipitated.
That will be the diagnosis.
So total. So 23-year-old
diagnosis. Diagnosis is not the age, demographics, political affiliation. We don't want to know all this.
Chronic interstitial nephritis, CKD, stage 5.
Yes.
Live renal transplant recipient.
Or would you like to say somewhere else, something else that you say?
Post live renal ABO compatible transplantation with the CKD, ESRD due to CIN, with the persistent allograft dysfunction due to chronic antibody.
Post-COVID state.
Post-COVID.
How do you say if I say it's CKD 5T?
CKD 5, sorry, ma'am. CKD-T is the term used for transplant.
Is it? Or something else? Chronic kidney is transplant patients considered to be CKD forever or we change?
Yes, ma'am, they're considered to be CKD as per KDIGO recent.
Keep the diagnosis properly. You have to write also in the notes and you have to tell also properly. Live related renal transplant recipient. Father was the donor. The later kidney disease of presumed chronic interstitial nephritis and the post-COVID status with renal dysfunction that probably chronic AVMR.
Chronic AVMR.
Okay. And any other infection between?
Other than COVID, no
No
other.
other
She had an acute gastroenteritis episode, but she was evaluated and told to have no CMV.
No, but she no CMV. You thought
Yes.
that was no CMV status, isn't it? So when it was discussed to you and you said the non-immunological causes of allograft dysfunction, you only mentioned BKV. What are the other viruses which can cause allograft
CMV itself can cause immunoactivation. It can predispose to other infections and allograft rejection also.
Can it cause chronic kidney disease by itself, allograft dysfunction without infection?
CMV invasion of the kidney is a known.
Seen that?
I haven't seen
tubular
personally.
dissociation
No, I
fibrosis?
haven't seen.
What are the viruses that can lead to gastritis in post-transplant?
So, norovirus and CMV, then rotavirus.
Data from India.
India,
You all have to know what is the data from India.
yes.
All have to.
I have seen one study from BHU.
BHU.
NIMS has a data. You have data from there.
Madam, Mike, all
But
of
there is
us
data
interested.
from here also. Like the transplant COVID infection, there is a very good data follow-up from Mumbai. So they have shown acute kidney injury post-COVID and almost 50% of their transplants had AMR.
And then COVID, if you say Vivek Kutte and all, 99.99% will be correct.
Very close. This was Divya Bajpayee, of course. It was not Vivek Kutte.
So 99.99% will be correct.
Only 1%. Yeah. So what are the ways COVID-19 infection affects the kidney?
So, it can cause acute cortical necrosis, thrombotic microangiopathy,
That's
collapsing
we start
glomerular.
with the commonest things in here.
Minimal change disease. Then
What is the commonest way COVID-19 affects the kidney?
acute tubular necrosis and AKI.
We use the word acute AKI. The word is
AKI.
acute kidney injury or acute tubular injury. Necrosis is biopsy finding.
Yes.
You have not biopsied them.
Yes, AKI.
Then
Minimal change disease, glomerular involvement, minimal change disease.
in which what is the common glomerular disease which you have seen? Is it minimal change or something else?
Collapsing glomerulopathy,
Go to that later. What is the other one? See, you don't go into
quasi-immune
that.
crescent.
Give the examiner time to ask you questions rather than you answering everything. So
Quasi-immune crescentic glomerular.
TMA is more common.
TMA also. Same.
So FSGS collapsing. Is there any literature from India about collapsing gene?
I'm not aware.
What precipitates collapsing gene? What is the pathophysiology of collapsing glomerulopathy in COVID-19?
So, ischemia due to endothelial injury, it causes.
Is there any underlying genetic mutation which is shown to predispose collapsing glomerulopathy?
ACE2 overexpression is associated.
More common.
Anyone from upstairs? Extenders, please.
Santosh sir.
Santosh sir.
That's Santosh, Dr. Ravindra Prabhu.
Santosh, Ravindra, can you ask something? We still have 10 minutes to drill out.
Sir, please go ahead, sir.
Ravindra?
How do you manage ABMR?
So ABMR, it depends upon the timing of presentation and whether it is the DSA class also. So if it is early ABMR presenting within the first 3 months of transplantation and the HLA is class 1 HLA donor specific antibodies, then we have to treat them with the steroid pulses along with the plasmapheresis at least 5 to 6 sessions. The number of sessions is decided by the DSA titers, and along with plasmapheresis, IVIG 2 gram per kg also has to be given. That is given at the end of plasmapheresis, or after each session of plasmapheresis, 100 mg per kg of IVIG can also be given. It is also said that rituximab can be given as an adjunctive therapy. The usual recommended dose is 375 mg per meter square single dose. And if it is a If it is an antibody mediated rejection that is associated with HLA class 2 DSA, and if there are features of chronicity, then in such cases it is recommended to optimize the immunosuppression, where the tacrolimus levels have to be maintained above 5 at least. And if the patient is on azathioprine, then it is better to convert them to mycophenolate mofetil, and steroid dose also has to be optimized.
Any other medications may not be available here, which you know of?
So complement inhibition.
It's a very high levels of DSA are there. So what medications could be used?
So complement inhibition with eculizumab can be done, and the other drug that has been told is one is if it is plasma rich infiltrates, then bortezomib also can be tried, and the other drug that has been said to be useful is IDIS, imlifidase.
Yeah, what does that do?
So it is a streptococcal pyogenes enzyme which degrades immunoglobulins.
What enzyme?
IBIS, the name itself is.
Yeah. Okay. Okay, madam.
Thanks.
Thank you very much.
Thank you.
Madam, she will be doing 2 short cases. Each short case is for half an hour.
So is it okay? The first case you present, second one you just summarize and let us know.
But take half an hour.
Half an hour.
I will be presenting a case of Sakshit, who is a 7-year-old male child, second born of a non-consanguineously married couple. They reside in Kachiguda, Hyderabad. He's studying UKG. His informant is mother.
Sakshit,
7 years. The mother is a 32-year-old lady, studied up to inter second year, and patient is actually currently asymptomatic and was admitted for a renal biopsy. I would like to date back the history. I would like to come from the antenatal period where it was relatively uneventful, and his birth weight was 3 kgs. He did not have any eventful postnatal history. And he had normal developmental milestones that he has achieved according to his peers, and also was vaccinated up to 9th month according to the standard immunization schedule. He was first symptomatic when he was at the age of 1 year 8 months, where he presented with swelling of the periorbital puffiness, abdominal distension, which gradually progressed to anasarca or generalized edema over the next 15 days. He also complained of excessive frothing of urine, and there was associated reduced frequency of urination, which the mother noticed. There was no history of associated fever, rash, or cola-colored urine. There was no preceding history of a sore throat or acute febrile illness, seizures, or crying during micturition. There was no history of any allergies or recent vaccination prior to this episode. He was evaluated and was told that there was protein leak in the urine, and was given omnacotl syrup, which was taken twice a day, and also was given albumin infusions. The mother was educated, so she knew all the medications. The dose of omnacotl was slowly tapered over the next 2 months, and the mother noticed that once they started making it alternate day, 10 to 15 days after the tapering was started, baby had increased swelling of the limbs and periorbital puffiness. At that time, he was taken to the hospital again, and the dose of omnacotl was increased. Then gradually it was tapered more slowly over the next 2 to 3 months. And he had his first relapse again in December 2017. His symptoms started in August. So before 6 months of completion of therapy itself, he had 2 episodes of relapse.
It almost sounds like a steroid dependent.
Yes.
No, relapses though doesn't matter. It's almost, you have to say it's frequent relapsing because it's dependent. No?
Yes, ma'am. He's dependent on the steroid. Whenever they were tapering the steroid, twice within
Then
6
after
months,
that-
he had
after that, this is the third time he's getting treated.
second time. First time in
in-
August
okay.
2017 at the age of 1 year, 8 months.
So they
he
gave
was
it for 2 months while tapering.
tapering.
And then
He
they
had
increased it.
no, they had
And then they
increased it.
stopped it completely.
Not stop now. It was they were tapering it slower in a slower rate. During tapering, again he had symptoms of edema, for which he was admitted at this point in time, and a biopsy was done, and he was all started on an alternative medicine. That is
Sorry, one quick clarification.
Yes.
The relapse in December was while on steroids or after
while on
stopping
steroids.
steroids?
While on steroids.
How much dose?
When he was being tapered, it was
What is
around, he was taking omnacotyl syrup, which was made alternate day. Daily dose was reduced to alternate day, and 2 weeks later, he developed symptoms again.
Mother doesn't know the dose. I think.
Dose, she said
Syrup,
5
how many
ml.
5 ml is how many milligrams?
Each ml is 5 ml.
Find out all these things.
Syrup.
5 ml is almost 10 milligrams.
10 ml.
Then?
Patient was started. He was started on
Santosh, it was,
tacrolimus.
the child is steroid dependent, and then they biopsied again. The biopsy
No,
was,
first
I think,
biopsy.
First biopsy.
first biopsy, I think, for starting tacrolimus. That's the reason this
Yes, ma'am.
biopsy.
A biopsy was done, and he was started on tacrolimus, which was given at a dose of 1 mg and 0.5 mg, and the oral steroid was started to taper off. And after 1 year of starting tacrolimus,
Steroid was stopped.
not stopped, ma'am. It was at a minimal dose of 2.5 mg alternative. At that time, baby developed varicella infection. He had chicken pox, and mother said that it was quite severe, for which all the immunosuppression was stopped and was admitted and treated for the same. And after recovery, he was reinitiated on oral steroid, but tacrolimus was not reinitiated. Over follow-up in the next few months or 2 months, patient was reinitiated on tacrolimus in a low dose of 0.5 mg.
This time steroids?
Steroid was there. He
Same
was taking,
2.5?
no ma'am, he was taking 10 mg. And after tacrolimus was started, they started to taper the steroid at a slower pace, and he was asymptomatic from December 2018 to September 2021.
And throughout this period, the child is
He
on
had-
the child is on tacrolimus and steroids.
Yes, ma'am, both tacrolimus and steroid.
And steroids 10 milligram and
No, ma'am, taper to 2.5 mg alternative.
and tacrolimus 1 and 0.5.
0.5 was introduced, which was later increased to 1 mg BD.
September 21. I mean, till 6 months back, the child was asymptomatic.
Child was asymptomatic. In September, he had developed fever with cold and sore throat, and he had an increased swelling of the limbs and periorbital puffiness, and was the dose of the steroid was increased at this point in time after treating the infection, and the tacrolimus dose was continued at 1 mg and 1 mg. After monitoring of the TAC levels, the TAC dose was continued at the same level, and steroid was slowly tapered and stopped.
Okay, this time.
Yes, ma'am. This time it was stopped. After stopping the steroid, since patient was asymptomatic, they were advised to get a genetic testing done, and which was done, and the mother does not know the exact report of what has happened. But now he currently is asymptomatic on only tacrolimus, 1 mg BD, and also was admitted for a re-biopsy. Coming to the family history, there was not significant family history. He was second in order of birth. His elder brother is there, 12-year-old, who is completely asymptomatic. And coming to the personal history, he has a mixed diet, normal bowel and bladder habits, and his education, he's doing his UKG.
But you so obsessed that he's in UKG.
Don't worry, he has a full life to get educated. Don't worry.
Only thing is because he was not well and due to COVID, he
Was
was
it not
not.
7 years upper KG? What is happening?
But he was doing well.
He failed in the semester.
Is now examination anything that you want to say from the examination?
There was only cushingoid facies, ma'am. Other than that,
growth.
His weight was 75 percentile of expected, but the height is less than 25 percentile.
What is the height?
Height was
What is the weight?
weight was 25 kg, sir. His age is 7 years, and height is 116 centimeter. So
What is the
according
expected
to
height?
116 centimeter.
What's his expected height?
Expected height is around 125, 123 to 125.
No, it's 119. No, it's his
120.
age is 7 years, right?
7 years.
7 years.
120.
So 6y plus 77. This 42 plus 77 is 119. No?
So,
119.
There's a nomogram, he said, no?
Yes.
Go on.
This is a child of idiopathic nephrotic syndrome, steroid dependent, CNI responsive with frequent relapse.
You said that it's the second one, and that too, the first one is the age of 1 year, 8 months. Now
Yes.
7 years.
Yeah.
How
No,
many
he's
episodes?
going on treated, sir.
He's
not
on
stopped. Non-stop medicines, not stop, no episode.
But why you said
No, he's-
frequent relapses?
No, she stopped it at that.
While withdrawing, he relaxed.
Initially,
steroid
that is
dependent.
steroid
Steroid
dependent.
dependent.
Yes,
Steroid
it is steroid dependent nephrotic syndrome.
Santosh, you want to ask something? Why do you biopsy a steroid-dependent nephrotic syndrome? What are the indications for a biopsy?
Actually, indications for biopsy in a child is more than 12 years of age presenting with nephrotic syndrome or a steroid resistant nephrotic syndrome. If there is any family history of a genetic cause for nephrotic syndrome or an FSGS in the family, or any abnormal facies, syndromic facies at presentation with nephrotic syndrome may require a genetic analysis.
Less than 1 year? What is the
Less
if the
than
child
1
is
year,
born less
yes,
than
ma'am.
1 year?
Less than 1 year, if you are suspecting congenital or infantile nephrotic syndrome, genetic analysis is.
Less than 1 year, what is the commonest biopsy finding? In our part of the world, is there any data? There is data from India on this. Ravindra,
Diffuse
Santosh,
mesangial sclerosis is the most common.
So did you inquire what was the preceding event every time before he gets into relapse?
Yes, sir.
When-
One was tapering of steroid, and the other is whenever he had an episode of infection, he had relapse, increased.
What is the data related to the steroid therapy during any infection in a child who has been on treatment for nephrotic syndrome?
Yes, sir. A low dose, short course of steroid is recommended by
For example,
KDIGO
he's been
for
taking around say 10 milligrams of steroid for this long. And what will you do if the patient has a fever and URTA like this?
How much
we
you
can
will increase the
increase
steroids?
the steroid. 0.5 mg per kg of steroid can be introduced, or the dose can be increased by.
See, in your clinical practice, I need to say that.
You will tell the
Yes.
parents to change it whenever he gets some URTA.
Yes, sir. We have to counsel the patient, attenders, I mean, the parents also, that whenever he has an acute febrile illness, the dose of steroid should be increased for a short
What is
duration
the
of
literature
5 to
evidence
7
for that?
Again from India, a very good paper. When Indians have been part of. Hey, Ravindra Prabhu, you're unusually silent.
So in this age group, what is the normal percentage of response to steroids and how early it comes?
Sir,
To take
90%
100
of
patients with the nephrotic syndrome, what would we expect?
yes, sir. 90% of the children of this age group will respond to steroid, and most of them are early responders.
By what time? 4 weeks?
4 weeks. Early responders before
And
by
then
4
by
weeks.
another 4 weeks, how much more?
Almost 98%, 97% of them will respond by 6 weeks.
8 weeks.
When you call it a steroid resistance.
What are the different strategies for steroid dependent? What are the different treatments available apart from what they have given now?
Yes, sir. Steroid dependent nephrotic syndrome, second line therapy can be initiated after he achieves remission with the high dose steroid. The second line therapy most commonly used are cyclophosphamide, levamisole, MMF, or CNIs can be used, and rituximab can also be used for maintaining the remission.
What is the strategy this child used? Did you
Same.
come down to remission and then start the medicine? Or, I mean, then start tacrolimus, or tacrolimus was continued and the child was still having some proteinuria? Did you find that?
Actually, with tacrolimus, he had good response, ma'am.
No, when
but
they started tacrolimus, was the child dipstick free?
Did he achieve remission?
No. He had a relapse. Biopsy was done, dose of the steroid, and it was increased, and tacrolimus
That's
was
a confusion we have, no? The child was, as you said, on alternate day steroids.
He had a relapse.
He had a relapse means he became dipstick positive. How do you treat such a situation? If your child who is on alternate day steroids has again relapsed, that means he's become, what is the definition of relapse?
Relapse is more than 200 milligrams nephrotic relapse.
How do you monitor a child who's been on treatment? This child, the mother is educated, but what should you tell the mother to monitor this child? How do you do that?
We have to monitor the weight of the patient.
Can you not ask them to monitor with a dipstick? That's what we asked. No? And what is our Indian Academy of
3+.
Pediatrics definition of relapse?
3+.
How many days?
For 3 consecutive samples or 3 consecutive days, if it is positive. 3+ in dipstick urine. It is
Same. This child, when tacrolimus was started, was it 3+ or he was trace or negative? As Ravindra asked, what is the strategy? How do you treat this kind of steroid dependence?
Steroid dependence, first we increase the dose of steroid. If there is no features of steroid toxicity, then the dose of steroid is increased, and we can add a second line therapy like cyclophosphamide, levamisole,
Increase
or
the dose of
MMF.
steroids, rapidly taper it off when the child becomes dipstick negative.
Yes.
And then add a, depending on how many days. And so, child, what was the first biopsy?
Cyclophosphamide, how many days you'll give in steroid dependent?
12 months, minimum of 12 months, 1 year is recommended.
12 months, cyclophosphamide.
Not TAC, cyclophosphamide.
Not cyclosporine.
Not cyclosporine. He wanted to know cyclophosphamide.
12 weeks.
Yes, 12
I
weeks.
actually the planning biopsy, it was not done before, no?
Second time. This is
Second time.
Second time biopsy.
Why do you think they're
want to
doing a
do second
biopsy?
If a child is on tacrolimus or CNIs for more than 2 to 3 years, and
Is there
biopsy
data
can
on
be
that
increased.
also? That biopsy? What is the data? Re-biopsying a child on long-term CNI? What would you give the child now? Is there anything new which you can give these kids? If it is
Rituximab can be given to reduce the steroid side effects because his growth pattern is also.
Rituximab in children, in Indian children.
very good.
Rituximab,
Okay.
steroid dependent
Nephrotic syndrome.
nephrotic syndrome in India.
India.
One protocol is rituximab given weekly for 4 weeks.
From how did you derive all these protocols?
Randomized control.
No, I'm looking for the key. How did, from where did you derive all these protocols for minimal change disease?
Minimal.
Why did you propose rituximab in nephrotic syndrome children? How did they come to a
What is the underlying pathophysiology to
Yes.
believe that rituximab will help children with nephrotic syndrome? Steroid dependent.
In usually in nephrotic syndrome, T cell activation and cytokine dysfunction was initially thought to be the pathological process. But now with the T cell activation, B cells, the activation of B cells is also increased because of the T cell activation and causing podocyte injury. So that is the basic.
Is it effective in children?
Yes. Rituximab.
What percentage of these minimal change disease in children will become FSGS later?
20.
Is there any difference in the tendency for the development of FSGS in those children who are pure MCD versus all those sometimes with IgM?
Nephropathy.
Yes.
Mesangial
It is thought that MCD, IgM nephropathy, and FSGS are a part of a single.
No, sir, also
phenotype.
say your biopsy shows plain MCD, IF negative. Other one shows plain minimal change, IgM positive.
IgM positive.
Patients with MCD and IgM positive have more chance of going into FSGS when compared to IF negative.
How many glomeruli are required for you to say that you did not miss the diagnosis of FSGS?
20 glomeruli.
You have 20, but still what percentage of chances of you missing the diagnosis?
Yes, sir, because the juxtaglomerular, juxtamedullary, if we do not get that piece of the biopsy, then
What percentage of patients with FSGS would have a family history of FSGS?
5%.
So how do you define familial FSGS?
Read this up.
In
Familial
gen-
FSGS.
What are the common mutations involved in?
Most common FSGS genetic mutations are autosomal recessive or dominant mutations can be there. In autosomal recessive, MPHS1, MPHS2, and PLC3, PLC6, and in autosomal dominant, there is TRPC6 and ACTN4 and WTN1. So most common is NPHS2 more than NPHS1 more than WT1, and the last is
When do they present
This
at
is the
what
same
age for
thing
this
you asked
particular
me.
age?
So I asked her, what is the rationale? Forget it, if you'll ask me later. Do you know of any antibodies responsible for minimal change disease?
antinephrin antibodies can be present.
Can there be any part of the syndrome actually, the genetic mutations you mentioned? Can
Yes,
there be
ma'am.
part of any some syndromes?
Yes, ma'am. Inherited syndromes like nail patella or Dennis Dash and Galloway-Mott syndrome can be associated with nephrotic syndrome.
Can they be associated with conflicts?
Alphorts, yes.
Yes, no, you have to tell. Is there any association of alphorts with the nephrotic syndrome?
And
So the
Other case.
other case will have to.
Ravindra, can we do the Ravindra Santosh, can we have a brief summary of the second case and then you can ask questions?
Yeah. Now, levamisole, how to use? You told levamisole, no?
yes, sir. Levamisole is given at a dose of 2 to 2.5 milligrams per kg, a minimum of 1 year.
Daily or alternate days?
Alternate day.
Yes. What is the problem with levamisole?
It can, we have to monitor liver function tests and also ANCA in patients who are taking liver.
Complications, levamisole complications. It can cause a reversible neutropenia, agranulocytosis, neutropenia. Why do you monitor ANCA titers there?
Levamisole is one of the it is a drug that can precipitate P-ANCA.
It causes cutaneous vasculitis and arthritis. So that can be predicted by monitoring every 6 months the ANCA titer. If the ANCA titers are high, you should stop it.
Yeah.
Otherwise, the advantage is it's a cheap drug, and if it is given over maybe 12 to 18 months, it seems to reduce the number of relapses or completely stop them. And sometimes when you stop the levamisole, there may be an immediate relapse, which indicates that it was working. Okay, please go ahead with the next case.
Just summarize the case.
I have a 40-year-old gentleman who is a water service man from Nalgonda. He has a history of bilateral renal stone disease, which was detected 3 years back, for which he underwent interventions like ESWL and bilateral DJ stenting, for which he was on regular DJ stent exchanges every 6 months. And he had 2.5 years back, he had noticed a right scrotal swelling, which was right scrotal swelling, which was gradually increasing in size over 4 months, which was not associated with pain or tenderness, but had some pus discharge, for which he came to came for medical attention, and he was also having complaints of recurrent urinary tract infections, which were associated with persistent lower urinary tract symptoms like increased frequency, nocturia, and hematuria. During the course of the last 3 years, he had acute worsening of chronic kidney disease on 2 occasions requiring renal replacement therapy, and now presented with uremic symptoms and was initiated on hemodialysis. This is the brief summary.
Santosh?
So what is your diagnosis?
Sir can go first. Sir, please go first.
That is you.
Can you just summarize again? I just missed the last part.
Yes, sir. He's a middle-aged man, 40-year-old gentleman from Nalgonda with history of bilateral renal stone disease, for which he underwent ESWL and bilateral DJ stenting, and had history of recurrent urinary tract infections, and also noticed a right-sided scrotal swelling 2.5 years ago, and which was not associated with pain or tenderness, gradually increasing in size. There was some pus discharge from the scrotal area. He also had complaints of lower urinary tract symptoms like increased frequency, poor stream of urine, and on and off hematuria, with history of acute worsening of the stream of urine and recurrent urinary tract infections on 2 occasions requiring renal replacement therapy. Now presented with symptoms suggestive of uremia, and was initiated on dialysis through a right IJV access.
So what do you think is the diagnosis?
Sir, I think it is an obstructive uropathy secondary to renal stone disease, so which has progressed to a chronic interstitial nephritis and CKD, end-stage renal disease. And also the right scrotal swelling with underlying history of recurrent urinary tract infections. I would like to consider tuberculosis, genitourinary tuberculosis also.
Why do you think genitourinary tuberculosis is a stone disease, right?
Stone disease.
DUTP
Yes.
presents with stones. The initiating event here is stones, bilateral stones.
Yes, sir.
What's the age, patient age?
40-year-old.
40-year-old. Okay.
Non-diabetic, non-hypertensive.
Actually, why do you think that the scrotal ulceration pus discharge from the scrotum
He
is to
had
do with the tuberculosis?
he had history of ATT.
Tell that.
That you can tell. Do you think the particular scrotal ulceration is related to tuberculosis? Diagnosed
Yes, sir.
scrotum?
Because he had a scrotal swelling which increased in size over 4 months. It was non-tender and there was no associated pain, but there was some pus point and discharge from the area as well, for which he had to undergo surgery.
It's something like the sinus formation.
Yes, sir.
Okay, perennial sinuses tuberculosis can be suspected, but not the scrotum alone.
Yes.
So if the scrotum ulcer is there, tuberculosis can be suspected depending on the duration and the sinuses. First discharging sinuses for a long-standing duration in this country, even in a non-diabetic person, tuberculosis is supposed to be suspected.
Yes.
But you are repeatedly telling recurrent UTI, recurrent UTI. So what do you mean by recurrent UTI? Recurrent?
Recurrent UTIs are an episode of symptomatic urinary tract infection of more than 2 episodes in 6 months or more than or equal to 3 episodes in 1 year.
Then did you check with him how many episodes he had in 6 months and 1 year?
In 1 year, he had 2 episodes, sir. After that, he didn't.
But don't you think otherwise also the patient
Yes.
with recurrent UTI and again the tuberculosis is suspected, no? Otherwise. So
Yes,
what are
sir.
the other features of tuberculosis which he had?
One is he had persistent lower urinary tract symptoms, sir. That could be secondary to a stone disease or the recurrent urinary tract infections causing a stricture, which has caused these lower urinary tract symptoms. So that the scrotal swelling and lower urinary tract symptoms are going in favor of.
What is
obstruction.
common? Is it stricture that is causing a problem, and what are the other involvement of tuberculosis which can manifest with low urinary tract symptoms?
He can have epididymitis, and prostate.
What is thimble bladder?
Thimble bladder is a small contracted bladder because of pancystitis happens. Pancystitis develops in tuberculosis, which can cause fibrosis, healing fibrosis and contracture, which causes the capacity of the bladder to be low and this.
So again, we go back to Ravindra Prabhu's question. How do you explain these stones in this patient? He said the initial presentation was stones.
Yes, sir. He's from Nalgonda, and also
Nalgonda means stones have to be
no,
there.
his
That's
source
right.
of water, drinking water is also a groundwater source of drinking water.
Now the
So-
situation has changed.
That situation is not there actually.
Yes.
No. It has not
He's
been there for more than a year.
And if it is a genitourinary tuberculosis,
Yeah.
if
Santosh?
it's present.
Santosh?
So can continue, sir, after I ask. So please continue.
No, she's actually answering back to the reason. What is causing the stones in this vein? What are the pathophysiology of renal stones in this vein?
Ravindra Prabhu sir can continue. He was
And secondly,
after that ask.
how do you explain uremia in this kind of end-stage kidney disease in this case?
It has progressed over 3 years, ma'am. He already had renal stone disease at presentation
Still it
and
is
small
acute
size.
or ESRD?
It could be.
He's on MS.
He was
Doesn't have to
initiated
become a-
recently.
No, that's
Then how
another
long he has
question.
been on
sir.
dialysis now?
He was recently 1 month back. He was initiated, sir. But twice when 2 occasions he had acute kidney injury and dialysis was done. First time he had presented with a creatinine of 14 and was initiated on dialysis. He continued for 2 months, following which he had recovery.
What percentage of patients on intensive dialysis in our country are secondary to the obstructive uropathy, secondary to kidney stone disease?
Obstructive uropathy around
Stone
15%.
Secondary to
10
stone disease, ESRD, how many on the intensive dialysis? The data. Yeah.
Again, there is data. No, the thing is, what Dr. Bhushan was asking, would you make this patient say ESKD now completely?
It could be an acute and chronic kidney disease.
Again, why the stones, not Nalgonda?
Recurrent urinary tract infections can precipitate stones in this patient and also stasis because of the stricture or the lower
Where
urinary
is,
tract.
now, this patient, what investigations would you want before you What is the investigation you want to? He is here, if you have started dialysis and you say it's obstructive uropathy. What investigation would you want to do? You would still have to, what if I say this is oxalosis? To the patient with tuberculosis.
Metabolic workup for stone disease.
Even
can be
then, first is your question of is this reversible or not? That's the first thing you have to do.
an ultrasound abdomen to rule out obstructive uropathy, but he was already on a regular DJ stenting and recent.
Do you think stents don't block?
Yes, ma'am.
What kind of stents he was on? Are you aware of permanent stents?
Yes,
He was on, and his stent exchange was happening every
3 months actually, but he was coming late for follow-up, so around 6 months. He had 2 episodes of urinary tract infection because of his preterm stent.
What if I see the stents have moved out? Ultrasound will help you get that diagnosis, or you would
X-ray, KAP.
Besides
or,
X-ray, anything else?
CT.
CT also.
NCCT.
Santosh? Santosh or Ravindra, anybody?
Usual presentation of GUTB after supposing person has pulmonary tuberculosis, after how many years they get GUTB and how does it present? What are the percentage?
Yes, sir. Around 5 to 20 years after a pulmonary tuberculosis, patient can have genitourinary tuberculosis. Usual spread is through hematogenous, but also if
What percentage?
Around 9% of all UTIs can be genitourinary tuberculosis.
Not UTS. Pulmonary tuberculosis.
Yes.
How long means what percentage of people after pulmonary tuberculosis will get GUTB?
Around 10%, sir. But the time duration between pulmonary 20%. Time duration between pulmonary tuberculosis and genitourinary TB also is around mean of 5 to 20 years.
Yes. There are reports even after 45 years, 1 to 45 years the range. And hematogenous, okay. So
The most common presentation is epididymitis, sir. Seminal vesicles can also be involved. The prostate can be involved. The collecting duct, the pelvis, the ureters can be involved.
So renal parenchymal involvement will be in what form?
Renal parenchymal disease can usually the bacilli will get accumulated in the loop of
renal parenchymal involvement. If you biopsy the kidney, what will you see, if at all? This is a different issue. This is a collecting system tuberculosis. Looks like, isn't it?
Yes. Granulomas can be present in the renal interstitium, and sometimes secondary amyloidosis is also can be presenting as nephrotic syndrome, very rarely.
What do you mean by putty kidney?
Putty kidney is a chronic inflammatory state where the interstitium is replaced by the granulomatous inflammation, and the caseous necrosis will happen, which will look like a putty, cement-like.
And dystrophic?
Dystrophic calcification is the main. Yes.
And in the urinary tract, what do you see?
In the urinary tract, pancystitis can be present, involving all the layers of the urinary bladder, timbal bladder because of healing fibrosis. The ureters can have multiple strictures.
I mean, is there a way you can differentiate them from malignant strictures?
There is beading, multiple areas of strictures will be present in genitourinary tuberculosis. And the golf hole ureter, the healing with fibrosis resulting in a reflux ureter will be present in.
Anything? What are cavernomas?
What is frozen hearts hypothesis of tuberculosis? Frozen hearts.
Frozen hearts hypothesis of tuberculosis. What is a Trojan horse?
Frozen heart, it is in Troy, sorry, Hercules.
Not
There's
Hercules,
a-
anyway, the Helen of Troy. Then that's different. What is Trojan Hearts?
it is a hidden.
Anything, Ravindra? You almost got it.
No, in none of these description, the bilateral stones was there.
Yes.
So again, I come back to the same thing. Of
Right.
course, dystrophic calcification is there.
True.
So here you have bilateral stones and going in for an ESRD.
Yes.
TB may be there. So
It
in a
could be a
40-year-old.
different entity, or around 5 to 10% of genitourinary tuberculosis can cause stasis and precipitate stone formation. So,
So, Ravindra, the bilateral involvement is often seen when you develop a reflux, thimble bladder or a gall. Then it happens. Usually, GUTB is unilateral, and end stage is not very common. What percentage is bilateral GUTB?
less than 5.
So other than the genitourinary, does it have any other site of involvement? Of tuberculosis?
There is
Any other site of tuberculosis involvement in this patient?
no, sir. He does not give history of pulmonary symptoms.
But
There
in
is no.
constitutional symptoms as well?
No, sir. Only since the last 2-3 months he's having loss of appetite. There was no apparent weight loss or fever.
Spine, lungs, lymphadenopathy.
No lymphadenopathy.
What did you make out of how they made a diagnosis? Is the first discharge, they start taking from the sinus, or
They
probably
have-
a urinary bacterial culture or urine bacterial culture due tuberculosis?
He said that excision of the testis was removed and sent for testing.
Oh.
Yes.
It's a truly genital,
Testing.
truly genital urinary.
So the second question again, why tuberculosis is so common in India? So same question, if I have to transplant this patient, what will I do? What are the investigations?
Yes, ma'am.
Would you go
Before
by-
considering for transplant, patient should have completed or in at least the first 2 months of treatment for.
Is he on treatment now?
No, he's completed. And one more issue with the transplant in genitourinary tuberculosis is the strictures or the bladder problem. So first the bladder augmentation or uretroplasty has to be.
How do you know that he needs a bladder augmentation? Usable bladder definition. Yeah. How do you think? So the question is, in a person you're going for transplant.
Yeah.
What is the clinical presentation that you will guide you that you need to address and study the bladder? And second question is, after you have done all the investigations that you need to do for the bladder, how can you say that this bladder is usable? And if you believe this bladder is not usable, what can you do? Criteria for the usable bladder. What are the criteria?
Criteria for usable bladder is it should have a good capacity of bladder. The bladder pressure should not be high. Refluxing should not be present, and
what is the capacity? Minimum capacity?
200.
Read that. You see, these things are very important when you're going for transplant. The patient is going to pass 220 liters of urine.
Yes.
Would you be happy with a bladder with 100 ml of urine capacity? These things. So if it is not usable, what can you do?
Bladder augmentation surgeries with the
In
bowel
GUTB, in tuberculosis, when you have set up pancystitis bladder, do you think your patient, would you augment the bladder? Would you do a what is metrophenol? So would you do this because you always said this is a thimble bladder, pancystitis bladder? Or you would suggest something to this patient if he gets transplanted?
Suprapubic.
That's one. Why suprapubic?
And
the third thing is,
intermittent
last question,
self-catheterization.
how do you assess for a metabolic cause of this bilateral stones?
A 24-hour urinary
Please
evaluation
urine,
if
no
he
urine,
has urine output. Otherwise, serum oxalates and cystinosis
Serum
can
oxalate
be
values in a patient with chronic
eyes
kidney
and-
disease, end-stage kidney.
not really.
It is, it can be used in numbers. What, if the kidneys look good size? Have you ever heard of biopsying those kidneys? What is
Oxalate
Scheinman scoring?
crystals.
You know Scheinman scoring? But Shastri used to ask us this question very commonly. Scheinman scoring. That's all. Manjusha, time over.
Madam, another.
Hey, Santosh, you asked something, boss.
Yeah. So, taking off from the last discussion on hyperoxaluria, supposing you find this patient's stone is actually oxalate stones.
Yes.
How will you work up this patient for a transplantation?
Hyperoxalosis is a relative contraindication for transplant.
Because I was a student, we used to transplant oxalosis. Santosh will know, we all used to do it. Now I don't think it's a relative.
How will you first diagnose? How will you first proceed with your diagnosis of the condition, underlying condition?
Hyperoxalosis with 24-hour urinary oxalates and
This patient
citrate
is now in end stage, no?
Yes.
So it will be difficult to use 24-hour estimates.
Any
See-
test? How do you test for primary hyperoxaluria?
serum.
He's saying serum oxalosis level. Anything else?
Any genetic testing you can do?
Yes. Hyperoxalosis can.
Okay, fine. The genetic test shows that this patient's got primary hyperoxaluria type 1. Now what will you do?
You want to go very quickly, by kidney and liver simultaneously. Sorry,
Sir is asking two questions. I'll add to this question. Would you do nephrectomy? Would you do simultaneous liver kidney? Or would you do
Simultaneous
something
liver
else?
kidney transplant
Is that the
indicated.
way? Why? What will determine your simultaneous liver kidney? If I say liver first, then kidney. What is pros for liver before kidney and or simultaneous both?
What is deficient actually? In oxygen, primary oxygen. What is happening? Why is it?
Liver and then
What is the enzyme which is deficient? Where is produced?
liver. It is produced in the liver. That's why we do a simultaneous liver and kidney transplant.
Answer to me. Answer to me.
Answer to it.
Simultaneous liver and kidney transplant to be done in this patient.
So
In primary liver.
answer ma'am's question. Which would you prefer to do, liver first and then kidney, or both together?
Liver.
Why? If I say I do liver first, why liver first?
Think and answer. Why should you consider one?
Think, madam. Chenmai also asked, what is the deficiency? You said it's an enzyme which is deficient. Now, I say I'll do the liver first and then do kidney. Why? Not simultaneous.
If we do the kidney first, then since the liver is not producing the enzyme, more chances of recurrence in.
We are not doing kidney first at all. That we never do. We used to do when we were students, and I'll tell you how we used to do it. It was there's a thing we used to hyperdialyze them. Can you think why we used to hyperdialyze them? We used to dialyze them for 8 hours every day. Why?
To remove the.
Do you think oxalosis is just a kidney involvement? The systemic burden of oxalosis? Oxalate crystals. So, what we would like to do is we'll do the liver first, replace the enzyme, reduce the oxalate burden. Otherwise, you put the kidney, the whole oxalate in the body will come through the kidney and deposit into the new kidney. So, we would prefer to do a liver first, keep the patient on that. So, Santosh, you agree?
So if you're doing a simultaneous liver kidney, because that may be easier to get logistically, if you're listing, you get priority. What should you be careful about? What should you do to prevent the oxalate from getting deposited in the new kidney?
Hydration should be maintained in the patient to wash out and to prevent oxalate.
No, you can't wash out. You don't want the oxalate which is already there to reach the kidney.
It's
You
not
don't want it to
filter
reach
it out.
And citrate should be replaced to prevent.
Anything else? She's saying citrate. Anything else which dissolves oxalate or sort of prevents its supersaturation in the urine?
Potassium citrate and so bicarbonate.
How do you treat oxalosis? I mean, do you use any medicines for medical management of oxalate, primary hyperoxaluria?
Some vitamin.
He says B6. She said B6 and high dose B6 pyridoxal.
Is there any new therapy now? New branch of therapeutics?
Yes, just last month in Kidney International. It's a recent report.
A totally new branch of therapeutics, in which this is one of the earliest.
Just now, KIR, you should read it. Just now. Ravindra, tell me.
siRNA. Have you heard of siRNAs?
What is siRNA? What are the RNAs you know? Sorry, the last minute. So you know what are the RNAs you know?
mRNA.
You know mRNA, siRNA, ribosomal RNA. Now what is microRNA and what is siRNA? That's what this is a form of oligonucleotides which interfere with expression of the enzyme and all. Okay, read this up. This is a new therapy on this. Okay.
Fundus manifestations.
Yeah, fundus manifestation.
Okay.
The other thing we use is magnesium because magnesium also, high doses of magnesium prevents, solubilizes. Which drug causes hypomagnesemia?
Madam.
Which drug?
On, madam.
On it.
Could madam.
Battery gone. हमने कितना बोल दिया battery से डर गया Madam, I have increased a lot. Mic का battery हो गया हम लोग बहुत we had troubled the mic so much it has decided to go to sleep.
Next is a long case, madam.
Long case.
1 hour.
It's a long case, sir.
Ravindra Prabhu and Santosh, long case.
It's a long case.
Good afternoon, sir. Good afternoon, ma'am. I would like to present my case, ma'am, a long case. My patient, Mr. Rajeshwarachari, he is a 31-year-old male resident of Hyderabad. Informant being self and his mother. He is a laborer by occupation working in a dairy factory. He is a case of cadaveric renal allograft recipient done in year 2018.
Deceased donor. Don't use words. Cadaveric.
Deceased donor renal transplant case now came to the OPD for regular follow-up. I would like to date back his history from the year 2009 when he was 18 years of age. That time he used to complain of intermittent body ache and headache while working in the dairy factory. So for that he used to take a daily painkiller 2 to 3 and this he continues for next 2 to 3 years. However, he never consulted to the doctor for the same complaints. Then in 2014, that is after 5 years of the above presentation, when he was 23 years of age, he started noticing swelling over his both feet, which was gradual and progressive over a period of 1 month. He also noticed a puffiness of his face, and it was associated with gradual decrease in the frequency of micturition. He also complained of anorexia and generalized weakness at this time. At this time, he denies any history of fever, burning micturition, cough, cold. There was no history of shortness of breath or orthopnea. There was no history of any abdominal pain, vomiting. On inquiry, he gives history of nocturia since last past 2 years. but he denies any history of recurrent urinary tract infection in the childhood. There was no history of bed wetting or a double voiding in the childhood. There was no history of graveluria. For the above complaint, he consulted to the general physician nearby, and on investigation, he was told that there is some renal dysfunction, and he was referred to the nephrologist. After consulting to the nephrologist and on investigation, he was found that his renal functions were deranged such that his serum creatinine level was 8 milligram roughly, and he was told that his both the kidneys are small and shrunken. In view of the fluid overload and anorexia, that is uremic symptom, he was initiated on hemodialysis via right IJV non-tunnel catheter. He received, during hospitalization, he received total 3 sessions of dialysis and was discharged after doing right brachiocephalic AV fistula. He was discharged on maintenance hemodialysis. He was taking maintenance hemodialysis 2 times per week, initially via non-tunnel catheter. Later on, he was started on right brachiocephalic AV fistula. During his maintenance hemodialysis period, his residual urine output was 500 ml per day. There was no history of any intradialytic or interdialytic hypotension or hypertension. During this period, he completed his hepatitis B vaccination, but he never received the pneumococcal vaccination. And there was no history of any blood transfusion during this maintenance hemodialysis period. Then in February 2018, that is after 4 years of dialysis vintage, he was at that time 27 years age. He underwent the deceased donor renal transplant. The donor details he is not able to recollect. He received induction through injection Basilizumab and methylprednisolone. He was shifted to the transplant unit in an extubated state. On POD 1, that is post-operative day 1, he noticed that his urine output was good, but on further next 2 to 3 days, his urine output was gradually declining, and he was told that there is slowly rising in the serum creatinine, serum creatinine, and there was an increase in weight gain and shortness of breath. So, in view of fluid overload symptoms and gradual worsening in the graft dysfunction, he was started on hemodialysis, and after 2 sessions of dialysis, he underwent graft biopsy. The graft biopsy detail he doesn't able to remember, but he says that after graft biopsy, he was started on plasmapheresis. 3 sessions of plasmapheresis were given alternate day, and after each session of plasmapheresis, he received IVIG injection. After 3 sessions of plasmapheresis, patients start to notice that his urine output gradually improves. However, total 5 sessions of plasmapheresis were completed for that, and after that, he was monitored for his urine output and renal dysfunction, which showed the improving trend. That is, his urine output was improving and serum creatinine was gradually declining. He was discharged approximately 25 days after the transplant on a triple immunosuppression. And at the time of discharge, his creatinine level was 1.5 milligram, and his 24-hour urine output was 3 to 4 liters per day. He was advised to have regular follow-up after the discharge, which he was compliant. During the follow-up, his immunosuppressions were monitored, means that his steroid, that is methylprednisolone, was gradually tapered down, and his tacrolimus level was tapered according to the trough level. He achieved his lowest creatinine, that is 0.8, after the 3 months of transplant, and after that he was having stable graft function with creatinine range in between 0.8 to 1.2 milligram per dl. However, during follow-up after 2 months, the patient was informed that he was having uncontrolled blood pressure, initially requiring one antihypertensive. However, his BP was not controlled, so he was started on 2 antihypertensive and later on 3 hypertensive. On inquiry, patient doesn't give any history of uncontrolled sugar during the follow-up. there was no history of any liver dysfunction, or there was no history of any post-transplant infection, urinary tract infection in the follow-up. However, he says that since last 6 to 8 months, he is informed that his hemoglobin hemoglobin level is gradually increasing from 11. So till now it has come up to 16.5 milligram per dl. After there is no any major complication during the post-transplant period. Coming to the past history, the patient is having no any major illness in the past like tuberculosis or diabetes or hypertension. Personal history, patient is unmarried, having vegetarian diet, his appetite is normal, and there is no bowel bladder incontinence. Family history, he is the youngest child of his there is no bowel and bladder disturbance.
Yeah, it's simple.
Family history, he is the youngest child of his family. He is born out of a non-consanguineous marriage, having 3 elder siblings. There is no history of any diabetes or hypertension in both parents. There is no history of any renal disease in both the parents or elder siblings. Birth history, he was born at the after completion of 9 months of gestation. It was a normal vaginal delivery. And
important this history is relevant for you for this transplant?
Since he has developed the chronic kidney disease and stage renal disease in very young age, so if there is a history of preterm birth, then there is possibility that there will be underdosing of the nephron, and in the adulthood they may land up into the CKD SRD very early. So that is why this history was taken.
What are the other things you would like to take now at time?
Birth history, sir. Birth history, I will also like to take a history of the maternal ANC checkup, whether she was having on regular follow-up and there was any history
No,
of
you can ask, but who will remember now actually?
Mother.
Mother had a anterior checkup or not? Why this fellow at the age of
59 years, exactly. He's
30s and 40s.
31 years.
30s and 40s, who will remember? Even if you ask him 20s, also difficult actually. Okay, no problem. But no, just be relevant in that. Maximum you can take about the child, the patient himself actually, whether what was the birth weight, approximately, whether he was told to have a low birth weight or not. People difficult also to remember the exact birth weight of 2.5 kg, but usually they'll tell that he was born with a low birth weight or probably prematurely born. It's very, very common. And also milestones are significant and comparison to the pair group and he's whether how he's performing physically, mentally, socially, and otherwise this scholastic performances and all of it. Okay, that you can take maximum.
His current treatment history, he is on triple immunosuppression, taking tacrolimus 2 mg in the morning and 1.5 mg in the evening. Mycophenolate, he is taking 750 milligram in the morning and 500 milligram in the evening. Bisolone 5 milligram OD and 3 antihypertensive. He is taking Micardia 20 milligram BD, Cardivas 3.125 milligram BD and Arcamin 0.1 milligram TID.
Creatinine?
Current creatinine, ma'am, he is having means in the range of 0.8 to 1.29.
What is your diagnosis? Again.
Summarizing the case, ma'am, my patient, 31-year-old male, case of deceased donor renal transplant with immediate post-op complication, delayed graft function, status post-renal biopsy, followed by which he received plasmapheresis and IVIG. So probably he might have having first differential will be antibody-mediated rejection, or there can be the recurrence of his disease, or there can be TMA also.
Please allow the examiners also to ask you questions. And please answer to the question given by the examiner. He said diagnosis and you started summarizing and you started giving differential diagnosis also. Don't presume the chronology of events in the exam.
Delayed graft function, most probably antibody
And
mediated
even summary is
rejection.
also very, very inadequate. Yeah, summary is inadequate. You just started seeing that's a disease or transplantation, immediately where the graft, immediate graft function. But who will tell you about what is the developed renal failure and what was the duration or vintage of dialysis and what was the rate of disease?
4 years of
Four
dialysis.
years.
No, I'm telling you.
Yeah, Santosh.
That's Santosh.
Santosh Garu.
Hi, just a few questions. So this patient, if you were treating this patient and this patient came to you in 2009 and you started this patient on a right non-tunneled catheter, that's the history you gave, right?
Yes, sir.
Okay, comment. Is that you agree with the treatment, disagree with the treatment? What would you like to do? Same, different, anything?
He wants to know what's the non-tunneled catheter, the right thing to do at the time.
Was it appropriate or?
Actually, for the first time, he was started on the dialysis. Being suspecting, considering he's a renal transplant patient, we will not do the femoral cannulation as it may hamper the blood vessels in the future. So he was initiated on dialysis via right
So
jugular.
you agree or you disagree with the treatment given?
I will agree, sir.
What is the guidelines, KDOKI, KDIGO, what do the guidelines say about initiation of dialysis for patients? What is the best access that you need to take, you would suggest?
Sir, best access would be the AV fistula, sir. But till the fistula mature, he will require some another access for which tunnel catheter will be the better option.
So that's your answer, isn't it? Your answer is the tunnel catheter.
Yes.
For somebody who's likely to require dialysis beyond 3 weeks, the access of choice is a tunnel catheter, tunnel jugular catheter, not a tunnel. We all put in uncuffed temporary catheters, but the actual answer is tunnel catheter. This patient was on twice a week dialysis. Comment about twice a week dialysis.
Sir, it is said that if the patient is having good residual urine output of more than 1 to 1.5 liter, and if there is no other major metabolic impairment, then we can start him with the twice a weekly dialysis.
What is meant by incremental dialysis?
Incremental dialysis means, sir, initially we start with the twice a weekly dialysis and see the parameters, means is clinical parameter symptom, whether is responding, that is his symptoms of uremia improving and his metabolic parameters are improving. If a patient is not responding to the twice a weekly dialysis, that is, he is having persistent of uremic symptoms and CKD MVD features, then we will go with the thrice a weekly dialysis.
Okay. This patient was given a disease donor transplant. How would you compare disease donor versus a living related donor transplant?
It is said that the outcome of living donor transplant, whether it is a related or unrelated, it is better than the cadaveric renal transplant.
It's better than disease donor transplant because of what all reasons?
Sir, in disease donor transplant, we don't have any information regarding the HLA typing of the
HLA. You can do the HLA typing.
Apart from that, sir, in a disease donor transplant, the cold ischemia time varies, sir. Some center may have prolonged cold ischemia time that can alter the future prognosis of the graft, because if there is a prolonged cold ischemia time, the patient will have high risk of delayed graft function and further complications.
What is delayed graft function?
Delayed graft function, sir, it is defined as a requirement of the hemodialysis within 7 days of transplantation, or if the creatinine doesn't fall by more than 30% from 0 to 1 day, then it is called as a delayed graft function.
See, this patient had delayed graft function, had 2 days of dialysis, and then required a biopsy. And now tell me, if you are on call and you are informed that the patient's urine output second day after transplant, like this patient, has suddenly fallen. It is going at 100 or 200 ml per hour, 500 ml per hour, suddenly became 150, 25 ml per hour, or has become anuric. How will you evaluate a patient? Patients in transplant step down or semi-ICU, wherever the patient is on the ward, and you're on call. How will you evaluate this patient?
So first, I will check whether there is any obstruction of the Foley's or not. I will try to flush it down. Then I will check his volume status, sir, whether patient is hypovolumic or not by measuring the CVP. Then I will do his ultrasound, graft ultrasound, to look for any obstructive cause.
Obstructive cause or just obstructive? Vascular cause?
Both, madam. That is, if there is any obstructive cause causing hydronephrosis, or if there is the impairment of the renal blood flow because of the renal artery thrombosis or stenosis, that I will rule out.
Okay. The radiologist says that there is no obvious thrombosis, but the resistive index is 0.4, 0.3.
So
Two
if,
vessels are there, 0.4 and 0.3.
If the resistive index is less than 0.5, it is suggestive of development of the transplant renal artery stenosis, sir. Also, there will be Pardus parvus pattern.
It's too early for stenosis to occur, no? The second day.
Second day, how will you even RI 0.4, 0.5 in second day?
There can be decreased perfusion of the.
He said no. Say that, yeah. Say
go on.
Perfusion might have decreased. So
what investigation will you do? That is better than your Doppler. Your Doppler has not picked up any thrombus. What investigation will you
to
do?
see the proper perfusion, we can go ahead with the DMSA scan, sir.
DMSA?
No, DTPS, sorry, DTPS.
Yeah, DTP can do, but you want to see the anatomical.
The DTP.
You want to see the anatomy, no?
You're sure that there is no perfusion happening because your RI is 0.4, 0.5. And what extra information your DTPA will give? What else?
You want anatomical delineation. What will you do?
This is post-op day 2. There is no urine output. Even though the Doppler does not show that there is no thrombus, but your RI is 0.4, 0.5.
We will do CT angiogram.
CT angio, CT angiogram.
Okay, your answer is not wrong. What is the risk of a contrast nephropathy with a CT angiogram versus a regular angiogram of the kidney?
Conventional angiogram.
Conventional angiogram, it will be the invasive procedure. So we will.
What is your worry? Your CT angio takes you about 100 ml of contrast. This we can find out in 10 ml. And what is the advantage of doing a CT angio? I mean, a conventional angiogram on D2.
Conventional angiogram, ma'am, there will be.
What is that one? You go and do a CT angio, you run around and call, you go there, and they do a CT angio, they give you, flush your dye at 100 ml, and then you get a diagnosis. And then you will sit and say, oh, I'm wasting my time, I should have done something else.
What more can you do?
What can you, see, this is a transplant patient. You have to think.
Any other modality apart from CT, which is more sensitive?
See, I think it means conventional angiogram. What is that?
Either conventional angiogram, or you can do an MR angiogram, which is very sensitive. Will show you a thrombus.
But as she says, if you have a conventional angiogram and you see a impending thrombus, which is developing, you can even intervene at that time. You don't have to waste your time. Isn't it?
So
Treat
over
the
to you, sir.
patient. What do you think happened?
Ma'am,
And how could we have prevented what happened?
in the now regarding his uncontrolled hypertension,
No, uncontrolled hypertension. No? Because within the graft function delay in the first 4-5 days leading to plasmapheresis and then IVIG and all. What happened and where did we, what could we have done to prevent this? What exactly happened?
considering he is a deceased donor renal transplant, and he was given induction with the paclitaxel, so it could be inadequate immunosuppression because DDA.
You cannot say that. No, basiliximab is inadequate and thymo is adequate. That's not the answer. The answer is what went wrong with this. What might have happened? What might have happened? You did plasmapheresis. Why did you need to do that?
And because of the development of the antibodies,
Careful, careful. Did the antibodies develop or they were preformed?
as such, there is no history of immunological
Within
history.
5 days, 4 days, you have development of antibodies. How much time it takes to develop antibodies? What is the immunological picture? First, the graft is implanted. The body recognizes the antigen,
and,
direct, indirect. After that, the lymphocytes, T cells, B cells, T cells and B cells work. You have co-stimulation. B cells proliferate. Then they form antibodies. How many days it will take? 2 days?
It's too sensitive.
And that is
history,
not
any
there.
history of
There is no
sensitization?
history of blood transfusion in the past.
So again, Santosh's question: what? How did we immunologically work this patient up?
So we should first take the sensitization history, whether he is having
No,
any
not that way. Sensitization you don't know.
investigation. We will do the panel reactive antibody.
Will panel reactive work in this situation? Are you looking for a cross-reactive PRA or you're looking exactly? You have a graft, you have a donor and a recipient.
Now what?
Now what do you?
No, we will do the.
Even if he is 75% PRA positive, he may be negative to this donor, no? Santosh,
We will do single antigen.
will you do SCP here? Or SCP?
Actually, we don't
Santosh
have
said
the.
SCP will do initially and then leave it because that gives you an idea of the patient's antibody against HLA, a spectrum of HLA. Now what will you do? How will you immunologically work up this patient? What will you do? You have a very small time frame, isn't it? You in our hospital within 4 hours, 5 hours, we go for a disease transfer, maybe 8 hours. What are the things you should do?
Before taking into transplant, ma'am, we do the this complement dependent CDC test.
You must have done CDC or what was it a CDC?
Yes, ma'am. CDC was. We do ma'am CDC.
And so what sensitivity, how specific CDC is for positivity and how sensitive is CDC?
And if CDC is positive, then we will not
Obviously,
go.
this was negative. So, was it a right thing? Was it all right, or we should have done something?
We should do also the flow cross match, ma'am.
You should have done a flow process. And after that, would you have not done something else? Would you like to have the donor's HLA?
Donor HLA typing and single antigen we will do.
No, we just need the HLA for them. No? Then we'll have to look for them. Do you think if it was your patient, this would have been the follow-up?
This one, CDC and flow cross match minimal.
Now that he had looks like he had a AMR and that acute AMR. So how do you follow him up? Would you be checking for these were all preformed antibodies. Looks like. Does having preformed antibodies increase your risk of developing de novo antibodies in the future? Preformed were the cells which were there before. The recipient carried these clones. Unfortunately, against this donor grafts, he had maybe anti-HLA antibodies or whatever antibodies we don't know. But if you have a preformed antibody, does it increase your risk of developing de novo antibodies? I mean, newer clones of antibodies.
Preformed antibody, if they are causing the graft dysfunction, then such patient may have high risk of developing the de novo in the later stage because of the exposure of the graft antigen.
Ravindra Prabhu, Ravindra, some questions?
Acute graft dysfunction, immediate post-transplant. How will you go about?
In the immediate post-transplant while evaluating, so sir, we will go with a compartment wise. Sir, if there is a pre-renal, if there is a excessive blood loss during the surgery, then a patient may have hypovolemic shock and he can develop AKI, renal dysfunction. Then post-renal, the patient may have obstructive cause. There may be thrombosis or there may be the obstruction of the digestion that can cause the graft dysfunction. Then coming to the
No, I'm not asking the causes. How to
approach?
This is you have to do a fast evaluation and management.
So, sir, if the patient
If there is no urine has come down, and you are called in to look at it.
So, sir, if the patient has acute graft dysfunction with fall in urine output, I will first do his ultrasound graft Doppler to look for any obstructive cause. If that is rule out, then I will check any drugs that can cause any drug-induced AIN. I will check for any source of infection such as UTI or LITI that can cause infection-induced graft dysfunction. If all these are negative and the AKI is not explained, then I will go ahead with the graft biopsy to look for the glomerular cause such as rejection or rejection.
Pre-renal causes, how will you rule out?
So pre-renal cause, if the patient is having history like there is excessive blood loss during the surgery, which predisposes into the hypovolemic shock, or if we check his central venous pressure, which is very low, suggestive of hypovolemia, or if the patient in the immediate post-transplant period is having excessive vomiting or loose motion, then all these features may suggest that there is a volume loss and pre-renal AKI.
Causes for graft dysfunction.
Causes of graft.
One is the rejection you told, APMR. Yes. What are the other causes?
Sir, either it can be drug-induced acute interstitial nephritis, sir. Then if there is a prolonged cold ischemic, and then there will be the ATN. Then there is the rejection. Then there could be the development of de novo glomerulonephritis. However, it will be the rare.
What about CNI toxicity?
CNI toxicity also can be there. So
how does CNI toxicity manifest?
CNI toxicity in the acute condition, it can clinically can cause hypertension with electrolyte imbalance such as hypokalemia and hypercalcemia and hypernatremia. And if we do the biopsy, then on biopsy there can be isometric vacuolization in the tubules.
So, which is a severe renal failure can occur in due to CNI toxicity.
If the CNI causes TMA like a picture, then there can be severe graft dysfunction.
Okay.
Can you, in a way, differentiate a TMA of AMR and TMA of CNI toxicity?
One, we will check the trough level if they are high.
Will you check a trough level in a patient who just underwent a deceased donor transplant today, and day 3, will the trough level be the right one for tacrolimus? When in your practice, when you check your tacrolimus levels? Immediately day, which day of transplant? Day.
Then we do POD1, then day 5, and after
So
that.
with the POD1, have you ever seen the difference between the POD1 and a day 5 report?
Not much difference.
Which is the day 1 itself. What is the pharmacokinetics of tacrolimus? How tacrolimus is absorbed? What are the factors which determine its absorption and its metabolism?
This CNI, they are absorbed from the gut and small.
Which part of the gut?
Ileum. Ileum.
Ileum or
small intestine. Small,
Duodenum and meat. Then, how do they get absorbed? Any proteins involved in their absorption?
P glycoproteins, but they are involved in the influx of the drug.
Yes, and what is absorption? How does tacrolimus by itself improves its absorption or reduces its absorption?
Over a period of time, it is said that after a few months, the absorption increases. So that is
Mechanism of absorption, how does it? That's what we discussed. So in this patient, as he said, we still have half an hour for you. You did a biopsy. What was the biopsy in your patient? Did you have any information? They didn't tell us, no? They didn't tell you, no? For the biopsy. So, this patient was a male after diagnosis, they required plasmapheresis. For a diagnosis of this acute AMR, what are the criteria that you need?
So now, according to the BAM criteria, there are
Your
three.
clinical practice, what are the 3 things you would like to satisfy that this has happened? Can an AMR-like picture happen in something else immediately after transplant? Same endothelial injury, damage, thrombosis.
TMA drug.
Forget the TMA. AMR is what? It's a endothelial, a vascular injury. This kind of vascular injury can happen with TMAs, can happen with AMR. Something else can exactly mimic like this and reverse. Immediately after in a deceased donor transplant. You biopsied on which day? 3rd day or 4th day? And you said it's AMR and you did plasmapheresis. Patient recovered. So much so that he's maintaining 5 years later normal creatinine. Isn't it? Can this picture be mimicked by a clinical presentation immediately after graft transplant? Have you heard of ischemia reperfusion injury?
Yes.
Exactly, it prevents like this. No, you have endothelial injury. Lot of neutrophilic infiltrates, endotheliitis, glomerulitis also you can have. So, how would you say that this patient had actually an AMR? So you did a biopsy,
Yes.
which might have the pathologist would have told that there is glomerulitis, isn't it? That's or C4D positive. Those this C4D was there in your hospital? 4 years back was there. What else would you have done? You should be sure that this is a antibody mediated rejection. You have biopsy. What's the other criteria? C4D. What's the third criteria?
Serological, we will check the DSA.
Your patient had HLA, you could have sent DSA. Then what else could you have done? Maybe it's expensive. I cannot get the DSA, it costs money. I have the HLA, I will do a DSA. What can you do to be sure that this is what is causing the problem? That the antibody, preformed antibodies are causing this AMR. You could have done a CDC again. If you had kept the donor's sample, you could have done a CDC, no? That would have helped you in your diagnosis, isn't it? So, AMR, what are the diagnostic criteria?
According to BAM, there are given 3 criteria, madam. First is the tissue injury in the form of a microvascular inflammation, that is glomerulitis or peritubular capillaritis, or there can be arteritis also, or there can be unexplained ATN or unexplained TMA. Then second criteria is the evidence of antigen antibody reaction, that is in the form of C4D positive, or again that there can be microvascular.
Is it an antigen antibody reaction? C4D is a marker of antigen antibody reaction or a marker
antibody mediated injury?
It's a marker of complement activation, isn't it? Antigen antibody mediated complement mediated.
So in this, there could be C4D positive, or there could be microvascular inflammation in the form of glomerulitis, peritubular prophylaxis, or there can be molecular marker in the form of endothelial associated transcript factors.
What are they called?
NDACs,
isn't it? So where is it from? What is it called? If you have the facility to look at RNA transcripts, what is this called? What is this way of identifying the subtype of rejection? What is this called? And who actually have, who are known to have done this? I mean, which group? Any idea? It's from Canada, from Dr. Philip Halloran's group. This is called a molecular microscope. So it gives you a differential expression, and you have AMR index, TCMR index. Isn't it?
Pre-transplant evaluation, you wanted to do CDC, and you wanted to flow cross match. Suppose if the CD is negative and flow is positive, what is it?
So if the CDC is negative and flow cross-match is positive, it means that there is a low titer of antibody present that has not yet picked up by the CDC, and we will confirm it either by doing the single antigen bit test.
Low titer or something else also? What does CDC do? It's a complement
dependent cell lysis man.
So, Madam is saying it's negative. CDC is negative, but flow is positive.
Flow, it can pick up both complement dependent antibodies as well as complement independent antibodies.
So, the CDC did not pick up the complement independent. Is that important?
Yes, ma'am, because in antibody mediated reaction, the injury can be based on the complemented antibody itself can cause the tissue injury.
What is Flozone phenomenon?
Flozone phenomenon,
in CDC, what is Flozone phenomenon? And how will you get away with it?
If a patient is having some non-specific IgG antibodies in his body, then he may give false positive flow cross match.
Is that Flozone? What does Flozone mean? It's like your urine Bence-Jones protein. You see positive, then you don't see for some time, then again it becomes positive, depending on the amount of antibody the patient has, I mean the recipient has. In a highly sensitive, it's a question of overwhelmed number of antibodies.
It can be seen in highly sensitized body, or the patient is having any autoimmune disease, then they may give false positive cross match.
So how will you false negative news? Negative. And the IgM one, what do you do when you said there are non-specific IgM antibodies? How will you check? Is there other ways you can improve your cross-match results?
We can improve cross-match result by adding anti-human globulin, madam, or prolonging the duration of complement process.
And how do you pick up cold agglutinins? Like you see in globulins, is there cold agglutinins? Santosh, something was? We have 15 minutes still. Santosh, any answer?
Yeah. So you said this patient's, what was the final diagnosis of this patient? Did you say the whole diagnosis actually?
Final diagnosis.
Final diagnosis, sir. This is a case of deceased donor renal transplant with delayed graft function. Status post graft biopsy, probably the antibody mediated rejection with current complication of post transplant uncontrolled hypertension and possibly, sir, post transplant erythrocytosis.
Yeah. So you said this patient has post transplant erythrocytosis. What are the how do you diagnose post transplant erythrocytosis?
It is said that if in the post transplant period, if the hemoglobin level is more than 17 gram per dl, or if the packed cell volume is more than 51 for at least 6 months, then it is considered to be the post transplant erythrocytosis.
What are the risk factors?
Sir, risk factor could be, sir, first the male sex, then history of no requirement of the EPO or blood transfusion in the pre-transplant period. Then history of no any graft dysfunction in the post-transplant period. If there is a history of any cystic kidney disease, that is native kidney disease is cystic kidney disease, then he may develop post-transplant erythrocytosis. Or if the patient was ex-smoker, then he can have the post-transplant erythrocytosis.
Very good. That's a list is quite complete. So this patient has got only one risk factor, that he's male, no? What cutoff will you use for doing venesection or phlebotomy, removing blood?
For phlebotomy, sir, we will consider if even having adequate medical treatment in the form of starting AC or ARB inhibitor is hemoglobin is persistently above 17 or PCV is more than 51, and he is symptomatic for that complaint, like he is having headache or dizziness or fatigue, then in such condition we will consider him for phlebotomy.
Is it 51 or
Any cutoff is there? PCV cutoff is there?
PCV cutoff?
They are given in the range. Some studies says 51, some studies says 55 now.
Okay, that's right. 55 is conventional.
55 is conventional.
Any other drugs that you can use for PT?
For post-transplant, it is said that first you should try with the AC or ARB inhibitors. If a patient is not responding to that, then we can try theophylline or even mTOR inhibitor like everolimus can also be used.
Okay, good. Before starting ACE inhibitors or ARBs, is there any precaution you will take before and after? ACE inhibitor, ARBs, before and after, any precaution you will take?
Sir, first, we will not start in the immediate post-transplant. Once his graft.
No. This patient develops PT. The PT in this patient happened a long time after transplant, right? It's not in the initial period. Okay. Well, at the time of starting ACE inhibitor or ARB,
rule out any critical transplant renal artery stenosis in this patient, sir, before starting the AC or ARB.
Would you think we should be evaluating this because your patient has
yes,
very high blood pressure? No?
Yes,
It started about 6 months post-transplant.
Yes, ma'am.
We moved from one single antihypertensive to now 3 or 4 now.
Yes,
so, what clinical clue would you get when you to suggest guess that this patient has got critical renal artery stenosis? What clinical critical clue?
Clinical critical clue, sir. First of all, if his BP is persistently uncontrolled even after taking 3 or 4 drugs, if a patient is developing intermittent episode of flash pulmonary edema, clinically.
Yeah, but actually something very much simpler. The patient develops edema itself. That may be a clue that he's got
non-proteinuric edema that is not responding to the.
So this is like a bilateral renal artery stenosis where water retention is common, isn't it?
Sir?
Ravindra? Yeah.
Nothing from my side.
So I mean, thank you. The student knows a lot more things.
What target immunosuppression levels will you want to maintain post-transplant?
Sir, regarding tacrolimus level, in the early post-transplant, we will try to keep the tacrolimus level in the range between 8 to 10, and later on we will try to keep the trough level in between 4 to 6. Then Visolon, steroid we can taper off up to 10 or 5 milligram depending upon the graft.
Cyclosporin levels? Cyclosporin?
Cyclosporin. Exact trough level 100 to 200.
We say 100 to 200. They have never used cyclosporin.
Okay, everolimus. Everolimus.
Everolimus, sir, 3 to 5, we will try to maintain the trough levels.
Okay. Sure. Thank you.
Thank you, sir.
Ask, sir. Any questions? 5 minutes, 5 minutes. 5 minutes.
What are the recent drugs you would like to onboard now in the studies? Okay. For ABM. What are the newer drugs?
There are studies going on regarding rituximab.
Rituximab we use. It's in the brochure. Newer drugs.
Santosh. Ma'am, what's to go?
What is Jordan's?
Okay.
You are the man is Devi.
Bye, bye,
Bye, madam.
Bye, bye, ma'am.
Jordan's. Deborah.
ठीक है, thank you. Good, thank you.
मैडम आपके लिए
Yes,
आपके लिए सबके लिए
I am also there. Yeah, thank you. Please go with us.
I pray that long is like me the last
Come. Sir, बोले. You were out for something. We talked a lot. बहुत बात किया मैंने.
Yes. Respected teachers. Good evening, everyone.
We respect teachers नहीं बोलना. You are equal to us now. We have finished 3 years. Good evening बोलो.
Good evening, everyone. So I will be presenting 2 cases. My first case is a 33-year-old male gentleman, unmarried. He was a graduate dropout, occupation by real estate business, residence from Hyderabad, presented with chief complaint of bilateral lower lip edema, past 15 to 20 days. Increased shortness of breath, 10 to 15 days. So symptomatology dates back to from December 2021. During the December 2021 last week, after he has taken the first dose of Covishield vaccine, he started to develop painless visual blurring in the left eye, which was insidious, progressive, and over a span of 15 days after the vaccine, it increased to involve bilateral eyes within a span of 1 month. It was progressively increasing. So for which he attended an ophthalmologist where they examined and suggested a detailed workup further, and he was given some antihypertensive medication, and he was told to have high-grade blood pressures with systolic around 230 by 160. So after which patient has taken initially antihypertensives, but in view of financial constraints, he could not follow up, and he was with his routine work. Coming to history of presenting illness, bilateral lower limb edema, 15 to 20 days. This is in the month of April. So this started in the foot initially, progressive to involve both the lower limbs, associated with the increased shortness of breath, 10 to 15 days, MMRC 3 to MMRC 4 in a span of 2 weeks. Not associated with any chest pain, wheeze, orthopnea, PND, palpitations. No history of any bleeding manifestations. No history of decreased urine output. No history of any cola-colored urine. No history of jaundice, swelling, fever. No history of joint pain, rash, or no history of any pain related to mobility. This is associated with symptoms of nausea and recurrent vomitings in the last 2 days before attending to the hospital. When he presented to the hospital, he was found to have an increased shortness of breath and he was underwent investigations where he was told to have high blood pressures, and he was told to have renal failure and initiated on dialysis through a temporary catheter. So currently he had 9 sessions of hemodialysis. Last session was day before yesterday with the catheter in situ right side. And he has also history of renal biopsy from left lower pole, which was uneventful 1 week back. Coming to the past history, no comorbidities, and personal history is a social smoker and alcoholic, bladder and bowel normal, and sleep is good. Coming to the family history, he was one male child with non-consanguineous marriage with a sister as a sibling. Father is hypertensive, mother is hypothyroid. No family history such of any renal disorder. So coming to the summarizing my patient with a 33-year-old gentleman with no prior comorbidities, presented after taking first dose of Covishield December last week 2021, presented with painless visual blurring, bilateral, progressive edema and increased shortness of breath with accelerated hypertension. So ruling out other systems, I would like to consider renal system being primary with a history of hemodialysis and biopsy. I would consider my differentials acute on CKD, primary differential.
Why acute on CKD? What's your syndromic diagnosis in this patient? Sitting on your head.
Acute on CKD with accelerated hypertension.
So rapidly he has presented.
First, accelerated hypertension.
So accelerated hypertension cannot be a syndrome. So what is the syndrome? With that, is it the RPRF or is it?
First I will consider acute on CKD.
Why there is no history suggested CKD previously?
So actually, his symptoms are from almost more than 4 months, with a history of dialysis 9 sessions.
No, he started with an edema.
Yes, ma'am. Shortness of breath and edema. It is more than 4 months, 3 to 4 months.
3 months or 4 months?
More than 3 to 4 months. 4 months, ma'am. After the vaccine has taken in the last week of December, so he started symptoms from January.
Why you want to actually stress again and again, saying that it all started with vaccination?
No, sir. I probably.
No, you wanted to implicate the vaccination as an etiology in the pathogenesis of the yeast syndrome, or probably it is like, say, for example, 2 years back it happened to see, or 4 years back it happened to see such as, would have started with the blood vision, no?
Yes.
And you tell me how many crores of people would have taken a vaccination in this country?
Almost.
It's just coincidental.
Yeah, it's
just coincidental.
Maybe he might have known. He might.
If he happens to have an infection, COVID infection, that was the first meeting with the doctor,
yes,
or going to the hospital. But here vaccination is actually a national process. Actually, it's involving the entire country. So you can, in the history, you can tell that probably somewhere in the past history or somewhere in the vaccination history or personal history, he was vaccinated against COVID in the month of December 2021.
Okay. And the symptoms started when?
After taking vaccine.
No, don't forget that. You give us the date.
January.
January
first week.
First week. And
Yes,
when did he come to the hospital for dialysis? When did he have his edema? Was in January?
It started in February, ma'am, initial. Edema and shortness of breath.
And then
he came to dialysis in 20 days back to hospital.
This is RPRF, no? It's in the history of 3 months. This is rapid
More than
failure. It's 3 months, no?
Madam,
February.
It started in January.
started in as it is more than 3 months. I kept.
Why not AKD? No, it's 3 months again.
RPRF I have kept at second.
Sir.
Santosh?
Yes.
Santosh, you start with the syndromic diagnosis only. Whether it's AKI, CKD or RPRF or AKD. So he wants to say there is a CKD because the clinical presentation is more than 3 months. The clinical involvement of kidney function is more than 6 months.
If it is CKD, then what is the etiology of that? You are saying that it's a chronic kidney disease.
Yes, sir.
And he is not a known diabetic or hypertensive.
No comorbidities, sir.
Age how much?
33 years.
33. Okay. And he has directly presented over a period of 3 to 4 months. He has gone to dialysis requiring.
Yes, sir.
So which CKD is this?
Sir.
Yeah, that's what kind of CKD will behave like this? And what if you say there is a superimposed AKI? What is causing the AKI now?
So it is probably with this hypertension and asymptomatic, I would consider IgA nephropathy first possibility with the accelerated hypertension, and IRGN followed by C3GN membranous down the line lupus, sir.
Maybe it's fine.
So it's a chronic glomerulonephritis, you're
Yes.
saying?
Yes.
I'll tell you this is malignant hypertension TMA. Because you said blurring of vision. Why not malignant hypertension with TMA? As TMA.
I'm surprised that you did not mention about this rather than started mentioning about
This is the commonest thing.
membranous nephropathy rather. Why do you think of membranous nephropathy? You would have thought about accelerated malignant hypertension are leading to TMA and renal failure. You would have actually thought about it.
Yes, sir. I have kept it.
That's a common diagnosis. You've been saying that blurring of vision and all.
Accelerated hypertension.
Yes, accelerated hypertension with TMA is a possibility.
So what percentage of hypertensives end up with end-stage kidney disease?
It depends on the. I mean,
Supposing I have a hypertensive patient, he asks me, can I get kidney disease? What percentage?
So if
Whether treated or untreated?
Untreated, probably 40 to 50% may land into yes study over 10 to 15 years.
40-50%.
That's a little too high.
The hypertension is.
We are seeing hypertensives
Controlled
all around.
hypertension is a.
All around us, hypertensives are there.
30%
Many of them don't even know they have.
Yes.
So it is.
उसमें अगर 40% लोगे तो then 12% will be end stage in India only. That's all.
Less than 10%.
What's the prevalence of hypertension in India?
40%.
40. We are the only three.
Santosh sir. Santosh asked.
Santosh. Can you please unmute, Santosh? Can you please unmute?
Thank you. Yeah. So this patient had bilateral pedal edema and shortness of breath. How was the onset? Sudden, insidious?
It was a progressive, sir. It was progressive over the period of 3 months.
So
initially
very
edema
gradual.
followed by shortness of breath, sir.
Okay. Why is that important? The history of whether it's sudden or it's very gradually increasing.
Sorry, sir.
Why is that onset mode of onset important?
Here we have two glomerular diseases presenting very far in like there are glomerular diseases which are present very fast, like RPRF presentation. We need to rule out these things, sir.
Okay, what is the presentation of an RPGN usually?
These generally present with faster progression within weeks to months.
No, see, that is when you have access to their creatinines. I'm talking about symptoms. A patient with a vasculitis, for example, an elderly gentleman with vasculitis comes to you. What is the typical presentation?
Generally, they will present with edema, progressive edema, shortness of breath, decreased urine output.
I see. What is the earliest symptom that you get in RPGN? All that you said, it may be there, but what's the earliest symptom you get? Usually, with like a vasculitis picture, what's the earliest symptom you get?
What is the subacute nephritis?
What symptomatology they get?
Subacute
nephritic syndrome, sir. I mean hematuria.
Subacute nephritis.
A vasculitic patient who comes to OPD in an adult, they may not look like renal failure to you. The symptoms are different. Edema, progressive shortness, all fine. But what are the? If you take a patient's history,
Rash.
Rash, we are not talking of rash. Anything else?
Usually they just have fatigue and lassitude. No, nothing else will be there to start with. at first. Okay, so these things are much later. That's why the way it progresses is important. And you said a temporary catheter was used. No,
Yes, temporary non-tunneled.
but you haven't told us which vessel they cannulated.
Sir, internal jugular vein, right? Sir.
Yeah, so because you say the patient came with shortness of breath and pulmonary edema and edema, it may be quite difficult to cannulate the jugular, no? So you must specify which
Yes.
vessel they used. Okay, it's very important to specify.
Sir.
The blood pressures, were they equal in all the limbs? Any idea?
Yes, sir. Blood pressures were equal in all the 4 limbs, and pulse was also no delay was not seen in upper limbs and lower limbs. Radioradial or radiofemoral delay was not.
So this patient came to you, let's say patient came and the blood pressure was 230, 160. What antihypertensives would you choose to control his blood pressure at this stage? Patient came to you with shortness of breath with accelerated hypertension.
So I would like to give initially decrease the blood pressure with IV drugs, preferably IV Levetolol, according to the blood pressure 20 mg every 15 minutes. So I would like to consider in a slow manner.
Okay, then
once his symptoms are elevated, then I would like to go for as he is overloaded and uremic. I would like to dialyze him, sir.
No, we stick to antihypertensives. What's the current antihypertensives he's taking now?
Sir, I don't know exactly, but he is on one tablet early morning, sir. After dialysis,
Only one tablet.
Only one tablet. So after dialysis, he is symptomatically better. His shortness of breath decreased, and he is on only one antihypertensive.
With 160 days.
Okay.
That was at presentation, man. 230, 160 at presentation. That is when he went to ophthalmologist. Now his pressures are controlled. 130. He mentioned it. 130.
Is it a good sign or a bad sign?
Is it good sign?
No. When your patient who has got hypertension gets suddenly controlled blood pressure with a single drug, is it a good sign or a bad sign?
Ma'am, this
Is normotension a good prognostic marker in RTRF?
In CKD and RTRF, normotensive is probably it is hibernating some.
Is it a good marker or a poor prognostic
poor prognostic marker? Non-dipping and these.
Non-dipping. This patient, your patient from we are talking, he was very good with one antihypertensive, 230, 160. Now he's come back to normal blood pressure. What does it tell you?
Arteriosclerosis.
No, he's acute. No, he's just a young 33-year-old boy. Same, it will be useful in any kind of a vasculitis patient. Your IgA crescentic also. In all of them, if the blood pressure is on the lower side or very well controlled, it's not a good sign. Why? What is the mechanism for that?
What is the analysis in sprint trial?
Sir, actually, it was conducted around 4,000 patients, which showed high intensity control versus a standard. It showed a good results with
what happened in a high intensity control trial?
But okay, it has showed more side effects in the
what side
high
effects?
intensity AKI, risk for AKI.
In your patient, it all means that your glomerular disease or whatever the vascular disease is so extensive, it has destroyed your juxtaglomerular apparatus. So there is no renin release. That's why your blood pressure has become very well controlled. In fact, that's a poor sign.
Okay.
The GGA is completely been extensively damaged by the whatever you are underlying pathology. So normotension is not a very good sign in rapidly progressive heart.
Okay.
Santosh or Ravindra, we can only see your, that Dr. Shastri used to say, Dr. That is half moon you can see. Both of you have become half moon anyway. Ravindra, you can give question.
So what are the different ways that hypertension can cause kidney disease?
Hypertension disease per se, benign changes it can cause, and malignant hypertension it can cause glomerular changes. Hypertension related to drugs can cause, and renovascular hypertension.
What are the changes in the kidney?
Benign, it sees hyperplastic changes in the vessels. Chronic, it shows arteriolar hyalinosis, thickening of the vessels, onion skinning pattern seen on the
Benign is onion skinning. Benign nephrosclerosis means what?
Benign nephrosclerosis.
Benign, it's thickening and hyalinosis, sir.
Arterial.
Arterial hyalinosis.
Glomerulus.
Glomerulosclerosis. Benign.
Sclerosis means?
Sclerosis, loss of podocytes with a mesangial.
Global sclerosis, focal sclerosis.
Yes, sir. Global is damage all the
glomeruli.
Yes, sir. No, single glomerulus.
Only one.
Yes, sir.
Focal means?
Focal, when we see one area, maybe in that area, some glomeruli is involved, then we call it focal.
What is segmental?
Global?
Segmental is only partially involved, more than 50%, less than 50% of the glomerulus.
No, see, you're getting
focal means?
Global, focal, diffuse, segmental. So that gives you the differential. So global is something, focal is something, diffuse is something, segmental is something. So you wanted to know what is focal.
Focal is
and what is segmental? Are they two things or two different?
Different things. So,
Yeah.
Two different things. Focal is some part of the kidney.
Some of the glomeruli.
Some of the glomeruli. Segmental is part of the glomerulus.
In hypertension?
Hypertension you want to know.
Hypertension, it is seen globally.
Globally.
FSGS, do you see FSGS?
No, FSGS is very limited.
Not seen in any. Which group of patients you will see benign hypertension when manifesting as FSGS? Focal segmental glomerulosclerosis.
Less.
Have you heard of a study called ASK? AASK?
Yes.
What is it study?
And malignant hypertension, what are the changes you'll see?
Sir.
SK. That's all. So maybe we will read up. This is these are again studies which have shown that hypertension can
The
produce.
landmark rights, no, they are supposed to know. Not say this danger, should not say that I don't know.
Read this. So Ravindra, ask.
How?
Malignant hypertension, what are the changes you will see?
We can see, sir, thickening of the vessels, onion skinning. We can also see TMA with a thrombi, vascular fibrin thrombi, partial or complete obstruction with a thickening of the arteries.
So what will happen to glomerulus? If you have this onion skinning and other things in the arteriole, glomerulus, what will happen?
Glomerulosclerosis.
Is there anything else he wants you to say that word?
Glomerulus will not receive the blood. No?
So what will happen to the glomerulus?
A glomerulus shunt.
Not
Shunting.
What? What is the
If the-
earliest sign of ischemia into the glomerulus?
If the glomerulus doesn't receive blood, what will happen?
I'm sorry, we have a lot of time for you.
Is it a reversible condition? Malignant hypertension.
Yes, sir, it is reversible.
How long it takes? If I control, like yours has become 130 by 80 now. Do I label him as ESRD or wait for some time?
So as of now, I think it is a acute on CKD. I will wait.
How long I should wait?
Sir, depending on the clinical.
No, he just wants you.
He's on dialysis now.
Weeks, 3 months, 1 year.
2 to 3 months, sir.
2 to 3 months.
Yes, sir.
It can take longer sometimes. This is one condition which is known to recover over a longer period of time. So you cannot give up.
Santosh?
Ma'am, that's all, ma'am.
Second case.
So coming to the second case, he's a gentleman, 48-year-old male, who is a residing in Hyderabad, occupation by mansion, married, having 2 children. History is given by wife, which is reliable. He has come with a chief complaint of progressive edema past 3 to 4 months from February 2022. It's history of presenting illness, progressive edema past 3 to 4 months, started in the legs, progressively involved to extend bilateral lower limbs and extended to trunk, associated with facial puffiness. This is associated with exertional shortness of breath, progressive, no orthopnea, PND, chest pain, and nor palpitations, no issue of decreased urine output, no change in the color, nor any bleeding manifestations, no issue of any B symptoms, no issue of any skin rash, joint pain, jaundice. And he was for these complaints, he was evaluated at a hospital where they was told to have renal failure, and he was advised to follow up in the nephrology department. So coming to the past history, my patient is a patient living with HIV, HIV past 15 years. He was when he was detected with the progressive weight loss 15 years back, and he was initiated on heart regimen on daily 1-day tablet. Since then, with good compliance, he's maintaining his good health. Currently, when he was went for hospitalization, he was found to have renal failure. So the drug was changed to dolutegravir based, which he showed to me, taking daily 50 mg 1 tablet and rest other tablets. Coming to diabetes, he's diabetes 5 years, and he's on oral hypoglycemic agent with good compliance. Hypertension past 5 years, and with the history of CVA, probably ischemic 3 years back with the right-sided residual hemiparalysis with the involvement of the face. Currently, patient is doing well with using one hand stick. Family history, nil significant. Personal history, predominantly vegetarian diet, reformed smoker, occasional alcoholic, bladder and bowel symptoms normal, sleep normal. Coming to the treatment history, he is on a heart regimen past 15 years. Currently changed to dolutegravir based from March 2022 in view of raised renal parameters, which the patient told. And he's on antihypertension and antidiabetic medications with a good compliance, with a history of renal biopsy 10 days back, which was uneventful. Summarizing my history, he's a 48-year-old male with a background history of HIV. He was on heart regimen past 15 years. Recently changed to dolutegravir based with type 2 diabetes, hypertension, ischemic CVA on oral medication with good compliance. Presented with features suggestive of progressive edema and shortness of breath. Ruling out other systems, I will Anasarca under evaluation, I would like to consider CKD, DKD being my primary differential diagnosis. And I would like to rule out non-diabetic kidney disease in this patient. Yes, sir. Right. Yes, sir. 1 week before it was done, waiting for the reports.
Is there a retinopathy?
No, sir. Retinopathy was not there.
Okay. And hypertension is there?
Yes, sir. He is a diabetic and hypertension, sir. Past 5 years.
And this one, the fluid overload is due to?
Sir, actually, in February, he was having symptoms of edema from January, sir. January, February. So routinely he went to ART center where they evaluated and found to have raised creatinine. The patient himself has told, and the drug is probably changed to dolutegravir based. I consider this fluid overload probably related to drug toxicity. First, I will consider a diabetic nephropathy followed by drug toxicity.
Diabetic nephropathy, will it progress with so fast?
Sir.
It's 6 months.
No, he's no.
They have done a biopsy, no?
Yes, sir. Biopsy has been done, sir.
Biopsy has been done. So they are thinking
5
of a
years.
So they are thinking of a non-diabetic. So what is the renal syndrome here?
CKD, CKD likely progressive diabetic kidney disease, sir.
Does it require a biopsy then?
Yes, sir. Biopsy has been done, sir. Report is awaited.
Reason? Diabetic kidney disease we will not do.
Generally, we do not consider in case of classical symptoms, sir. As this patient is does not have any, and is type 2 diabetic, no diabetic retinopathy. He is also having HIV and is on multiple drugs with.
There's no retinopathy.
No retinopathy, sir.
So in a diabetic with kidney disease, where will you consider doing a kidney biopsy?
So when coming to type 2 diabetes, he is having no retinopathy, and if his creatinine is in atypical presentation, I mean rapid progression.
Rapid means? Rapid progression means?
EGFR increasing in the trend of 5 to 10 ml per meter square per year.
Normal is?
Normally after the 40 years it progresses 1 ml per meter square per year, sir.
Diabetics.
Diabetic, yes, sir. It has increased. It is 4 to 5 ml, sir.
Average.
Sir.
Now, what is the progression of diabetic kidney disease?
It is
4 to 5.
5 to 7 ml.
You have to make up your mind clearly. 4 to 5, 5 to 7. So if it is above what, we will do the biopsy. Rapid means what?
Increase in serum.
Rapid increase.
Rapid
we don't know what is rapid.
The baseline.
It's a judgment of the clinician or some guideline is there. Okay, this much fast it goes, I have to do biopsy. Or each clinician will have his own decision.
No, sir. Cutoffs. It is based on some guidelines, sir.
Okay. What are the other indications?
So when do you do biopsy?
Other indications for biopsy in a diabetic with kidney disease. One you told rapid progression, but you have to see the speed. Then
absence of retinopathy.
That you told. Then
proteinuria, presence of proteinuria.
Diabetic kidney disease will have proteinuria. How to decide this fellow needs or that fellow doesn't need?
Any other symptoms along with proteinuria you want to do? Do you think any
how to decide this person with proteinuria is require biopsy or this person does not require?
Presence of a nephrotic range proteinuria.
Nephrotic range.
Yes.
But diabetes also is a cause of nephrotic syndrome.
Any other symptoms apart from
How to decide now?
Yeah,
Confusing now.
any symptoms or other
You say diabetes is the commonest cause of nephrotic syndrome, and then you say nephrotic proteinuria, we have to do biopsy.
any other symptoms presentation along
Any systemic presentations
like
skin rash, if any associated infection, if associated
okay, if there are atypical features, autoimmune features are there.
autoimmune
Okay.
features, if we suspect any malignancy or
How to suspect?
so based upon we have B symptoms clinically.
Malignancy. Why you are thinking of malignancy in the kidney? Huh?
No, sir.
you're suspecting the non
So leave away the malignancy. You are okay. You are correct. Systemic autoimmune features, if they are there, we will do it. Then, so absence of retinopathy, rapid progression. You have to decide what is rapid. Nephrotic proteinuria. You have to decide. You are correct. We do it, but at what point? In which patient? And systemic features. What else?
Presence of any urine cast, hematuria, urine cast.
Hematuria can be there, no, in diabetic kidney disease. 20% of them will have.
Sir.
You are doing biopsies for diabetics with kidney disease.
Yes, yes, sir.
You have seen in your 2 or 3 years.
Sir.
You would have seen so many. And so, how did you decide in those people to do the biopsy?
Generally, we do if any atypical presentations, sir. Like presence, absence of retinopathy, rapid increase in creatinine, systemic features.
That rapid increase, how did you decide this fellow is rapid?
When comparing with the baseline creatinine, if it is increasing to more than 30%, I would like to consider.
Okay, so if it is 1 creatinine, if it becomes 1.3, you will biopsy. Or 2 becomes 2.6, you will biopsy. Is it correct? Like he is initially he is 0.8. If it becomes 1.1, we will biopsy.
No, sir.
No. Then anyway, you thoroughly read it up because diabetes is one of the commonest. Almost 60-70% of our practice is diabetes.
Sir.
So when to biopsy? The easiest way is to biopsy everybody. That way you are not wrong at all. But that we don't do, no?
No, yes.
Okay. Now this person, you have biopsied. What is the syndrome you told? What is the syndrome? Acute and chronic?
Likely progressive CKD, sir. Diabetic kidney disease. Yes, sir.
CKD is progressive disease only. Why we will biopsy this progressive CKD?
I want to, sir, non-diabetic kidney disease.
Okay, you want to rule out a treatable non-diabetic kidney disease.
Yes, sir.
You have to be. It should be treatable. Otherwise, why to biopsy?
Yes, sir.
So what is the disease you are thinking of when you are biopsying?
Sir, as he is using ART for past 15 years, I would like to consider drug toxicity in this patient. And HIV per se, even high
This
diseases
is
are
the presentation of a drug toxicity. Drug toxicity is a tubular or tubular.
Yes, sir. Generally, it presents with Fanconi syndrome, with the tenofovir, sir, and other drugs like Indanavir, Astanavir, they present with stone disorders and
tubular.
Yes, sir.
So this is not the presentation of a classical drug toxicity. So it is a, what is the presentation then?
So I would like to look the HIV related disorders, sir.
Like?
I will consider Heivic glomerular disorders, podocytopathy, associated IgA nephropathy, membranous, immune complex disorders, tubal disorders.
Okay. Of these, which one?
Proteinuria. Membranous, I will keep my possibilities, sir.
Here, membranous.
Yes, sir. Hyvan is generally not seen in Indian population. It is associated with APOL1 genes. It is more commonly seen in African patients, and it is seen in AIDS patients, not per se in HIV control.
Santosh, sir, please.
What are the ways in which HIV affects the kidney?
HIV virus directly can affect the kidney in some of the proteins like VP or VPF. It can directly involve the glomerulus, and the endothelium gets involved and causes disease. Associated with other co-infection with hepatitis B, C, opportunistic infections can cause the diseases. Associated with the drugs, especially tenofovir is prone for Fanconi syndrome and tenofovir nephropathy with
Go on. Other ways. What's Hyvan or Hivan?
Yes, sir. We can see many, almost all the disorders in HIV, especially this Hyvan is seen in AIDS-related disease in early stage when CD4 counts are low. Glomerular, it is classical FSGS associated with Hyvan.
It is what?
Collapsing FSGS, sir.
Okay.
We also see, sir.
Presentation.
Manifestations: proteinuria, proteinuria. We may see hypertension in few patients.
Hypertension not very common. Proteinuria, yes. Hyperalbuminemia, and rapidly rising creatinine. Okay, what else? What are the way apart from Hyvan? What are the kidney and drugs?
Hyvic, we also see which includes immunocomplex disorders, MPGN, membranous. We see IgA nephropathy. We see C3GN. We also see this tubulointerstitial disorders associated with HIV.
Okay, which is the worst HIV-associated kidney disease?
Sorry, sir.
Which is the worst HIV-associated kidney disease? Worst prognosis.
Hyvan, sir. Collapsing FSGS.
No, one worse than that also is there. HIV-associated TMA is there. It's even worse.
Sorry, yes, sir. TMA is also sir.
This doesn't respond to anything. This patient is diabetic, and you said he's on OHAs. Which are the OHAs that are safe in kidney disease?
Sir, we can give GLP. Sir, metformin is sorry, sir. We can give sulfonylureas like glibenclamide. Sorry, glycazide. We can give GLP-1 analogs. Linagliptin. We can give DPP-4 like dulaglutide, semaglutide, and SGLT2. We can give up to EGFR 30, and in insulin we can give.
Okay, that's a good answer. You said Yeah. So, Sir was asking about my hematuria in diabetic kidney disease. Comment about hematuria and diabetic kidney disease.
Actually, hematuria, microscopic hematuria can be seen in.
Go on, complete your sentence.
Yeah.
No, sir.
Sorry.
Infections can cause hematuria. Yes, subclinical infections in these patients, if uncontrolled sugars, probably they might have some baseline hematuria in these patients.
So, but what hematuria will make you think it is a non-diabetic glomerular disease?
More than 3 to 5 RBC per field, I would like to.
No. Microscopic hematuria, Sir said 20. There are occasional reports. There's at least one paper which says up to 40, 50, 60% may also have. Very rarely, but 20 is a common answer.
Okay.
But what hematuria? Macroscopic hematuria is not. Okay, macroscopic hematuria, you must think of some other condition.
Okay.
Yeah. That's all from me.
Then.
Thank you. Thank you.
Thank you.
Thank you, sir. Thank you. Time is.
Yes.
Pathology.
Yes.
I maybe now.
Yeah, thank you so much, Dr. Santosh and Dr. Ravindra Prabhu. Yeah, it was a great day and it is a long day. I'm sure every one of us have learned and hope you have also enjoyed being in your place. So we move on to the last session of today's program, that is a pathology session. We try to thank you for giving the pathology slides, 4 slides from Dr. Santosh, 4 slides from Dr. Ravindra Prabhu. So we will project. The students have already seen. Only what I would like to request you is please take 8 minutes per candidate because I think you are also tired sitting in the same place. We'll wind up by 6:30. It is around 6:20, 6:15. 8 to 10 minutes per candidate for discussion of a slide. Is that okay?
Okay.
5 minutes.
Yeah, actually, the slides they just write down the answer.
Yeah, they have written already.
So much,
Only thing is you need to just discuss it. That's all. Just about 5 to 8 minutes per candidate, and we wind up the day 1 program.
Okay, sure.
Okay, right. Thank you so much. So, can we start the pathology session?
Rahul, can you project the slides, please?
One music there. You are the first person. Please. Second slide. Rahul, second slide थोड़ा ये slideshow mode में रखना. You are able to see Dr. Santosh and Dr. Ravindra Prabhu. I hope you are able to see.
Yes.
Yes, we are seeing that.
Yes.
So each candidate has seen how many slides?
Only one.
Only one slide. Huh? Only one slide. 8 students, 8 slides.
Okay.
Good evening, sir. 45-year-old male with edema, with 8 grams proteinuria and albumin 2.1. That is probably adult onset nephrotic syndrome with a creatinine of 4 milligrams per day. With bland urine sediment, that is the description of this patient. This is the kidney biopsy with patch staining.
Okay.
With a single glomerulus in the center.
You already must have written, no? So read what you've written.
There is one glomerulizer, one with segmental sclerosis, collapsing glomerulopathy.
Okay, right. There are some white huge balloons at 12 o'clock, 2 o'clock, 3 o'clock, 5 o'clock, 7 o'clock positions. What are those?
Sir, those are foams, sir.
Very good.
Foams,
Two possible etiologies for the diagnosis?
Sir, one is classical is HIV, sir, HIV associated nephropathy. And the other can be these drugs, any drugs like heroin or pamidronate, drug induced, and usually secondary FSGS.
Okay. Thank you. No, you're right. Thank you.
Next slide. Can you know? What is next slide? Doctor just asked.
Mr. Rahul, can you change the slide? Go to number 2.
Third slide. Yeah.
Yes. Good evening, sir. So I've been given a histopathology slide of a 54-year-old man with hypertension, mild edema, proteinuria 2 gram, creatinine 4, and RBC numerous. So this is a PA stained histopathology section in showing one glomerulus, which is showing lobular accentuation. And then endocapillary and mesangial hypercellularity. So probably it's a membranoproliferative glomerulonephritis.
That much is correct. Anything more you want to add?
Yes.
In the 10 o'clock, 11 o'clock, middle of above the center,
So there are
1
some,
o'clock, 3 o'clock.
There are some acellular.
Where are those located? Where are those big rocks located? Where are they located?
In the vessels.
Yeah, okay. So what is that in the capillary? So what are those?
Probably cryoglobulinemic deposits.
Okay, very good. Okay. Next question. What investigations you want to send for?
So investigations, I would send for a complement analysis, complement level C3, C4, and serum cryoglobulins, and viral markers. I will send HIV, HB, CGHC.
Good answer. Thank you. Thank you.
Good afternoon, sir. Can you please go to the next slide, slide number 3? Okay, so my question was a 45-year-old man with edema and a proteinuria of 8 gram with albumin of 2.1 with urine showing numerous RBCs per high power field. So this is a light microscopy H&E stain, and it is showing a single glomeruli with multiple fragmented RBCs seen in the capillary lumen. Most probably a TMA, thrombotic microangiopathic picture. The other
so this is a little tough question. So your answers. Just look at the capillary walls. Do they look normal?
Some mild thickening is there in
Not mild. It's very thick, isn't it? It's quite thick, right? And most of it is quite thick. So when the capillary walls are thick, what is the diagnosis?
Mesangial.
It's not a complex question. Yeah, membranous. So the answer is it's a membranous nephropathy, but you've also got a lot of RBCs in the capillary loops. When do you get membranous? When do you get RBCs in the capillary loops? With a membranous nephropathy.
Sir, if it's a secondary membranous, like.
No. That's the second part of the question. What investigation should you send for? This actually is a picture of a renal vein thrombosis with RBC congestion and fragmented RBCs in the capillary. It's a very tough question. It's not your fault, but it's a very unusual thing. So if you see RBCs or if you see neutrophils in a membranous, you must think of RVT. It's a tough question. Thank you.
Mr. Rahul, will you please change the slide to slide number 4?
Good afternoon, sir.
The slide has not changed yet. Just change the slide, please.
Yeah, slide has been changed. Shall I? Yeah, 23-year-old lady presented with edema, hypertension, proteinuria 2 gram, serum albumin 3.1, creatinine 2.3. Urine may they haven't mentioned this. They have mentioned RBCs. So this is light microscopy, sir. HNA stain, a single glomeruli. Here we can see, sir, mesangial expansion, acellular mesangial expansion is there, sir.
So your answer is mesangial, acellular mesangial expansion, is it?
Yes, sir. Yes, sir.
Capillary loops, are they open or closed?
So capillary loops, most of at the 12 o'clock, 3 o'clock position, they are closed. 9 o'clock around the capillary loops.
Okay. Okay. Some of them are closed. So and there are these huge, thick things. No, what do you think they are?
Sir, mostly my disease would be like amyloidosis.
So see, it's a 23-year-old lady with hypertension, 2 gram proteinuria, renal failure, RBCs numerous. So amyloid, you don't get numerous RBCs in the urine, right?
Or MIDDs.
Just think of much simpler things. No, okay, this something at the 5:30 position, something at the 4 o'clock position, something at 2:30 position. What are those things?
And sir, there is even some mesangial hyper, like if 4 mesangial cells.
No, just answer this one question. What do those things look like at 5:30, 4 o'clock, 2:30 positions? What do those things look like? Actually, I was trying to look for classical finding. They look like things that you play as to blow bubbles as children. No, they look like wire loops, right? Imagine they look like wire loops. Yeah, so they're subendothelial deposits are causing wire loops. So what is the diagnosis now?
Now class 2 lupus nephritis.
See, when you have subendothelial deposits, it is not class 2, no? It has to be at least 3.
Proliferation, sir, so there is no proliferative.
See, if you have a capillary loop obliterated, it is proliferated, right? It is proliferative, right? Okay, so anytime even one glomerulus has one capillary loop obliterated, or you have one subendothelial deposit, it becomes already a proliferative gene. So don't say class 2 anymore.
Okay, sir.
Okay, so it doesn't mean not any one is enough. And the investigations you should send for?
Pardon, sir?
What investigations you want to do?
ANA and all this C3, C4, DST and anti-Smith.
Okay. So don't forget the wire loop picture and the fact that even one glomerulus obstructed with the capillary loop obstruction with something in the lumen makes it proliferative. And if the subendothelial deposit, also it is proliferative. So don't say class 2 for this.
Yes, sir.
Okay. Okay. Thank you.
Thank you, sir.
So the next slides are all yours, sir.
Okay.
Good evening, sir.
Good evening.
So this is a 50-year-old man with pedal edema of 3 months duration. His serum albumin is 1.5 with serum creatinine of 1. So the slide shows a single glomerulus with a few tubules. The glomerular capillary basement membrane is thickened diffusely, and there is no collapse, no mesangial hypercellularity. The tubule appears normal. So this looks like probable membranous nephropathy. Underlying etiology, I would like to further work up.
So how do you say it is the capillary loop, this basement membrane is thickened? How do you diagnose that?
So we have to compare with the nearby tubular basement membranes.
Yes, tubular basement membrane. And how do you differentiate secondary from primary membranes?
So in the secondary membranous glomerulopathy, there would be mesangial expansion usually. So that would point us towards a probable secondary etiology. And electron microscopy would also show deposits.
Immunofluorescence, any help?
Immunofluorescence would show, in case the secondary membranous is because of underlying lupus, then full house immune deposits would be there.
Yes. And in the blood?
Blood, I would like to work him up. Serum plateau levels, ANA, C3, C4 levels. And considering his age, if all of this comes negative, then malignancy will quite
Okay. Okay, good.
Thanks.
Thank you.
Please change the slide. So I have a 20-year-old woman with pedal edema for the past 6 months. CUV is showing 3+ albumin. Serum albumin is 2.3 and creatinine is 2.1. So here we can see a single glomerulus with focal segmental sclerosis, which is tip variant.
Okay. So we,
And there are foam cells also seen in the
so how many glomeruli do you need to rule out FSGS?
Yes, sir. At least 20 glomeruli are required to diagnose FSGS.
Okay. And are there any side findings which would point to towards like you don't see the sclerosis, but some other features which would point, which would favor this?
Without
Something in the tubules or something?
diffuse podocyte effacement is seen.
But that's a EM, no?
But
It's an
is an
EM.
EM finding.
Where is this
Mesangial-
commonly seen? Where is this commonly seen? Which glomeruli it is seen commonly?
Juxtamedullary glomeruli
Medullary,
are more
yes,
common.
yes. So any telltale signs are there which could point that, okay, this patient could have, you may not see the sclerosis, but the patient could have FSGS. So tubular atrophy.
Tubular.
How do you treat this kind of condition?
Sir, with FSGS can be treated with oral steroids, 2 milligrams per kg per day, or alternate day regime can be given for a minimum of 8 to 12.
So you have to give it for a longer period of time to say that it is steroid non-responsive.
Yes.
As compared to the MCD,
Yes.
this may need to be treated for a longer period of time. Which are the other variants you see?
So there are cellular variant, perihilar variant, non FSGS NOS, and collapsing variant.
Diffuse mesangial sclerosis.
Yes.
Okay. Thank you.
Sir, slide number 9, sir.
No, the slide has to, okay.
9 number, sir.
Yes, this is the slide. Please describe. This is not your slide.
No, sir.
You can ask for yourself, no?
Slide number 9, sir.
Rahul bolo.
Rahul.
Next slide.
Next one. Next one.
But you don't start by Pache.
This one. 25-year-old female. She presented with the history of pedal edema and oliguria. The complete urine examination is showing active sediment. Creatinine is 4.8 milligram per dl. So this is a light microscopy high power field. The stain is a silver methenamine stain, and it is showing proliferation of the endocapillary as well as the mesengium with circumferential cellular crescent.
Okay, it's a crescent. Can we say it is a crescentic glomerulonephritis?
Sir, on single glomerulus, it is very difficult to comment, sir, whether it is a crescentic glomerulus.
So when can we say it is?
Sir, if out of total glomeruli, if more than 50% glomerular are showing crescent, then it will be called as a crescentic glomerulonephritis.
Okay. So could this be anti-GBM disease?
One of the possibilities anti-GBM disease, sir.
Glomerulus, you told something is there, no?
Endocapillary hypercellularity with
So
the circumferential crescent.
So if I am given anti-GBM versus ANCA vasculitis versus immune complex with crescents, how to differentiate?
Sir, in anti-GBM, sir, crescents will be monomorphic, sir. That is, they could be either, all the crescents will be either cellular or fibrocellular or fibrous. On the other hand, in ANCA vasculitis, there will be polymorphic. Some crescent will be either cellular, some of them will be fibrocellular, or some of them will be fibrous.
And immune complex?
Immune complex, sir, if it is a infection-related glomerulonephritis, then there will be monomorphic crescents only, sir.
So immune complex versus anti-GBM, how to differentiate?
Sir, depending upon the immunofluorescence, sir. If the
Light
immunofluorescence
microscopy?
Yes, sir. On a light microscopy and anti-GBM, there is a nearly involvement of all the glomeruli. While in immune complex mediated, there will be not all the glomeruli will be completely involved, sir.
If they are all involved?
If they are all
in the
involved,
glomerular tuft, is it possible to differentiate?
Pardon, sir?
Seeing the glomerular tuft, is it possible to differentiate between these three?
Yes, sir. Means in anti-GBM disease, sir, the complete glomerular tuft will be involved. That is, global glomerular involvement will be there. Whereas in immune complex, it will not be there, sir.
Okay. I think you should read it up. Then what about the other causes of crescentic?
Sir, considering her age,
I'm just asking you the causes of crescentic, apart from the three already named.
sir, crescentic, sir, we can classify as type 1, type 2, or type 3, sir. Type 1 will be the anti-GBM, type 2 will be the immune complex mediated, in which there could be lupus nephritis or infection related or IgA crescentic, and type 3 will be ANCA associated crescentic GM, sir.
Any drugs can cause crescentic GM?
Sir,
drugs.
Is sir, cocaine, if adulterated with
any anti-tubercular drugs? Okay, thank you.
Thank you.
Yes.
Rahul to show the slide number 8.
Mr. Rahul, slide number 8. Clinical scenario, 60 years old male, presented with oliguria, 10 days, shortness of breath, serum albumin 3 grams, serum creatinine 7.2. This is a high power view, PAS strain, showing tubules and vessels, no glomeruli in the field, with a large fractured cast in the tubule is seen. Small cast is also seen in with associated with interstitial edema and lymphocyte and inflammation. So it is myeloma cast nephropathy.
So what are the causes of renal failure in myeloma?
Most common is myeloma cast nephropathy. It is dependent on the cast burden, hypercalcemia, AKI.
Hypercalcemia, cast nephropathy, then
ATN.
No, causes, not the pathology there. Hypercalcemia, cast nephropathy, then two more.
Amyloidosis in rarely less than 5% it is seen. Interstitial
Commonest causes. Cast nephropathy, hypercalcemia, then I think no. NSAIDs and pre-renal. NSAID and pre-renal. 4 causes: pre-renal, NSAID, cast nephropathy, and hypercalcemia. What are the glomerular changes you can see in myeloma? Glomerular diseases or patterns, glomerular patterns, I should say, in the which could be seen in myeloma. One you told already, amyloid. Anything else?
No, sir. I'm not.
You don't know. Okay, thank you.
Thanks.
Thank you so much, Dr. Santosh and Dr. Ravindra Prabhu, for staying for such a long time. And thank you so much for teaching the students. I'm sure students must have learned quite a lot from all of us. And I mean, examiners also. I hope you have enjoyed. Would you like to give a feedback to the students? Yeah, both Dr. Santosh and Dr. Ravindra Prabhu. Your feedback matters because
so first of all,
yeah.
First of all, thank you for calling us, madam, because it was.
It's indeed our pleasure, sir. You have really
yes.
accepted. It's our pleasure.
Yeah, and of course, it's very easy for us to sit on this side and give the questions. The students are the ones who have to really take it positively, I think. And I hope we were not too strict with them. But of course, again, in a mock exam, you can be strict, I think. Yes. But overall, I think they have done well. They are presenting quite well. Okay. And the history taking and all was quite thorough. Most of the students, what I realized was it was quite thorough. Once you take a good history, I think it depends only on what you have read before. So the more you have read and the more you remember, that is the one which is going to take you. One advice I can give is, I think they should do a case-based reading rather than from the first to the last page reading of the textbook. They can take up a case and read about it. And as they take at least one case per day reading, that would, at the time of exam, I think they should be thorough with all the common things which they are seeing. Yes. And as examiners, we ask only what is, what can I say, what we see day to day. So students should not expect that we are going to ask something rare and expecting some rare disorders from them. So that's it from my side. I think, again, I thank you for calling and this opportunity.
Thank you so much. I think, yeah, the students will take this view that common things first and rare things to be later. So it's a very good on your part, students, that you have done well today. So the examiners are indeed happy that you have presented the cases very well. That's a good go for all of us. Over to Dr. Santosh.
I don't have much more to add compared to my senior external examiner. Sir has encapsulated the gist of everything that we would have wanted to say. Congratulations to the students for having the guts to come and do it and present before the examiners, and they've done reasonably well considering the exams are still a while away.
Yes.
And they can build on what they have already done. All the best to them, and it was wonderful to be here, and thank you again, ma'am, for calling, and wonderful to be co-examiner with sir again.
Thank you.
It's been our third time, I think, together.
Thank you so much. Yeah, it's in fact on happy note, we are here to share that 100 people have joined online for today's session. So your examination pattern and the students presenting has been viewed by 100 people across probably the state or probably other states as well. So it's a very good thing, good initiative from Hyderabad Nephrology Forum as well, that we have started online events from this year on, so that it would have a wider reach and used by many people as well. So thank you sir, thank you so much, Dr. Ravindra Prabhu and Dr. Santosh, thank you so much. So see you again, probably in the examinations to come in the future.
Yeah.
Thank you so much. Thank you very much.
Thank you.
Bye.
Bye. Take care. Bye. Have a nice weekend.
Yeah,
Thank you, sir.
Thank you so much. Thank you.
Thank
So
you,
may I
ma'am.
ask, yes, thank you, sir. Thank you. May I ask the interns to give the feedback? Madam, what will happen? Bhushan sir and Kiran ma'am.
By the time I stand up,
I don't need to call you. No. You're always a microphone.
The students are doing well actually. Their level of confidence and the way they are answering, their ability to answer, I think they have more knowledge than they express actually. I think they are getting confused how much knowledge they have put in. There's some probably they're finding it difficult to push it out by expressing it actually. They are the peak stages, the peak hours of their preparation now before the examination. I think I could find that actually they're thoroughly bubbling with a lot of knowledge, and now the only thing is that they should be able to express it also very clearly and properly. So that's very important in the examination, and you don't have to demonstrate the entire knowledge also. But listen to the examiner and just to see what is the question and what the examiner wants you to answer. That also is very important. Then you answer, because nobody wants to trouble you in the examination. You'll be troubling yourself unnecessarily, and which is not really required in the examination. It's definitely the last button exam of your life. If the DNB is also there, or DNB is also there for the students like you. So, simple examination always in the exam, but one thing is that you read more again and again. As Dr. Ravindra Prabhu clearly said, read the case-based studies rather than the entire textbook from page 1 to the last page. Well and good. And you all have done very well. And I also thank the Nephrology Forum for giving this opportunity to be the examiner. Thank you.
Thank you, sir. Thank you for making it brief. Very unusual from you. We generally make it very long one. So you make it very brief. So thank you so much. So I request the other examiner, Kiran is in line. Madam.
Thank you, everybody. Thank you for the opportunity. Hyderabad Nephrology Forum. Yeah. But this was an opportunity to learn. I was learning since morning. Thank you very much. Everybody has presented well. Congratulations. Confidently, you people have presented and answered well also. Only thing is, don't get unnecessarily confused. You are doing well. And think of simple things first, then go for a very rare differential diagnosis later. You people come into the differential diagnosis in the first itself, some of the people, that is not needed. Answer and learn simply, simple questions, simple answers, that will be good.
Thank you, Kiran. Thank you. That was nice and sweet of you. Madam,
I think whatever Dr. Prabhu and Dr. question, Kiran said, I will just synthesize. That's what. We have a lot of information. Please don't tell everything to the examiner. And then they will catch it. Remember, the examiner knows one thing more than what you know. If you have told everything, then you have nothing left to tell them. So start slowly, tell properly that always common things are much more common. Always common summary. What is your diagnosis? What are your supporting points for the diagnosis? That's what you do, but you will not do that. I think all of you did that.
Great, madam, excellent, thank you. Any of the students want to comment about the pattern of examination, about the tomorrow? Okay, we expect all of you to be here tomorrow as well, so that there is another tension-free, anxiety-free learning for you tomorrow, because you're done with your job today, so you're more comfortable listening to the examiners tomorrow. Yes, so I mean, so be here, let's all learn, and that's it. So I wind up for today's program. So unless you want to say something, you can wind up. So thank you, sir. Thank you, Dr. Santosh. Thank you, Dr. Ravindra Prabhu. Good evening and good night to you. Thank you so much for this.
Good evening. Have a very blessed weekend.
Sure. Thank you.
Manjusha will send you cash in.
Bye, sir.
That was not digitally transferred, so they will send you.
Coffee too. Coffee too.
Coffee and cash in to all of you.
Yes.
Both
Yes.
of you.
Yes. Thank you. Thank you so much. Thank you.
Okay. Bye, bye, sir. Bye, ma'am.
Thank you. Thank you, everyone.
Thank you, thank
And
you.
be here today. Tomorrow, right? Yeah. You are.
Thank you, sir, Dr. Santosh and Dr. Ravindra Prabhu for your, patience, sitting there from the morning and then, assisting our candidates and helping them with learning all these things. In fact, I can say it was a new experience for me. I have learned a lot of things in organizing, the background work. And I was not concentrating on the questions and answer, but I have, learned to do and love it. Probably next time I can concentrate more on, the how to, be an examiner or something like that. So I also enjoyed this, and I wish all of you have learned out of this, and probably you can give feedback after the program is over, so that we can improve the coming year. Thank you. And one thing is we have made it online this time, and we were little doubtful whether it will be successful or not, but it went on smooth, and 100 people have participated online. I think tomorrow there will be more participation, tomorrow being the Sunday. So we can use this experience in improvising ourselves and providing a platform for the sharing of knowledge. Thank you very much, and we will close the session, and tomorrow we'll all meet together. Thank you.
Thank you, sir. Thank you.
Thank you, Rahul and your team. I think it was, thank you. It was well organized, Amma. It went on very well. I think tomorrow also we'll follow the same pattern. Tomorrow night.